those adverse events. So we'll spend a few slides and minutes talking about genetics, then I will try to revisit those scenarios again and try to answer those raised questions later on. So the estimated IBD prevalence among family members, if we take UC as an example, ranges between 7.9% to 12% using a 0.3% as a reference in general population with high concordance of disease type. Although those observations may be explained by shared environmental factors among the family members, but further proof of genetic involvement has come from twin studies that showed higher concordance rates of IBD, especially Crohn's disease, among monozygotic twins. If we just have a historical review of genetics in IBD, so we remember that in 1875, Sir Samuel Wilkes described the first case of vasculitis. It was not later until epidemiological twin studies started in 1980s. Then we had the international 13-year human genome project that was started in 1990 and completed in 2003, after which we started to have a lot of genetic association studies. We had a lot of genome-wide association studies. The first one in UC was in the 2000s, and then we started to have more described IBD-associated loci, reaching more than 200 in the latest years. If we have just a quick look into what we know about pathogenesis of IBD, I try usually if I was asked about the pathogenesis of IBD by our colleagues or by patients, to explain to them that this is multifactorial. It's not a single factor that can explain the disease. We believe genetics plays a role. We believe environmental triggers like smoking, diet, medications, exposure, and the interaction between genetics and environment are the leading factor to a possible dysregulated immune response that would eventually lead to the onset of inflammatory bowel disease. So there is multiple interaction levels between genetics and environment, but till maybe recently we could not have a better understanding why would a patient with family history come with IBD while the other will not. We might try to highlight some of those gaps and the new tools and discoveries that help bridging those knowledge gaps. If we look deeper into IBD and genetics, on the left side of the screen, sorry, the pointer. So on your left side of the screen, you will see that we know that there is an overlap between ulcerative colitis and Crohn's disease. And this is maybe more clear if you look into patients with very early onset of IBD who could follow a Mendelian, pattern of inheritance. But this is not the case with all, idiopathic IBD that we see, especially in adult population. On the right side as well, you're going to see the coding variants of IBD, what's called the functional genetics that helped to mechanistically link risk genes and genetic variants with cellular and molecular functions. This helped us to understand the disease and helped us to develop even a new target therapies. An example of that is JAK-STAT pathway and interleukin 23. Will not go over this complex slide into details. This just shows you the complexity and the interaction between the IBD genes and their implication in key biological functions that are shown here in gray circles. Those are controlled by interconnected molecular pathways that are colored in the colored rectangles. So you can see the impact of the genetic on the cytokine level that would lead eventually to an immune dysregulation that we believe is the common pathway for the final phenotype of the disease. One of the largest association studies is a recent one that was published in Lancet 2016. It was conducted among 49 centers in 16 countries in Europe and North America and Australia. They looked into around 35,000 IBD patients, 20,000 of Crohn's and 15,000 of ulcerative colitis. And they applied and tried to link a phenotypic to genotypic association. So they used for phenotypic classification, the known Montreal classification for IBD for both in Crohn's and UC in terms of behavior, location, and age onset. And they tried as well to test the genotype-phenotype association across more than 150,000 genetic variants using an immune chip array. The take-home message from this study, or the major findings were the following. First, they highlighted that the previously proposed relation between NOT2, which was the first maybe genetic mutation that was described with CARD15, And they kind of like propose that relation between NOT2 and the stenotic disease is not true. Rather, it is driven by NOT2 association with young age at diagnosis and early location. Second, and this is interesting, that what we see actually in clinical practice, when you scope a patient with isolated colonic Crohn's disease or an L2 Monte Carlo classification, that they found that colonic disease location, or L2 for Crohn's disease, was better predicted by the HLA susceptibility alleles for ulcerative colitis rather than those for Crohn's disease, as if, colonic Crohn's disease is a subtype of ulcerative colitis rather than Crohn's. And they concluded that colonic Crohn's disease is genetically distinct from ileal Crohn's disease and proposed a new nomenclature for IBD. And this is actually among the largest, genetic phenotypic association studies to date. Now, we started lately to hear a lot about epigenetics. So we know epi means above or on or around. So what does epigenetics mean, and how can we utilize that in our clinical practice, and how much would that add to our knowledge in terms of the role of genetics in IBD? Let me take you one step back into medical school and the structure of the human genome. We know that the human genome is composed of, if you start at the primary structure, which is the simplest level of chromatin, that is double-stranded helical structure of DNA, up in the slide here, that are complex with histones to form nucleosomes. And then those nucleosomes consist of 8 histones proteins that are wrapped around the DNA. And those chromosomes will get into further complex structure, we call it secondary and tertiary structure, to formulate the chromosome eventually. So still, I haven't highlighted what does epigenetic mean. So on the left side of the screen, you will see our old paradigm of thinking of the role of genetics in IBD. We used to think or say that you have a genotype that predispose you to IBD, then you have the phenotype, so you have the disease. So it's not as simple as this. We know this is further complex. So now we believe that in certain patients who are predicted or predisposed to develop IBD, who have an interaction with environmental factors. And again, I said early on that this gap of knowledge that we have regarding the interaction between genetics and environmental factors could be bridged partially by the fact of epigenetics. So we believe that the epigenetics plays a role to translate those environmental triggers on certain hosts or patients who are genetically predisposed to eventually lead to that immune dysregulation and eventually have the disease. So again, just to emphasize on that fact, so the environmental triggers will work on the epigenetic modification that will lead to gene regulation and phenotype. So still, we haven't discussed what does epigenetic mean. So the identified genetic factors that we have so far account for only a modest proportion of the disease variance, for around 13% of Crohn's disease and 7.5% for ulcerative colitis. So we believe that epigenetic factors can mediate interactions between the environment and the genome, as we said. So we think that it might partially account for this hidden heritability in IBD. So you can define epigenetics as mitotically heritable changes in gene function, not explained by changes in the DNA sequence. So if you remember the initial slide I showed you about the human genome, so I'm not talking about the gene itself or the chromatin itself. This is something above. This is something around the gene. So you modify the function, the final function of the protein that you will get after the gene translation, but without altering the gene itself. So the gene expression can be altered by changes to the structure and function of the chromatin. You will start hearing a lot about those, epigenetic mechanisms. So this is just to highlight them rather than going into depth about them and their relation. You heard a lot maybe in the role of DNA methylation, for example, in colon cancer, and the histone modification, RNA interference, and the positioning of nucleosome. We'll take maybe one example of those later on. So the gene expression can be altered by changes to the structure and function without altering the chromatin itself. So if you just have a quick review and think about different cells in your body. You have the nerve cells, you have the myocardium cells, and you have the epithelial cells of the gut. They all have the same genetic code, yet they have or serve different functions. We think that this is mediated through the epigenetics. So think of epigenetics as a switch, button that allows to express or translate gene and suppress another one. One example of epigenetics is what is shown here. It shows a little bit maybe complex description, but to highlight it, so in the upper part of this slide, you can see the heterochromatin. So we believe that the chromatin has two different chains, the hetero one and the euchromatin part. The heterochromatin is the condensed part where you cannot translate or have a transcription of that gene into a functioning protein. Well, in an euchromatin form, then you will be able, or the RNA polymerase that is responsible to translate or transcribe the gene into a functioning protein will be functioning. And so this structure of the chromatin will be altered according to the epigenetics. For example, here is the DNA methylation. So what does epigenetics do in IBD, and what have we understood so far? So we believe that DNA methylation, for example, as one of the epigenetic mechanisms, has been proposed and involved in dysregulation of bacterial and immune responses in IBD. The global hypermethylation has been associated with IBD-associated colorectal cancer, comparison to sporadic colorectal cancers. If you switch to a different mechanism like a histone modification, then we think that it might be an indicator for microbiota-host interaction. And actually, one of those had been a potential target for new drugs. Expression of non-coding RNAs, for example, the microRNA, and you will hear a lot of talks about that and studies, had been found to be a key regulator of intestinal immunity, especially innate and adaptive. So back to the scenarios as I promised. So a 24-year-old lady with ulcerative colitis in remission comes to your clinic prior to her conception to discuss the chances of her kids having IBD. So we believe that voluntary childlessness is more common in women with IBD. A recent survey conducted in Europe showed that almost 75% of women are afraid of passing disease to their descendants or offspring. Therefore, it's important to provide such consultation or counseling about the accurate risk estimates to prospective parents. So you can use this, a graph or bar chart to help, addressing the risk. Although if you use the folds, then it might sound larger, but the absolute risk is still low. We know that at least the estimated prevalence of IBD in high countries with high risk of IBD reaches to 3 per 1,000. So this risk increases according to the number of relatives with inflammatory bowel disease. So if you have more than 2 first-degree relatives, then the risk might reach up to 10%, especially in Crohn's. But in monozygotic twin studies, as we mentioned earlier on, in Crohn's disease, it might reach up to 50% concordance. To have just a quick numbers for you to discuss with your patient in the clinic, we know that from cohort studies, it highlights how the genetic risk factors for Crohn's disease is higher than that of UC. The absolute risk of an offspring developing Crohn's with maternal Crohn's disease is around 2.7%, while the risk is lower in the range of 1.6%. But having both parents affected by IBD will increase the risk up to 30%. Second scenario was about your fellow asking you about that 19-year-old gentleman who was diagnosed to have Crohn's disease when he was 4 years old. So he was wondering about the fact if there is really a monogenic IBD, is there a syndrome? How can I tell? I'll take you quickly over monogenic IBD and what we mean by that. So IBD and IBD-like diseases that are caused by monogenic variants with Mendelian inheritance patterns have been described as monogenic. So these represent very small number of IBD patients that we see in adult population. Maybe a pediatrician would see more, and we will present one quick study regarding that. So IBD, as we know it, is a polygenic one. So there is no single gene mutation that could explain it. But yet, we don't want to overlook those subpopulation of patients who might have a single gene explaining the disease. So what are the factors that I keep in my mind in my clinic seeing a new patient with IBD, similar to the patient presented in the scenario, to distinguish monogenic from polygenic IBD? Age of onset is important, and we'll come about the cutoff age. Family history, definitely. Atypical endoscopic findings, severity, atypical infection history is important, and definitely extraintestinal comorbidities. Skipping this just for sake of time, and I will move to present one quick, interesting systematic review that was recently published last year. This is a nice systematic review that looked into all the literature about that described and presented monogenic IBDs from 2000 until 2020. They included around 300 eligible articles, and they covered around 68 of around 75 genes known to be associated with monogenic IBD. So the common genes, and maybe some of you are aware of that, interleukin-10 receptor A and B were among those, and LRBA, we have maybe 2 or 3 patients in our clinics who we have LRBA and has associated IBD-like. So this is a game changer. This is a disease diagnosis changing a game. So the idea is here, when should I suspect monogenic IBD? What is the cutoff age beyond which or before which I should start thinking of monogenic IBD? So before 6 years of age, around 63% of patients with monogenic IBD were suspected if they had a very early onset. So below 6 years of age is defining what we call a VEO IBD, or very early onset IBD. Only 10 to 11% could present to you with a new diagnosis of IBD in the adulthood. And maybe in our country, we treat patients who are diagnosed at age of 14, so maybe we are exposed to more patients with possible monogenic IBD. So in this systematic review, they reviewed 750 patients, so the absolute risk is low, yet it is there. Keep in mind that the highest extraintestinal comorbidity was atypical infection in up to 44%, dermatological abnormality were in 38%, and other or coexisting autoimmunity was in 21%. They were treated with either bowel surgery, biologics, or stem cell transplant, which could be curative for certain patients, like patients with interleukin-10 deficiency. For sake of time, we'll skip on this, but keep in mind as well that those patients with monogenic IBD could have associated malignancy. The highest one is lymphoma. Those patients who were described in this systematic review were treated differently. Around 27% underwent bowel surgery. A third of them, they were treated with biologics, and around a good number, 23%, which is around 170 patients, were treated with stem cell transplant, and 124 out of them get better. So identifying them and diagnosing them early on, doing a proper study early on, consulting your genetic colleagues, and maybe offering them a curative treatment is an option. And then I will conclude with the last scenario about a patient who's coming to your clinic asking about predictors for adverse events of the medications. And just I will finish with one slide. So we know that pharmacogenetics or pharmacogenomics as well is coming, and it helps with predicting new targets for novel medications, but as well has been helping to predict adverse events of certain medications. In 5-ASA and prediction of nephrotoxicity has not been validated, so it's not being utilized clinically, yet the others has been utilized, maybe underutilized because of availability. But for example, thiopurines and the risk of myelosuppression through TBMT or NUDT15 has been utilized, or predicting of alopecia through NUDT15, or pancreatitis through the HLA-DQA1 or HLA-DRB1. Or for immunogenicity with anti-TNF through the HLA-DQA1*05. So I will conclude here. We believe that advancement in genetics and epigenetics of IBD could lead to better disease pathogenesis understanding and hopefully novel drug treatment and development. Multidisciplinary approach is needed in early onset and multifactorial IBD to integrate multiple disciplines, including genetics, GI, and immunology, to improve diagnosis and hopefully guide further curative or potentially curative treatment like stem cell transplant in certain selected patients. Pre-treatment genetics tests are useful tools that can be incorporated into clinical IBD management, yet their availability could represent a challenge. Thank you for listening.
Our next speaker is Dr. Sara Al-Ali. She is staff physician in the Digestive Disease Institute at Cleveland Clinic, Abu Dhabi, and she's clinical assistant professor at medicine at Cleveland Clinic Lerner College of Medicine, Case Western Reserve University in Cleveland, Ohio, and she will be talking about the modern monitoring of IBD.
Thank you. Good morning, everyone. Thank you very much for the introduction, and thank you very much for having me and inviting me to this wonderful conference. It's really good to be back to Riyadh. So my task today will be to give you a little bit of a brief overview on modern monitoring of IBD. I have no disclosures that are relevant for this talk. Just a brief outline. We'll try to talk first about some overall monitoring strategies, and then we'll try to go more into detail into what type of tools do we use to monitor IBD. And lastly, we'll try to talk a little bit about the future of IBD monitoring. So a little bit about monitoring strategies. What I realized, by preparing this talk is what we do in general is monitoring. All we do in clinic is really monitor, and we're monitoring so many things at the same time in our patients. We're monitoring their disease activity, we're monitoring the impact that the disease has on them, we're monitoring therapy, often doing therapeutic drug monitoring, we're monitoring complications of the disease and complications of the treatment. And so that would be a lot to cover for today. And so just a little shout out, we're gonna have a therapeutic drug monitoring talk shortly, actually in a few minutes, and a nice talk later on malignancy risk in IBD. And then the other thing to keep in mind when we're talking about monitoring in IBD is really it's adapted to different clinical scenarios, and your patients may be in different scenarios throughout their life. It could be during pregnancy, which the monitoring in pregnancy will be different than in patients that have ileal pouches, and postoperative Crohn's disease will be different in terms of monitoring, and perianal disease as well. And so again, we'll have a nice postoperative recurrence talk tomorrow by Dr. Reguero, and perianal disease later today. And so what I'll do is I'll try to focus on disease activity monitoring for this talk. And now we know that our patients have a very variable disease course, right? They're really up and down. This is the Ibsen cohort from Norway. This is specifically ulcerative colitis, but it's the same concept in Crohn's disease. But our patients, some of them do well over time, some of them go up and down in terms of disease activity, some of them are just really never down. And our job is to really try to monitor them during that time and try to flatten that curve to make them feel better as much as possible. And so it's always a struggle when you're monitoring. You have to not only monitor disease activity, which goes up and down, but at the same time realize that IBD is a progressive disease, and not just Crohn's, and this is the typical diagram that we always put for Crohn's, but ulcerative colitis as well as a progressive disease. Damage builds up over time, and so what we're trying to monitor is also monitor for complications that may develop and try to really get to them even before they develop. So how do we get there? Mucosal healing. And so we've heard a lot about mucosal healing the last few years. Mucosal healing is associated with better long-term outcomes, and this isn't ulcerative colitis, but also in Crohn's disease. So we know that if you go from the top images to the bottom, if you try to decrease or normalize, essentially remove the inflammation endoscopically, your patients will do better over time, and this is why it's important to monitor them. Just specifically, this is a meta-analysis that looked at mucosal healing specifically in ulcerative colitis. And what they did is they tried to evaluate the association between mucosal healing at the first endoscopy after they started treatment and long-term outcomes. And they found a pooled odds ratio. There was about 2,000 patients. A pooled odds ratio of 4.15 for decreasing the risk of colectomy, and then also decreased risk of relapse over time. So really, this is what we're trying to aim for. So how do we get to mucosal healing? And we all know about the CALM study, but just in a nutshell, CALM, as you know, is the first randomized controlled trial that looked at treating to target as a strategy in general in treating our patients. And remember, they had two arms. They had an arm where there was just, escalation of treatment was based on clinical management. So these were patients with moderate to severe Crohn's disease, started on adalimumab, and you were escalating treatment in the first arm based on symptoms. And in the second arm, the tight control arm, is escalating treatment based on symptoms, but also biomarkers like fecal calprotectin and CRP. And you can see there, their primary endpoint was mucosal healing at 48 weeks. And you can see that the tight control group really did better. So treating to target is probably one of the ways that we can really get to that mucosal healing target. And so a bunch of experts came together as part of the STRIDE-2 consensus, and we know this as well, but just as a bit of a reminder, these are the targets that we're really aiming for. And so there are short-term targets, intermediate targets, and more long-term targets. Of course, our first target is for the patient to feel better and then essentially back to normal, symptomatic remission. This is your short-term to intermediate target. You want your CRP to normalize. You want your fecal calprotectin as well to normalize. Of course, in children, there are different targets. Like, of course, you'd want to go back to having normal growth. And then your long-term targets after 6 months is really endoscopic healing, normalizing your quality of life, and really going back to being fully functional. Couple words, transmural healing and histologic healing we're going to talk about this in a few minutes. So some of the monitoring tools that are available to us to monitor our patients. So before we talk about this, it's just important to realize, obviously, we always need a baseline, right, to benchmark and better interpret our values. And this is why whether the patient comes to see you for the first time or whether it's at diagnosis, it's always good to have a really good baseline of what's going on clinically, biochemically, radiologically, endoscopically. And definitely, Dr. Sherara will be talking to us about diagnosis and probably a little bit of the comprehensive management that happens there. So we won't talk about this very much. So the first way that we really monitor our patients is symptoms, right? And so clinical evaluation, when we're seeing patients in clinic, there are all of these features that are going through our head, right? It's symptoms from the disease, symptoms from possible complications, symptoms from their extraintestinal manifestations, and we're trying to cover all of these symptoms. And there are some scoring systems out there, as you know, the Harvey-Bradshaw, the CDAI, that can help us in terms of standardizing this approach and being able to monitor them from an objective standpoint. We don't use them that much in clinic, definitely use them more in research. But just an important thing to keep in mind is psychosocial evaluation, which is really important, and we now have really good questionnaires to be able to identify that disability in our patients and the quality of life. And then, of course, a lot of work is being done on patient-reported outcomes that can help clinically, but definitely for research. So the big problem with symptoms, though, is that they don't tell the full story. They actually do not correlate very well with disease activity, especially in Crohn's disease. So what do? So we need, obviously, our other tools in our little suitcase, in our toolbox. So CRP, we use it every day. We all know that it's easy to obtain, it's cheap, it's quick. But as a quick reminder, it actually does predict the risk of relapse very well. It's been shown to be associated with hospitalization rates, treatment response, risk of relapse after you stop a therapy. So really helpful there. Of course, caveats, it's not specific to IBD, and they could have a high CRP for other reasons. And not all patients mount a CRP, and this is why it's important to really know your patient even before or at their baseline, essentially. Fecal calprotectin, we also use it all the time. It correlates very well with endoscopic inflammation. I put quote-unquote non-invasive. We think it's non-invasive. Our patients feel it's very invasive. It's an embarrassing thing to do, an embarrassing test to do. It's often not done whenever you ask them to do it. It's a bit of a burden on them. And so that's one of the caveats, right? It's great. It gives us a non-invasive image of what's going on, but low acceptance from patients. We also have to keep in mind there's some intra-individual variability, and the fecal calprotectin could go up and down at some point without necessarily, meaning that it is from the disease. There could be other things causing an increase in fecal calprotectin in our patients, like infections, pseudopolyps, etc. And of course, not as reliable in isolated small bowel Crohn's disease. So of course, trends are more useful than actual single values, and you wouldn't want to really take an action on one single value. What are our targets with fecal calprotectin? So in general, so this is a post-hoc analysis from Calm, and what they found was that patients that really reached that endpoint of mucosal healing, which, by the way, they defined as CDAIS less than 4 and no deep ulcers. And I'll just mention that there is no accepted definition of mucosal healing, and it really changes according to the study that you look at. But in general, it means no endoscopic inflammation. And so in Calm, essentially, a fecal calprotectin less than 250 and a CRP less than 5 are really what you needed to get. So of course, endoscopic monitoring is our gold standard, and we talked about how mucosal healing leads to better outcomes. It helps in establishing diagnosis, monitoring disease activity, and monitoring treatment response, and of course, dysplasia, which we'll talk about later on today. Capsule endoscopy, very helpful in specific cases of small bowel inflammation, and we're glad to have that tool as well. So when do we scope? We talked about scoping, but when do we actually perform endoscopy in our patients? So the ECHO guidelines tell us that for patients with ulcerative colitis, when you put them on medical therapy, you really should be evaluating mucosal healing endoscopically or by fecal calprotectin at 3 to 6 months. And when else should you be getting a scope? Well, of course, you would need to reassess if the patient is not doing well, severe relapse, or suddenly relapses, and that was unexpected, before switching therapy to document the disease. And then, of course, you could also use a sigmoidoscopy in some patients, right, with ulcerative colitis, and that could be helpful in specific scenarios. When do you scope in Crohn's disease? Very similar idea there. You need clinical and biochemical response to be determined within 12 weeks, so about 3 months, following initiation of therapy, and endoscopic or transmural response to therapy should be evaluated within 6 months. So essentially what this is telling you is get your CRP, your fecal calprotectin at 3 months, and get your endoscopic workup / transmural workup at 6 months. So just by a quick show of hands, who here uses endoscopic scoring systems for Crohn's disease? If you could just, Crohn's disease endoscopic scoring systems. Okay, and how about in ulcerative colitis? More, okay. All right, so this is actually interesting because it reflects a little bit what was found in this study. I wanted to highlight this because 2 of our speakers are part of the study, Dr. Riguero and Dr. Bawardi right there. So this is a survey that was done among participants of IBD Live. You know, IBD Live is a weekly conference, IBD conference. And so they surveyed those physicians and asked them, how often do you use these scores, and do you use them more than 50? How often do you use them more than 50% of the time? And you can see Mayo endoscopic score and Rutgers did not so bad, but SES-CD was just a bit more than half, and pouchitis disease activity index was barely used. So we really aren't using these scores, which is a shame. It's a shame because, of course, there's a lot, and it's tough to keep up, but they do allow for standardized monitoring, objective monitoring, and so you're able to follow the progress. And it's, you know, if the patient changes hospitals or changes physicians, it's also very helpful because you have an objective way of measuring it, and of course, it's helpful for research as well. That being said, inter-observer agreement can vary, and in some some physicians that are not as trained to read to use scores, it could be a bit more difficult. And so this is why it's nice to get you trained or get other trained around you to really help using this more. A couple of endoscopy scores in ulcerative colitis. The ones that we use the most are obviously the Mayo endoscopic score. The UCDAI and the UCEIS are also used quite well. And then in terms of Crohn's disease, the top scores that are being used really are the SES-CD, the CDEIS, and the Rutgers score. I have to say, I was yesterday at King Khalid Hospital, extremely impressed by their endoscopy unit, and they had those scores, these posters everywhere in their endoscopy rooms, and it was quite impressive. It really helps when you have them up in your room or if you have them part of your reporting system. So then you do your endoscopy, you get your biopsies. What are the biopsies telling us about the disease activity? We know that histologic remission, so no activity histologically, is associated with better outcomes. This specifically looks at UC, but Crohn's disease, similar idea there. So there's a reduced risk of relapse, there's a reduced risk of surgery, hospitalization, and colon cancer. So it's fantastic, right? The problem is that histologic healing, essentially, we really don't have a consensus on the definition of histologic remission, and multiple scores exist. Our histopathologists, from a clinical side, don't actually use them, and they're also prone to sampling error. So if you're going to use this as a target, you need something a bit more reliable. There's a lot of sampling error that could happen, especially with Crohn's disease. So on top of everything, it is a difficult target to achieve, and so I don't think we're there yet. Cross-sectional imaging, in just a couple words, we use them all the time to evaluate the rest of the GI tract, obviously. It evaluates for disease complications. MRI enterography is favored over CT enterography just because of the lack of radiation, where we also have access to perinatal MRI to really evaluate for perianal disease and complications. And we know that they actually help you monitor treatment response, and they're really responsive. Once you start someone on treatment, you can really follow that up. So is it time to use transmural healing as a target? Not yet. So actually transmural healing, it's fantastic if you're able to achieve it. What do we mean by transmural healing? Essentially normalization of the inflammation, essentially on your imaging. It's great. It's associated with decreased surgery in the future, decreased hospitalization, but not yet a target because it's just so hard to achieve. And we don't have enough biologics or treatment options to really warrant this. Quick word on intestinal ultrasound. It's a fantastic tool to be able to monitor the disease activity. You can evaluate for bowel complications, bowel damage. It's non-invasive. You can do it in the clinic. You get immediate feedback, and patients love it. I'm not going to tell you anything else on top of that because we have a really nice talk by the iBuzz group later on today, and they'll talk about the role of ultrasound, but it's a really important tool. So we're talking about monitoring, and I'm throwing all these CRPs, fecal calpro, endoscopy, The problem is that a lot of these tests are not well accepted by our patients. And if you look at this was a large survey in France. Our patients really don't like the tests that we're doing, and they don't like the way we monitor them. Venipuncture, labs, ultrasound was okay, capsule was okay, but for the rest of the tests, we were not doing well. And look at the sigmoidoscopy there, only 4.3. I mean, patients really don't like the test that we're subjecting them to. So what can we do to help since we need to be able to really monitor them so closely? So I think in terms of future, I was thinking of this, you need to use the tools you have first. And so that could mean basically thinking outside the box. Now, a few people out there have been trying to look at different models of care in IBD, and one of them is the IBD medical home, and Dr. Ruggiero can tell you a little bit more about this, but essentially, in that model of care, your patient is in the middle of that model, and it's a multidisciplinary care approach where you have a lot of different providers from different types of specialties that come to the patient to monitor the patient, because we can't do all of this on our own. It really takes a village. So you need all of these providers to really monitor and evaluate the patient, care for the patient. And that model has been shown to really decrease ER visits, decrease hospitalization rate, and increase quality of life. So we just have to really think, well, how else can we monitor our patients and care for them? Of course, remote monitoring is great, especially since COVID. This really took off. We have virtual visits, we have applications. This specific application was invented by UCLA, and what they found is that just by using this on their phone, patients could essentially record their symptoms, and you could see that this actually correlated very well with disease activity. But even better would be an option that does not require them to input information all the time. You really don't want them to be constantly reminded that they're sick, and so this is why wearable technology might be the future. This is just a proof of concept study that was published in the IBD Journal a few years ago, where essentially you have a patch that measures cytokines, including CRP, in your sweat, and they found that actually really correlated well with values in the blood. So who knows, maybe one of the things we could do for our patients in the future. And of course, I'll conclude my talk with artificial intelligence in IBD endoscopy. Now, we're already starting to use AI in endoscopy in general, polyp detection, dysplasia, but it could also help you monitor disease activity. And this study, the area under the curve was 0.97, so you could see how well AI did. They had about 3,000 patients, and tons of images from those 3,000 patients. And really, when they compared AI to the human reviewers that were experts in their field, AI did very, very well. And similar concept here, this was a study from Japan, and same thing. And actually, AI could also accurately detect histologic remission without the need for biopsies. So just in summary, treating to target and tight monitoring are really key in optimizing our outcomes in IBD. Monitoring strategies and modalities vary according to the clinical scenario, of course. Histologic and transmural remission are great, and they're associated with better long-term outcomes, but not yet formal targets. But really, as we're demanding tighter and more frequent monitoring on our patients, we really need to be rethinking how we deliver our care and how we monitor them. Thank you very much for having me.
Surgery, colorectal surgery, gastroenterology, hepatology, and nutrition, with the sites in different places in Ohio, Florida, London, and Abu Dhabi. And Dr. Aguero's main clinical and research interest is inflammatory bowel disease with a focus in nature course and medical surgical management of Crohn's disease and ulcerative colitis. He leads the research in post-operative prevention for Crohn's disease, as well as developing a new method of healthcare, including the first of its kind, especially medical home for IBD. And today he will talk about optimizing the use of integrin and interleukins in IBD, please.
Great. Well, thank you. Good morning. And first of all, I want to congratulate the Saudi Gastroenterology Association for a wonderful conference. I was here several years ago, and it's nice to see that the number of people and attendees has grown even more. There's a lot of talk around your conference, and so thank you. I'm honored to be here today. This year, unlike the last time I came and I flew from the United States and had jet lag, I was in Abu Dhabi for most of this week at Cleveland Clinic, so the flight was a lot easier and a lot shorter, but it's wonderful to be with all of you today, and I look forward to great discussion. As mentioned, I'm going to talk about optimizing anti-interleukins and anti-integrins in IBD. You'll hear a monitoring debate in a minute. You already heard from Sarah about some of the therapeutic monitoring aspects. But I think one of the key and most important things for all of us that see patients in our clinic is not to burn through, not to cycle too many biologic therapies without optimizing first. Many of you have seen patients with Crohn's or ulcerative colitis that come to your clinic who've already been on 4 different biologic therapies in 1 year. And the problem with that is when we run out of options, often these patients are left with really only surgery and difficulty with care. So I'm going to focus, this is a bit of a different talk in that I'm not going to focus on the anti-TNF optimization. I think probably you'll hear from the debate a little bit more about therapeutic monitoring with TNFs. But I'm going to focus on the non-TNF biologics. So vedolizumab, ustekinumab, risankizumab. And I think all of us are starting to use these and have used these for some time. So let's ask 4 simple questions. When you see a patient in your clinics who are on one of these medicines, the question is, does using these as first line, Vedo, Risa, or Usta, is that better? Second, should we use thiopurine or methotrexate with the non-anti-TNF biologics? Third, does decreasing the interval optimize therapeutic benefit? So from going from every 8 weeks, what about every 6 weeks? What about every 4 weeks? And then finally, does therapeutic drug monitoring in Vedo, ustekinumab, and risankizumab matter? So these are my answers to the questions. This is my summary slide. Thank you very much for having me today. This has been great. All right, I'll keep going, but these are really the answers to what I'll show you in a minute. Does first-line usage of Vedo, ustekinumab, and risankizumab matter? Yes. We now know that the best treatment we have is usually the first treatment. And this is true probably with the small molecules, and this certainly is true with the biologics. I will give you my take on the second. Should we use concomitant immunomodulators with these patients? And really, the answer is maybe it depends, and I'll elaborate on that a little bit more. Does decreasing the interval optimize therapy, bringing from every 8 weeks to 6 weeks or 4 weeks? Probably yes, it's just a matter of timing. And does therapeutic drug monitoring matter? Or should we do this with Vedo, Risa, and ustekinumab? My answer is probably not. I don't know that we get much benefit from doing that, unlike TNF inhibitors. So these are my kind of takes. So does first line matter? Yes. By the way, I will show you data slides, but this is really, I'm just going to give you the highlights and the title, so don't get bogged down too much on the slide. I'll just kind of speak through these. On the left-hand side are anti-TNF naive. On the right-hand side are prior anti-TNF failure. This is with vedolizumab. And the vedolizumab, you can see the different doses of vedo, how they were given. The bottom line is, if you compare the left with the right, and you've seen this in your practices, using vedolizumab as the first biologic works well. However, when it's used after an anti-TNF agent, often it does not work as well. This is another example of this in terms of in Crohn's. On the left-hand side is anti-TNF naive patients, where vedo's first line. On the right-hand side is after TNF. And again, you can visually see the bars are much higher in anti-TNF naive. So you'll hear tomorrow I'm going to give a positioning talk, and I'll give you a punchline now. Using vedolizumab first line works well in actually the majority of our patients. Using it after an anti-TNF, it does not work as well, and we're still trying to figure out why that is. What about ustekinumab? Same story. In the TNF exposed on the left compared to TNF naive on the right, you see higher rates of benefit by using ustekinumab as the first therapy. So this theme of the first medicine we use is often the best medicine. This is just an aside. This isn't really about positioning in terms of therapeutic monitoring. But it's very interesting. There was a study that showed, and the title's really the bottom line, ustekinumab is superior to vedolizumab in prior anti-TNF Crohn's patients. So when you see a patient in your clinic who's been on an anti-TNF and you're trying to think about what's the next therapy, vedolizumab's not the wrong answer, but the problem is the data don't support vedolizumab as much as ustekinumab. So in my practice, if I have a patient who's been on TNF inhibitor and they're failing that, or they've been on that, I will use an anti-interleukin. Ustekinumab in this study, risankizumab is also certainly an option. So just to keep that in mind, this is something interesting. All right, what about risankizumab? Actually, how many people are using risankizumab? Actually, just so I get a sense, because this is fairly new. So this is a handful of people, and we'll talk about this through the course of today and tomorrow as well. Risankizumab actually works extremely well. This is an anti-interleukin 23. It's specific to anti-IL-23. But when you consider bio-naive versus bio-failure, patients who've been on first-line risankizumab seem to work the best. Interestingly, and we'll get into this maybe in the conference, risankizumab also does work very well after TNF inhibitors. So when we think about positioning, this is something we need to consider. Same theme, you're seeing it over and over, bio-naive risankizumab. On the right-hand side, higher, you can see the higher bars. On the left-hand side, in patients who've been on bio-failure. All right, so that's using first-line therapy, and that's probably pretty easy. Probably most of you know that already. You don't need me to stand up here and show you the data. But what about concomitant immunomodulators? We have all now known that using concomitant 6-mercaptopurine, azathioprine, or methotrexate with infliximab or adalimumab is what we should do. That works well. But what about vedolizumab, ustekinumab, and risankizumab? The answers I'm putting up front here on this slide. If you're worried about immunogenicity, if you're worried about antibodies to vedolizumab, ustekinumab, and risankizumab, you do not need to use concomitant immunomodulators. They're extremely low in terms of immunogenicity. However, point number 2 is important. All of you in the room are referred very refractory, very difficult to treat patients. Sometimes to using 2 mechanism of action medicines, thiopurine, vedolizumab, thiopurine, ustekinumab, risankizumab. Maybe you're using combination. We talk about combination biologics now, but let's not forget that 6-MPA-azathioprine methotrexate still has therapeutic benefit. We worry about the side effects, I acknowledge that, but don't forget that, and that may be beneficial. On the right-hand side, it's probably easier just to look at the little pie graphs when I talk about this. very low rates of immunogenicity with vedolizumab and ustekinumab. The bottom line with ustekinumab and risankizumab, it's about 2% antibody formation. And the antibodies to the ustekinumab and risankizumab do not seem to be neutralizing. So we might get them, but probably don't mean much. The bottom on the right is vedolizumab is about 4%. That's why for me in my practice, I don't check therapeutic levels of these medicines, because if a patient is losing response, I simply want to give them more drug. I'm not sure I care as much about the immunogenicity because it is so low. This is hard to read, but really the title is the answer. But if you want to look at the study, it's listed here. This was from DDW a couple of years ago. Prior immunogenicity to an anti-TNF is not associated with increased anti-drug antibodies to vedo or ustekinumab. What that means is if you have a patient on infliximab and they develop antibodies and you're worried about that with ustekinumab, risankizumab, vedolizumab, the studies have not borne that out. If they've developed antibodies to infliximab, they do have a high rate of antibody potential to adalimumab. And you heard about the HLA-DQ, and maybe we should use concomitant immunomodulators in those patients. The other thing is the durability of vedolizumab and ustekinumab monotherapy versus combination has not borne out. So vedo on the left, ustekinumab on the right. It's hard to make out the colors, but the blue line is monotherapy, single drug. The green line is combination therapy. And you can see the lines almost superimpose. So whether you give a thiopurine methotrexate with these medicines or not, in terms of immunogenicity, it probably does not matter. Similarly, levels of new biologics are not affected by concomitant immunomodulators. So this is ustekinumab. So again, you're seeing the same theme over and over. I'm not going to present all of the other studies. What about therapeutic drug monitoring? In my opinion, and I've said this already, I think with vedo, risa, and ustekinumab, I don't necessarily check the levels. I'll show you some of the data, but I'm not sure we have the same information we have with the TNF inhibitors. And the obvious thing, you don't need a scientist to tell you, if you give more drug pharmacokinetically and pharmacodynamically, you're probably going to get higher levels. The question is, what does that mean? So this was actually a study looking at vedolizumab. On the far left of the plot, it's every 4 weeks infusions of vedolizumab. On the far right is every 8 weeks. The y-axis is vedolizumab concentration. And so probably the obvious conclusion is you give more drug, you have more higher levels of concentration. And that's pretty much what we've seen with most of our medicines. But does that matter? And I'm actually going to look forward to the debate that's going to come next. I'm not debating this year, so Al-Shiraz, he's actually smiling in the front row. But the age-old question is proactive therapeutic monitoring. Should we do it? We stand up at conferences all the time and say, we should do this. Does it matter? Here's the chicken and egg. I don't know. All right, so the chicken and egg is this. If we can place a patient in remission, you heard from Sarah, you heal the mucosa, we see some of the highest drug levels of infliximab, adalimumab, vedolizumab, ustekinumab, risankizumab when the inflammation is down. So the question is, if you heal the patient, are the levels high? Or, on the right-hand side, do we need the high levels to heal the inflammation? I still don't think we know the answer to that. I think with infliximab and adalimumab, there are enough data to say that we should. But with the other therapies, I'm not sure. So that's the question. I'm going to skip through some of these because I think the bottom line is most of the data have not shown with the non-anti-TNFs there's a benefit. I'll pause on this for a minute to just represent this. Adalimumab's on the left, ustekinumab's on the right. Sorry, the numbers are in white, so it's harder to see, but the bars I think you can see. The bottom line is this is looking at interquartile levels. So from left, it's lower levels, to right, it's higher levels. Look in the right side, the orange bars, ustekinumab. They all look fairly similar. So whether you have low levels or high levels doesn't really matter in terms of remission. Where adalimumab, you do get a sense that the higher the levels, the more the remission. So this comes back to the question, do we actually need levels with ustekinumab, vedolizumab, or risankizumab? Similarly with endoscopic response, looking at post-induction vedolizumab, there was some association with clinical remission, but the question is, are we just healing the bowel? One concept I'll tell you up front that I think I've seen in my practice, and I'm sure you've seen in yours, we need to get it right in induction. We need to get it right in induction. What I mean by that is, within the first 3 months of seeing a Crohn's and colitis patient, if we can heal the bowel and improve them, that's a patient that's going to do very well long term. In the first 3 months of seeing a patient, if we do not heal the bowel, that's the patient that we start to optimize therapy. We're behind in terms of treatment, and that's the patient that switches. So I think it's much more important for us to be very aggressive early, treat them, heal them, and then their maintenance will actually better long term. These are more studies, and this one I do want to pause on. I'm curious if this will come up in the debate. This gets into proactive therapeutic drug monitoring versus conventional therapy. And you can see the editorial on the right-hand side is, has the time come to say goodbye to therapeutic drug monitoring? Because the concept here was, at least in our studies, we're not sure we're seeing the big bang for the buck. All right, and then the final part of this is for Vedo, Usta, Risa, you put the patient, forget the induction, but they're on every 8 weeks. So this is easy for me to talk about because the maintenance is every 8 weeks for all 3 of those. Should we give higher levels, shorter intervals in everybody up front? Probably not. I don't think we necessarily need to do that. But if a patient starts to lose response to any of these, do we bring them from every 8 weeks to 6 weeks to 4 weeks? Does that make sense? And the answer is probably yes. So giving more drug from the start, interestingly, this is a study that looked at Vedo every 4 weeks, blue bars. So that means everybody got every 4 weeks. They didn't go to 8 weeks. They went to 4 weeks as blue bars. Red bars is every 8 weeks. And you can see that really there wasn't much of a difference whether you give every 4 or every 8 weeks. So I don't automatically from the start give every 4-week vedolizumab. There's not enough data on that. Similarly, the blue bars look very similar to the red bars. So whether you give every 4 or every 8 weeks doesn't really matter up front. Same thing, risankizumab approved at 600 milligram IV, but there was looking at higher doses. So the question often says, why don't we use even higher doses? There was really no difference. So we actually get the dose right with risankizumab. For those that haven't used it, I think the dosing being high is maybe a benefit over ustekinumab and the IL-23, but the higher doses don't matter. Same thing, 180 versus 360. Now we have 360 approved and we have 180 approved in the United States. I'll tell you up front, I do use the higher dose 360, but you could argue the 180 dose also looked very good. And then increasing the amount of drug when losing response, I think there are a number of studies that have actually shown now, if you give more drug in patients losing response to Vedo, every 4 weeks matters. Crohn's, Vedo every 4 weeks matters. And there's actually data with ustekinumab showing higher rates of response endoscopically in patients who are losing response. These I'm going to skip through, and I'm actually just going to go through to the end and kind of give you some of the conclusions. In the United States, and I know it's different based on the country that you're in, but the problem we have in the United States is getting approval for anything that's outside of the FDA label. So sometimes I can stand up here and talk to you about dosing and every 4 weeks and 6 weeks. Sometimes it's just not possible. So here's my conclusion. So first-line therapy, vedolizumab makes sense. And if you're to use vedolizumab, that's where I think we should use it. I think it's very reasonable. Ustekinumab and risankizumab are getting much easier to use first line in the United States based on insurance, and I think all three of those work very, very well first line. Tomorrow I'll give you a positioning statement of where I look at. Using concomitant immunomodulators based on the insurance company is easy. These are cheap, so that's not something we have a problem with. We have a difficult time decreasing the interval, and again, I don't know what it's like in the country that you're in, but sometimes going from every 8 to 6 to 4 weeks, that's difficult for us to do, and sometimes we just practically can't do it. And then therapeutic drug monitoring is getting easier, meaning the companies, the insurance companies in the US are paying for it. So this is my final slide. This is the conclusion slide. The first drug is usually the best drug, and we've seen this, I think, time and time again. However, with the first drug, we should optimize it before switching. So if you have a patient who's not doing well or not benefiting after a few months, the only thing I would ask for is before we switch it quickly to something else, try to either increase the dose. If it's a TNF, that's where I think levels is reasonable. Vedolizumab has less efficacy after TNF. I'll just tell you in my practice, I uniformly, if a patient's been on TNF, I'm not using vedolizumab second line. It's not wrong, it's not bad, but I think we have other options. Concomitant immunomodulators don't improve efficacy in terms of vedolizumab, ustekinumab, or the risankizumab. But if you have a patient who's very sick and you're looking for two mechanism of actions, I will sometimes still add 6-MPAs of thiopurine to one of these drugs. Not because it makes the efficacy better, but you're using a second-line therapy. Does therapeutic drug monitoring for these, is it required? My answer is probably not. And if I have a patient who loses response, I just simply, if the insurance company will pay for it, try to give it more frequently. I try to give them more drug. And then finally, does decreasing the interval matter? In patients who lose response, yes, but I don't do that automatically up front in all of my patients. And for those that haven't been to Cleveland Clinic in Ohio, this is how I left it. It's actually this time of the year, it's very nice. Wait a few months and you will see gray, cold, rain, sleet, and snow. So I'm happy to show you Cleveland Clinic, Ohio now. Thank you for having me here, and I look forward to a great conference.
Thank you, and now we are shifting to two of the eminent professor. First, Professor Badr Party. He's internal medicine residency. He's a consultant gastroenterologist and IBD specialist and King Faisal specialist hospital and research center in Riyadh, Saudi Arabia. He's an assistant professor at Riyadh School of Medicine, CG, USA, Al Faisal University in Riyadh, Saudi Arabia, after completing the medical school at George Washington University. He completed internal medicine residency, gastroenterology fellowship, and IBD fellowship at Mayo Clinic. And now he joined the faculty of Yale University as an assistant professor of medicine, where he developed and lead the Yale IBD fellowship program. Main interest of Professor Party within IBD include clinical outcome research, medical education. He has served previously an associated editor of Saudi Journal of Gastroenterology, and is currently on multiple editorial board of GI journals. The second speaker will be Professor Ala Sharara. He's a professor of medicine at the American University Beirut Medical Center, and previously chief of division of gastroenterology at AO PMC from 2000 to 2017. Also a consulting professor at Duke University in Durham, USA. He has American board certification in internal medicine and gastroenterology. He's a fellow of American ACG and AGA and the Royal College of Physicians London. He's a member of AGA, ACG, WEO, ECHO, and Lebanese Society of Gastroenterology. He has what's called over 200 published peer-reviewed articles, 4 books, chapter, and served as an editorial board of gastrointestinal endoscopy, American Journal of Gastroenterology, Clinical Gastroenterology and Hepatology, World Journal of Gastroenterology, and he's an associate editor of inflammatory intestinal disease. They will talk about a very strong debate, one, proactive versus reactive therapeutic drug monitoring. Welcome.
Okay, good morning, everyone. Before I start, I want to thank the organizers and congratulate them on a very nice and well put together conference. It's my absolute pleasure to be with you here this morning and to be debating with Professor Ala on the role of proactive therapeutic drug monitoring in inflammatory bowel disease. So these are my disclosures. Before I go ahead with the talk, I want to emphasize that for the presentation, we will be talking strictly about anti-TNFs. So Dr. Miguel really nicely set this up. I think I would agree that the role of TDM and ustekinumab and vedolizumab is very limited, and we don't use it much in our clinical practice. So this is basically, we're just talking about anti-TNFs. So as objectives for the talk, we will first talk about the factors that impact anti-TNF levels. Then we'll review the differences between proactive and reactive therapeutic drug monitoring. Then we'll dig deep into the literature on proactive TDM with anti-TNFs. And finally, we'll discuss the future directions of proactive TDM. So as a background, why is TDM important? We know that even with our best anti-TNF strategies, including combination therapy, the remission rates with IBD gets up to 60% at best. But more importantly, the rates of primary non-response to anti-TNF can be as high as 30%, secondary loss of response can be as high as 40%, and the annual rate of loss of response can be as high as 10%. So why did this happen? It happens for two main reasons. It's either pharmacodynamic, where there's an alternate inflammatory pathway that the drug does not target anymore. But for the sake of this talk, we're going to be focusing on pharmacokinetics. So that's low serum drug level, increase anti-drug antibodies, or increase clearance of the drug. So before we talk about therapeutic drug monitoring and drug concentrations, it's important to realize that when we do measure the drug concentration, it's a result of three processes. It's absorption, distribution, and elimination. And we have to also take into account how the drug is administered. For example, as you can see, if you're giving an IV or an intravenous drug, there's a high peak and typically a low trough, versus a subcutaneous drug tends to maintain the drug levels at a steady state when we look at trough concentrations. And it's also important to realize that drug levels or concentrations do not exist in isolation. So these are affected by many variables that should be taken into account when interpreting drug levels. For example, there are certain demographics that we should know about that can lower or is associated with lower drug concentrations. We know that males in general, obesity and smoking has been associated with lower drug concentrations. We know that a higher inflammatory burden, as measured by high CRP, high fecal calprotectin, low albumin, and low hemoglobin, has been associated with low drug levels, and the presence of antibodies. And now we have a genetic link with the HLA-DQ-A105 mutations is associated with low drug concentration. And finally, the lack of immunomodulators is associated with low drug concentrations. So reactive versus proactive. I'm just going to touch basically on these definitions as they will set up the debate. So reactive drug monitoring refers to measuring a drug level in a patient who's symptomatic with evidence of disease activity or potentially asymptomatic with evidence of disease activity, such as elevated CRP or fecal calprotectin or endoscopic activity. But if we really look at the pure definition of proactive drug monitoring, it's really measurement of a drug concentration at a pre-specified time point, followed by titration of the drug to achieve a target range. And that's really kind of the definition of proactive drug monitoring. So reactive therapeutic drug monitoring, when we utilize anti-TNFs, is the standard of care, and it's supported by guidelines and evidence. However, the point of contention that we'll be discussing today is proactive therapeutic drug monitoring. So where does the story of proactive therapeutic drug monitoring start? Well, there was numerous, I think, retrospective studies, including this one, which was a multi-center study, over 264 patients with an infliximab maintenance target between 5 to 10 micrograms. And they utilized two different assays, the ELISA and the high mobility shift assay, and followed up the patients for 2.5 years. So what you're seeing in these reverse Kaplan-Meier curves is the proactive group is in the solid line and the reactive group is in the dotted line. So first you see that the surgeries are much higher in the reactive group. The IBD-related hospitalizations are much higher in the reactive group. The antibodies to infliximab much higher in the reactive group, and the serious infusion reaction are much higher in the reactive group. However, I must say that I cannot use these type of data as an argument for proactive drug monitoring. We know there's a big limitation with using retrospective studies to answer this type of question, because there's a huge selection bias or confounding. It's obvious that symptomatic patients or patients who are flaring will eventually have worse outcomes. But let's look at prospective randomized controlled trials, and I'm glad that Dr. Reguero already touched base on this large systematic review and meta-analysis published in Gastro last year, which focused on randomized controlled trials. So let me walk you through the systematic review. So this was a review of 9 randomized controlled trials, over 1,400 patients, and they compared proactive TDM with conventional management. The primary outcome was clinical remission, which there was no difference between the proactive and the reactive. The secondary outcomes, they noted that patients who got proactive TDM were more likely to get dose escalation, but there was no difference in anti-drug antibodies. Okay, so you're thinking, why am I bringing this up if I'm actually gonna debate for proactive drug monitoring? Because as we know, systematic reviews and meta-analysis, it's a funnel, it's a plot. So it's about which studies go into the review, it will impact the final results. So let's look at those studies individually. And for the sake of time, I won't be able to go through all the studies, but the way I look at systematic review and meta-analysis is when I look at the studies, I want to know how much weight is each individual study contributing to the systematic review, and then look at these studies individually. So 6 of the 9 studies were negative. They did not meet the primary endpoint, but 3 of the studies were positive. Now, I kind of organized these studies in having the higher relative weight. So if you look, for example, the TAXIT study had 263 patients, the SERENE CD study had 219 patients. So let's delve into these negative studies that had the highest weight contributing to the systematic review. So we'll start with the TAXIT trial. This was published back in 2015. So for the TAXIT trial, this was a randomized controlled trial of 263 patients with IBD on infliximab. Here's a major issue with the TAXIT trial. Is all the patients were actually dose optimized. So they all got proactive TDM prior to randomization. So they got their levels checked, and the infliximab dose was either decreased or increased to achieve a goal of 3 to 7. Now, more than half of the population ended up with changing their dose prior to randomization. Now, once the patients were randomized, there was 1-year follow-up, and they measured clinical scores and CRP. So obviously, there was no clinical difference between when we look at remission between the proactive and reactive, but there are some important secondary endpoints that were met. For example, the risk of relapse was much lower in the proactive group. The undetectable drug level was much higher in the reactive group with a relative risk of 3.7. And those who maintained an infliximab level between 3 to 7 was more likely in the proactive group. So here are some limitations of the TAXIT trial. As we said, patients were dose optimized prior to randomization. And again, this study was done in the maintenance phase. Patients, the median time of infliximab therapy was 4.5 years. So these patients were already in stable dose prior to randomization. There was a short follow-up time, and we've learned a lot more about these infliximab levels, and a level of 3 to 7, I'm not sure is generalizable. So let's move on to the next study, which contributed a significant number of patients, which is the TAILORIC study. So for this study, patients with Crohn's disease on both infliximab and immune modulator were randomized to one of 3 strategies. 2 of them were proactive TDM, and the other was control. And the criteria for dose escalation was either a CDAI plus CRP or fecal calprotectin, infliximab trough level less than 3, or to maintain a level of 3 to 10 if there was a more than 50% drop at week 14. While the control group this is interesting, the control group had dose escalation just based on clinical data, not objective data. So when we look at the endpoints here, there was no significant difference between the two groups. But a couple of limitations we have to acknowledge about the Taylor study. One of them is there was a significantly high rate of dose escalation in the control group. So 40% of the control group dose escalated. And that's really based on, I think, nonspecific symptoms associated with the CDAI. And if you think about it, if your control group dose escalates at a higher rate, that will wash out any benefit from the TDM group. And again, going back to the target of 3, we have learned since then that this is probably a low level for our IBD patients. Now, the SERENE study is one of the newer studies published, and it did include a proactive TDM group. So just to review the study design of the SERENE study. So you had 2 groups. You had the standard induction regimen and the high-dose induction regimen. So the high-dose induction regimen received 160 milligrams on week 0, 1, 2, 3, and then 40 milligrams. Now, patients were then randomized or re-randomized after induction to either a therapeutic drug monitoring arm or a clinical arm. So these are the criteria. So I'm going to zoom in on some of these criteria. For the clinical arm, the dose was escalated based on either CRP or CDAI. For the TDM arm, if the level was less than 5, the dose was escalated, regardless of the symptoms. If the level was between 5 to 10, the dose was escalated if the CRP is high or the CDAI is high. So they try to maintain a level above 5. Now, when we look at the endpoint, when we look at the rate of dose escalations, it was about 40% or so in the TDM group and about 28% or so in the clinical group. And there was no significant difference between these groups. So what's my take home from these studies that have already been done on proactive drug monitoring? So here are the major limitations. I think the cutoff trough levels were low, as we've learned a lot more. So that's point number 1. Point 2, most of these primary outcomes were clinical and not objective. If you look at the primary outcome for the systematic review and meta-analysis, it was actually clinical remission and not objective. So we are lacking endoscopic or biochemical remission data. The other point is that populations are heterogeneous, so we're including patients with different phenotypes, and we have learned that patients with a different phenotype, such as perianal disease, usually tend to need to have a higher drug level to be associated with remission. But I think the most important part is the way we're thinking about proactive drug monitoring in these trials during the maintenance phase is where there is a major limitation. And Dr. Miguel mentioned this earlier. I think it's really important to get this right during induction and not maintenance. So why is the induction phase very important? So number 1,
do you have time for Ala also?
Sorry?
Ala.
Okay.
Okay.
So 2 minutes. So the number 1 is that we know that there's high drug clearance and the risk of antibody formation, and that usually happens in the induction phase when you have a high inflammatory burden. Antibodies to infliximab can form as early as 18 days after the first dose. And we know, we've learned from multiple studies that higher infliximab induction levels are actually associated with favorable outcomes. And for the sake of time, I won't be able to go into detail on these studies, but in brief, what they show, this is a study for UC showing that a higher induction level at week 2 and week 6 is associated with favorable short-term mucosal healing, which was measured at week 10 or 14. Same for Crohn's disease. This was a prospective study of patients on adalimumab, and what was interesting is that 50% of those, or 55% of those who formed antibodies actually formed it as early as week 2. And those primary non-responders, 2/3 of these primary non-responders had antibodies during induction. So it's really important to get it right during induction. And this is where the pilot study comes in. This was one of the positive randomized controlled trials of adalimumab in patients with pediatric Crohn's disease. And the take home of this study is that TDM started at week 4, so it started really early. And with those, it did show a significant benefit of proactive TDM, where there was a higher rate of corticosteroid-free clinical remission, and also higher rates of objective parameters, including low CRP and fecal calprotectin as a composite endpoint. And subsequently, we have this not yet published in full manuscript, but presented at ECHO, a randomized control, a non-blinded randomized study of 112 pediatric Crohn's patients on infliximab, and they randomized the patients into either TDM or clinical dosing post-induction. And again, objective parameters, endoscopic healing was much higher in the proactive TDM group. And then we've been talking about efficacy, but we should also mention safety. This is a systematic review and meta-analysis of proactive TDM, and in contrast to the previous one, this looked at safety, and they noted that there's actually lower acute infusion reactions and adverse event rate with proactive TDM. So just give me a few minutes just to talk about the future, because I think this is where we are actually going to be noticing a benefit with proactive TDM, and this is about pharmacokinetic modeling.
Better, I think we need to give space, Dr. Ala.
Okay, I thought we had 20 minutes. No? 15? Okay. All right, well, this was really my selling point, which is pharmacokinetics and dashboard dosing. So just if we can just extend 5 minutes, I would really appreciate it. So the dashboard dosing, if I go back just one slide here, this is really kind of the most important slide. This is using population pharmacokinetic and pharmacodynamic data and applying individual data to get a drug concentration for precision dosing. And I'm going to just share with you a couple of studies that show that there's a significant benefit with dashboard dosing, including this study here that use objective parameter. Another study also showed that if you do not adhere to dashboard dosing, that forecasts having antibodies and needing discontinuation. And finally, the simulation study showed that the probability of deep remission is as high as 64% with that. So there are a couple of ongoing trials looking at these dashboard dosing for both Crohn's disease and UC, and I think this is really where the future is. So this is my take home on how I use proactive drug monitoring. I would use it in induction, post-induction, and high-risk patients. Those with history of anti-TNF antibodies or monotherapy for treatment de-escalation and reinduction. And I just put this as a guide. If you want to use proactive drug monitoring during induction, these are some of the levels that we should aim for. So with that, I'm going to end here. Current randomized controlled trials have multiple limitations. I think dashboard dosing appears to be a promising TDM tool, and proactive DTM during induction is likely where the benefit is. So thank you for the attention, and I apologize for running over.
All right, well, good morning, everyone. I also like to thank the organizers for the kind invitation. I was here 3 years ago with Miguel for the first meeting that we attended together, and I have to say that this is really a fantastic work that the group is doing, and I see really a lot of people who are attending, and I hope that we get a chance to discuss and debate more issues as we go on. So it's always hard to go second in a debate, but the advantage is that you potentially could get the final punchline in. I think Badr did a great job in really pointing out the pros and cons of TDM, and I'm going to sort of continue the discussion. There will be some overlap, of course, we're covering the same topic, but I'll take a different spin on things as we go. So these are my disclosures. So we're on for the battle of the titans here. So who's right and who's wrong, and in the final analysis, I think we both will be right because there are some valid points for both of the discussions. So as mentioned, the discussion is going to center on the evidence for TDM for anti-TNF, as was mentioned, the role of TDM in other biologics, and of course with small molecule doesn't have a role. The question really centers around, is more better? Because what proactive TDM is trying to say is like, keep pushing the drug to control inflammation in all patients or in most patients. There are some caveats which I'll discuss, and finally, how to best optimize anti-TNF independent of TNF. So we've already know proactive versus reactive TDM. The concept is fairly simple to this audience. The rationale is clearly this exposure-response relationship that has been identified from multiple studies, generally in a retroactive fashion, post-hoc analysis of randomized controlled trial. And Better alluded to some of the studies in clinical practice. There are some prospective studies, but the most of the evidence that have accumulated initially came from retrospective studies and few randomized controlled trials that have used clinical remission as their primary outcome. And this table here really shows the following concept, is that higher levels are associated with more difficult to achieve outcomes. So you could see that in order to achieve histological healing, for example, you have to have the highest level of the biologics compared, for example, to clinical remission or biological remission. So the concept is more is better in terms of controlling inflammation. And this concept appears to be something that is accepted by physicians. So we didn't have a poll at the beginning as who's in favor of proactive or reactive TDM. Would have been interesting to have that before and after. But this is a survey from the United States, and you could see that in blue, the current use of TDM, really this is a concept that's accepted for secondary loss of response, interestingly even for primary non-response, and we'll talk about that a bit later. And when asked whether if we remove the barriers to use TDM, meaning cost, access, rapidity of getting the test back, you could see that essentially all the surveyed physicians said, I'll use it. So if that's the concept, and a lot of them actually moved to proactive TDM. So people are convinced that it's useful, but they're also convinced that there are barriers, and if we remove those barriers, maybe proactive TDM will win. Now, generally in life, whenever you're proactive, it's always better than being reactive. I would argue that in this particular situation, it may not be as clear. So reactive strategy is fairly simple. As Better mentioned, you basically have symptoms in the patients and potentially loss of response. You measure the trough levels, you measure the antibodies, you adjust treatment, increase the dose, or switch out of class. Now, for proactive and best clinical care, I'm also going to highlight the same studies, obviously. This is the Taxit and the Tayloric studies. They did have limitations, as was mentioned by Better, but both did not meet the primary endpoint, which was to show that proactive TDM was better than a clinically based algorithm. This is the Payot study, and I think Better mentioned it, showing that there is evidence in pediatric population that there is a benefit. Now, we have to notice that the devil is in the details in those studies. In this study, the dose escalation in the reactive arm was only allowed if the level was low, regardless of symptoms. So the children could be suffering from real symptoms of active Crohn's disease, but they were not allowed to escalate if the level was less than 5. And what happens is, you saw the results are in favor of proactive, but essentially almost everybody in the proactive group required intensification and ended up on weekly adalimumab versus 60% in the reactive arm. So essentially, more drug was given to the proactive patients, ended up with better results because of that. Now, there are two recent studies that were published sort of a back-to-back in JAMA, and this is classic for the Norway type studies, like the NorSwitch study, if you remember. This was a study that was done on TDM in IMID, so in all the immune-mediated inflammatory diseases. This was a hodgepodge of different diseases, rheumatoid arthritis, psoriatic arthritis, etc. But the concept was tested on infliximab in two studies that were published, one on induction, so looking at proactive TDM in induction, whether that makes a difference. And you could see here in the forest plot that there was no evidence that there is benefit from proactive TDM with infliximab in this particular patient population in the induction phase, which of course was alluded to as being perhaps the most important phase. This is the second part of the study, which was the TDM and the maintenance group. And here there was a benefit in favor of proactive TDM, showing that there is a benefit in terms of the outcomes. However, the studies, of course, had limitations. It's an open label study. There's possibility of biased assessment of outcome. The population, as I mentioned, was an IMID potpourri with nearly 140 patients with IBD, and it was not powered for each specific disease. Nevertheless, it did, of course, open up the debate again as whether proactive TDM is better. Now, always when in doubt, we go back and ask the experts. This is a paper that was published in the Red Journal on a comprehensive literature review, expert consensus statements on TDM in inflammatory bowel disease. So what do the experts say? This is regarding reactive TDM. Now, you see on the right is how these agreements were made. Obviously, these experts really conferred, and they were all patting everybody's shoulder, and they agreed with all the statements, and a high level of strength of recommendation. But notice here that they also said that reactive TDM should be done when you have confirmed primary non-response. Now, I'm a bit puzzled by the evidence behind that, but this is open for debate. I'm not really sure that when you have a primary non-response, there's a whole lot that can be done in those patients. How about proactive TDM? The answers were all over the place. So you could do it after induction. You could do it at least once during maintenance therapy. You should use it after reactive TDM, so we asked the expert, and we ended up being a bit more confused than before asking the experts on what to do. The reason, I think Badr mentioned this early on, the reason this debate is important is because our results are really not that great with these agents. This is a table that I put together with my colleagues here from Saudi Arabia, looking at the endoscopic healing in patients who receive anti-TNF. And you can see on the right, and highlighted in yellow, is that our mucosal healing rates are low. And that's why we really need to optimize, and one of the strategies is TDM. This was mentioned by Badr also, of course, the primary non-response and the loss of response. And where does this importance of TDM fit? Now, in my opinion, and it may be a bit too dogmatic on my part, is that when you have a primary non-response, it's like having an antibiotic that doesn't work. So you give a drug, you give a high dose usually with induction, and there's really no response. The patient is no better, inflammatory markers are not improved. This is like using an antibiotic for a resistant drug. It's not going to work even if you increase the dose of the drug. Now, how about the secondary loss of response? The idea, again, the concept here, and the central, I think, tenet in terms of inflammation is that, again, giving more is better. So you have possible mechanisms of loss of response. One is, of course, antibodies and clearance in terms of pharmacokinetics. But you could also be moving away from a TNF-mediated mechanism of inflammation, and hence, increase in the drug is not going to result in any improvement. So the proactive model of TDM is really central to one concept, is that more is better. So you keep pushing the drug up with the aim that you will achieve this drug. Now, clearly, the pharmacokinetics of anti-TNFs is very complex, and it would be simplistic to think that increasing the dose only without taking other considerations in terms of genetics, patient gender, size, other metabolic factors could play a role would be simple. So I'm going to discuss quickly two important situations where dosing, increasing the dose did not really result in improvement. So the first one is one that we struggle with all the time, is acute severe ulcerative colitis. And in those patients, the mechanism for lack of efficacy or reduced or destruction, let's say, or loss of anti-TNF response is multifactorial. But this is the strategies or studies that have looked at intensifying the dose in acute severe ulcerative colitis. And you could see on the right, or maybe you can't see, is that all of the studies were negative, essentially, except for the Gibson study. There was no benefit from either decreasing the interval in the first induction period or increasing the dose to 10 milligrams per kilo. So here in this particular situation, more was not really better. So there is some studies on therapeutic drug monitoring in acute severe ulcerative colitis, but those have really not shown that there is a benefit here in doing this particular strategy. The second is the SERENE study. This was covered by Badr, so it makes my presentation a bit faster. It involved two parts. One is intensifying the induction regimen, which means giving more of the drug. And the second part, after the induction, is to do therapeutic drug monitoring, so you following a proactive strategy. And in this study, as Better showed you earlier, there was no benefit from the higher dose induction, and there was really no benefit from proactive compared to a clinically based and CRP-based management strategy. So this brings us back to the concept that was actually brought up by Miguel a bit earlier. These are relationships that may not indicate causality. We're looking at higher levels and better outcomes, but this could be a situation of is it the chicken or the egg that's driving this parameter? And I put this in terms of kids' play and a seesaw, in that if you have low or controlled inflammation, you are ending up with high trough levels. And if you're having high or controlled inflammation, you have low levels. And it may be what you're looking at is the result of the status of the inflammatory status, not the cause of what's driving this. Now, I don't have evidence to support this, as we mentioned. Clearly, one main determinant of the pharmacokinetics is the inflammatory sink. So the higher the inflammation is, the higher the TNF expression, the more likely that the drug will be eaten up and the drug levels will disappear, versus giving the drug to somebody who has no inflammation. And I want to show you this interesting simple study that was done using a biosimilar of adalimumab in healthy volunteers. The problem is we don't have pharmacological or pharmacokinetic studies long-term in healthy volunteers. But this is one single shot of adalimumab in a healthy volunteer. You could see the drug levels already up to the 3 microgram per milliliter dose, and you could see that the drug was persistent in the circulation for 70 days after one single shot of adalimumab. The reason is there is no TNF in that volunteer to bind this drug and take it away. So the concept of the chicken and the egg really is very relevant here. Finally, there are also barriers to proactive TDM. We like to do it. I do agree that it may have a role despite this debate, but there are hurdles that may not be easy to overcome for most of us, because the optimal concentration therapeutic windows are not clear. When to do it in the induction phase, early in the induction, during maintenance, when the patients are, years out, what type of assay do you use, and the out-of-pocket cost of the assays. And also, these biologic drug assays have variations, so their inter-assay variabilities, the gold standards are not set. And also, if you think the trough levels are difficult to standardize, the anti-drug antibodies are 10 times more difficult to standardize in terms of assay variability. So Better mentioned the dashboard effect, and I saw Peter Irving just walk in, so this is a beautiful review from Peter and in gastroenterology on TDM. I would advise you to read it. It's a fantastic review. And using the dashboard, of course, putting all of this into the equation is important, but I like the statement that was made at the end of the paper. It is important to remember that TDM represents a small part of the assessment of patients with IBD, and while we believe that its use can enhance clinical care, decision-making based solely on TDM has the potential to harm. So we really need to understand where and when to use it in our particular patients. And it is one part of the management algorithm to basically optimize, as was discussed and presented beautifully by Sarah earlier. And TDM could be one of those strategies, but we need to take that into context in every patient when we manage patients with severe Crohn's disease. Thank you.
Thank you very much, Prof. Ala. So we have room for 1 or 2 questions. You can ask it through the system here, or you can walk up to the mics there. In the meantime, Prof. Miguel, so is there, in the monitoring part and the optimization, is there a real phenomenon of drug amnesia and reinduction? Is this a reality or a myth? So we have these drugs that has been going, like I've seen that in interview, that you give the medication and then it loses the response, and then you reintroduce again, reinduce, and it picks up in the response. So is there a room? Can you give the mic, Prof. Miguel? The mic to him. He's behind you. أديله المايك لو سمحتي. Thank you. And if you can.
Yes. So I think that's a good question. The concept that there's a high loss of response in some of our monoclonal antibodies, but then at a period of time later, we actually reinduce. There's some quiescence and then we reinduce them. And the answer is yes, we do see that. There is a benefit in reinduction in patients who've lost their response. I think the problem becomes if it's too far gone, meaning if the inflammation is too great, if it's a TNF and they developed antibodies, then it makes no difference. Just very briefly, I will give a single dose of IV ustekinumab, and I will induce with 3 infusions of risankizumab and 3 infusions of vedolizumab in patients that I want to try the reinduction tactic. And it's about 40% effective. So why does it seem to work, the reinduction? I mean, you just heard the debate about giving more is better. I think that there are some people who actually get a biologic switch, where they actually switch their cytokine profile, they come off the therapy, then we try it again in the future, and it works. I don't think any of us entirely know, to be quite honest, if you look at it from a scientific standpoint, aside from the potential of immunologic cytokine switch that may occur and reintroduction in the future. The problem is now, not the problem, the reality is now we have so many therapies that now we're not necessarily going back to the same medicine. This is where you'll hear about small molecules at this conference. I'm using a lot more upadacitinib in patients who've been on anti-cytokine therapy and seen very good responses in those patients.
Yes, second question, Professor Mosley.
Hi, good morning. I'd like to thank all the speakers for these wonderful talks. My question is directed to Miguel. So I think we all agree that the probability of developing anti-drug antibodies with anti-integrins and anti-cytokines is quite low, like we heard. In lieu of that, how do you explain the significant amount of patients who lose response? If you look at the literature and you look at your own clinical practice, it seems to be equivalent to those who develop antibodies to anti-TNF. It's about 25 to 30%. And the reason I'm asking is we keep saying that these drugs are more durable compared to others, but we do see in practice that patients do lose response. So how do you explain that and how do you navigate through that?
Yeah, no, I mean, I'll put it a different way. Why are our therapies, all the therapies we have now, we still talk about our remission rates of 40% being great? We still have a very low ceiling. So to your question, vedolizumab, ustekinumab, risankizumab, even though there seems to be a durability, we do over time seem to see about 40 to 50% of patients over a 3-year period lose response. My answer to that is if you look at the studies and who loses response and who it's more durable, it comes back to that getting it right in induction and really that complete remission. When we have fecal calprotectin under 50, when we have mucosal healing endoscopically, and this is true of any therapy, but for the anti-cytokine vedo ustekinumab risa, the actual durability, sustainability of remission is about 85 to 90%. When you look at the patients, to your point, that seem to lose, that have that 50% drop-off, interestingly, that correlates with the inflammation not being completely controlled. Beyond that, there might be, as I mentioned a minute ago to the first question, there might be an immunologic or a biologic switch. So this concept that if people haven't heard this before, where one anti-cytokine's working, IL-23 is important, somehow internally in that patient, in the body, they switch away from 23, and that doesn't work anymore. I think we need a lot more precision medicine, but that may be part of what we're seeing. And maybe not seeing that as much with the small molecules, but we need more time to say that.
Thank you.
I think I have just a comment, but not a question, from all the lectures. I have a problem up to now about therapeutic drug monitoring at the end of the session, which proactive, were proactive, and also a problem with the using colonoscopy. You know that Spark study, it's 1,700 colonoscopy, something deliver abnormal knowledge for consensus about using colonoscopy for follow-up in treat to target strategy up to 50 months. And they deliver special knowledge about the impact of this colonoscopy use on the outcome. We have still debates and we have still a problem at the level of this session about final decision, just consensus for therapeutic drug monitoring, inter-association variability, intra-association variability, it's a big problem. And the second is about colonoscopy driving treat-to-target methodology.
Professor Badr, Badr and Professor Ala, though the data is not supporting for time being the proactive drug monitoring, you think in clinical practice some patients still benefit from proactive monitoring for the drug level?
I mean, I do. Well, I mean, based on what I mentioned, I think, again, the idea in my mind is kind of, is it the chicken or the egg phenomenon? But when you have a patient with severe disease, I think you try to do everything that you can right from the beginning, as was mentioned. This induction period is very important. A week 14 level, for example, TDM, could be useful. It can help you adjust the dosing. Sometimes this helps you sort of improve the maybe address the insurance issue and say, well, you know, I need to just go up on the dose. Sometimes they don't. We find it easier to up dose infliximab, honestly, because as an infusion center, it's easier to just adjust the dose. A bit harder for adalimumab. But I think it helps you in the most difficult patients, yes.
I mean, I think the only thing I would add, we even though we debated last time, I think we practice very similarly and we agree more than disagree. I think for the audience, if you think about who should use proactive monitoring of infliximab, primarily adalimumab, really it's the two groups, as Al-Sharara said, severe ulcerative colitis and perianal fistula. If you want to keep it simple, those are the two groups. And you could get into extraintestinal manifestations, but those two groups have actually shown, especially if you get to levels within the first 10 weeks over 15, the benefit to the question that was asked about loss of response, the benefit is higher. So fistulizing Crohn's and severe ulcerative colitis, that is when I will use proactive monitoring 100% of the time.
I would just add another scenario that I think it's important if you have a patient on an infliximab or adalimumab holidays, particularly infliximab, after giving the first dose, and I usually give a higher dose, I give 10 mg per kg on the first dose. That's not when you're going to get a reaction, but about 7 to 10 days after the dose, I typically would do proactive drug monitoring in these patients to see if there's any antibodies that could predict a infusion reaction with the second dose.
The last question from the back there. Yeah.
Thank you for the wonderful talks. I have a question for Sarah. Sarah, if you have a patient, 32 years old, she's one of your IBD patients, Crohn's disease. She didn't show up the last time for her appointment. Now it's a year that you saw her. She's on biologic therapy. She's sitting across from you saying, I'm fine. Everything is completely fine. Now in your daily practice, what would you do to monitor her?
Right. Thank you, Christian, for your question. So I wish I'd had the intestinal ultrasound to just take a quick look at what's going on, but for sure you want to really know how she's feeling, you want to go through the clinical symptoms, and you'd want to get your blood test, right? Not only just the CRP, we talked about CRP, but there's a lot of other ways to know whether her disease is active, hemoglobin. You really want a really comprehensive assessment. You're going to get a fecal calprotectin as well. I usually try to get it every 3 months, if possible. It's really challenging for our patients to really do it every time. And intestinal ultrasound, and I look forward to your talk, would be such a good way of checking, because sometimes they feel good, but that's not what we see inside.
Thank you.
Thank you all for the whole speakers. It was a wonderful session. Thank you to all the audience, and we conclude this session. I would like to invite the next chairmen, Prof. Yusuf Gari, Prof. Amr Saada, to the podium to introduce the next speakers in the session.
السلام عليكم ورحمة الله تعالى وبركاته. Good morning again, dear colleagues. We will have to continue our program because of the time. The next, I'm joined here by Professor Omar Saada, co-chairing with him this session. He's the Dean of the Faculty of Medicine at King Abdulaziz University in Jeddah. And I'm Yusuf Gari, a gastroenterologist at the same university. So the topic of the next talk is a combined SGA, MOH, or Saudi Gastroenterology Association and Ministry of Health IBD guidelines from west to east, similarities and differences. I will pass to Prof. Amr Saada to introduce the speakers.
Good morning, everybody. It's my pleasure to introduce both speakers to the next session. Dr. Mosley, he is currently an associate professor of medicine and a consultant gastroenterologist at King Abdulaziz University Hospital. He is also the head of the inflammatory bowel disease unit. Dr. Mosley is completed an internal medicine residency and gastroenterology fellowship in the University of Western Ontario, London, and Canada, followed by 1 year advanced clinical IBD fellowship at UWO, and then completed a master's degree in epidemiology and biostatistics from McGill University, followed by 1 year IBD clinical trial fellowship from Robert Research Institute. He has more than 100 publications, mainly in the field of IBD, and he is currently an associate professor of, associate editor at the Journal of Saudi Journal of Gastroenterology and the IBD Cochrane Collaboration Group. The second speaker is Dr. Hajar Al-Mudahim. She is an advisor and assistant deputy minister for therapeutic supportive services at the MOH. She is also a director of Drug Policy and Regulation Division. She was appointed as a head of National Drug Information Center at the Ministry of Health in 2015. She established more than 50 centers across the kingdom. Dr. Hajar is responsible for MOH formulary management and was recently appointed as Drug Policy and Regulation Manager. She is a board member of the Pharmacy Profession Society under SCFHS and of the Saudi Clinical Pharmacy Society. I may invite both speakers for the intended topic. Thank you so much.
Good morning. Thank you, Prof. Gari and Prof. Saada, for the very kind introduction. I'm very pleased to be here and happy to be part of the speaker panel for this event. We all have been looking forward to this masterclass, and I'm hopeful that everybody is enjoying it. So today's talk, I've been tasked with talking about the Saudi Arabian consensus guidelines for the diagnosis and management of IBD, and maybe going in depth about the rationale behind these guidelines from multiple perspectives. These are our disclosures, both myself and Dr. Hajar. So here are the objectives. I'll start with introduction, so it's a little bit of IBD epidemiology, touch on the current available international guidelines, the barriers to managing IBD in the Kingdom of Saudi Arabia, the rationale for creating local IBD guidelines, a little bit or a summary about the published IBD guidelines and future plans. So we all know that inflammatory bowel disease is on the rise. Over the past 50 or 60 years, there has been a steep increase in the incidence and subsequently prevalence of IBD worldwide. You can see this figure published in The Lancet in 2020 showing the increase in worldwide prevalence in both genders going between 1990 and 2015. But if you take a closer look, when you differentiate by location, you can see that the incidence and prevalence differ depending on geographic locations. For example, higher incidence and prevalence rates are known to be present in the United States, Western Europe, and Australia, as opposed to lower incidence and prevalence rates in areas of the world such as the Middle East and Japan. This is a very nice figure published by Jill Kaplan a couple of years ago. And you can see here in this figure, what they did is divided the stages of IBD existence or occurrence into 4 stages. So emergence, acceleration, incidence, compounding, prevalence, and then finally the prevalence equilibrium. And you can see the different parts of the world, depending on how industrialized countries are, fall into these categories. So for example, you can see in the figure on the left that Saudi Arabia is among the countries in the acceleration incidence phase, as opposed to the United States, who are going through the compounding prevalence phase. Other areas of the world, such as the majority of Asia and South America, are in the acceleration phase as well. Now, it's important to understand, even though IBD is a global disease by definition, it's everywhere, there are some differences seen or observed between ethnicities and geographic areas. So, for example, you can see in this publication, a systematic review and meta-analysis published in Clinical Gastro back in 2018, you can see when you look at different races, so white, Asian, black, and Hispanic, there are some differences in phenotype. For example, Hispanics tend to have more L1 disease compared to other races. With regards to phenotype or behavior, for some reason, black patients seem to have more fistulizing disease and perianal involvement. So these are some phenotypic differences that need to be considered when planning management of IBD in specific areas of the world. Other differences include natural history of the disease. So the need for escalation to biologic therapy, the need for surgery also differs between races and ethnicities. For this reason, it's difficult to generalize guidelines across the world. You need to look into these specific differences when you're planning to adopt certain guidelines in your practice. This is a very easy way to look at the journey of the disease. And you can see in a vertical fashion, you start with diagnosis. This is from the patient's perspective, of course, IBD disease activity or flares. Then you have a point where you need to start treatment, go into remission, and then finally deal with phases of recurrence. And of course, on the right side is the role of the physician, who has to look at the beginning into differential diagnosis in order to be able to establish diagnosis of IBD, be able to monitor and evaluate, like we heard from Dr. Sara in the morning, and then also be able to predict therapeutic effect, do TDM, like we heard in the previous talk, and then of course perform endoscopy, look at histological response, and finally be able to predict recurrence. Now with the evolution of endpoints, also there is evolution in therapeutic choices. So you can see since 2003, in the past 20 or 22 years, lots have changed in the number of medications that are made available for IBD for both UC and Crohn's disease. We went from having one class of medications, one class of advanced therapy, which is anti-TNF, to more classes that work in different ways. So we have anti-integrins, anti-cytokines, and more small molecules. And this is likely to become more complicated in the next few years. Here's the most recent STRIDE-2 guidelines. We've heard about this today, and mainly we're focusing on objective evaluation of disease activity and making rapid decisions to avoid periods of time where patients are in active disease without intervening. So we have drugs, we have objective tools to monitor disease activity, we have colonoscopies, etc. But how do we use all of this to manage our patients in lieu of the presence of these differences that we talked about? So we do know that there's a lot of guidelines out there. There's multiple international guidelines. The four most popular ones, the ones that we mostly use in our practice, are the European Crohn's and Colitis Organization, the ECHO guidelines, the American Gastro Association, the AJA guidelines, the American College of Gastroenterology, ACG guidelines, and the British Society of Gastroenterology, BSG guidelines. So just a highlight on each of them. So the ECHO guidelines mainly focuses on all aspects of IBD. So it doesn't look at other gastrointestinal diseases, only IBD. It's published in the Journal of Crohn's and Colitis. Each published document focuses on a specific part of the patient journey. So you'd have a document on diagnosis and variable areas of therapy. It's regularly updated and it follows the grade system. It's also available online for free, and you can see on the right side some of the guidelines published in the past few years. This is the most recent IBD guidelines published by ECHO. On the left side, you have the ECHO guidelines for ulcerative colitis, and on the right side, the Crohn's disease medical treatment guidelines. Then we have the AGA guidelines, so focuses on all aspects of gastroenterology, not just IBD. So IBD, it's one part of what they look at. So it's published in Gastro. Each published guideline document focuses on a specific part of the patient journey again, regularly updated, follows grade, and is also available online for free. These are the most recent AGA guidelines for ulcerative colitis and Crohn's disease. The ACG, so again, focuses on all aspects of gastro, not just IBD, published in the American Journal of Gastro. Each document focuses on a specific part of the patient journey. It's regularly updated, follows grade, and also available online. These are the two most recent ACG guidelines for IBD. Finally, the BSG guidelines. So here, these guidelines focus on all aspects on gastro, not just IBD, published in Gut. It's very comprehensive, covers all areas of the disease, regularly updated, and follows the AGREE Instrument 2, and is also available online for free. This is the most recent BSG guidelines. It's a very dense and quite comprehensive document to read, and it's very informative. Now, let's focus on the barriers in managing IBD in KSA. This is according to local literature and local surveys. We've identified a few barriers that hopefully need to be addressed in the next few years. So, number one, delay in diagnosis, mainly secondary to misdiagnosis. This is a global phenomena, but we have identified it as a major problem in the kingdom. Delay in referring IBD patients to specialized care for multiple reasons. Delay in starting effective treatments, especially advanced therapies. Overuse and prolonged use of corticosteroids. I know this is also a global phenomena. higher prevalence of tuberculosis in KSA compared to the Western countries, significant heterogeneity in treatment selection patterns, lack of adherence to treat-to-target strategy, differences in the phenotypic characteristics of IBD in KSA compared to other parts of the world, and finally, presence of multiple international guidelines to follow. So how do we overcome these barriers is the question. So number one, standardized care plans. Number two, establish measurable goals and KPIs. Number three, establish methods to measure these KPIs. It's easy to have KPIs written down, but it's more difficult to have an objective way of evaluating them. Identify gaps in IBD care through assessment of these KPIs, and finally design interventions to close these gaps. So why do we need local guidelines? So number one, to standardize diagnostic and therapeutic approaches for IBD and KSA. So we would want to be able to minimize delay in diagnosis, minimize delay in starting effective therapies, prevent overuse of steroids, improve treatment selection and sequencing patterns for IBD medications, improve adherence to appropriate monitoring strategies, namely the treat-to-target strategy, and through all of this, we're hopeful to be able to raise standard of care. Guidelines would be very helpful in guiding governmental and institutional formulary decisions. And finally, guidance for the private healthcare sector, especially the insurance companies. I'm going to hand over to Dr. Hajar, and she's going to be guiding you through the rest of the presentation.
Assalamu alaikum jami'an. Thank you, Chairperson, for welcoming me today. Thank you, the organization committee, for inviting me, and of course, thank you, Dr. Mosley, for your leadership in presenting our guidelines. So, first of all, if we look back on why now currently we need to have a certain guidelines, local guidelines, that would reflect our need, and we need to address that we are different than different countries. So first of all, we need to address that we still have uncertainty when it comes to different or new molecule or new medications and breakthrough medications. Two is the high prevalence of the disease and the high prevalence of population with chronic diseases. Third is we all have lack of resources. We all have limitation when it comes to budget and expanding to this new molecule. And this new molecule, we all know that does not come cheap. So understanding all of these barriers and where can we move forward in addressing these, and keeping in mind that we need to have three objectives when it comes to healthcare. So we need to make sure that healthcare is improved. We need to increase the value of patients' healthcare, and all of this needs to be measured into certain KPIs and outcomes. Now, we all know we know that we are a young nation. Now we are a young nation, but flipping the chart by 50 years, we are not going to be a young nation anymore. We'll be more into elderly, more with chronic diseases, more utilization of resources that would really have a higher budget. Now, this is a screenshot or snapshot on how this molecule is coming to the market and what are the percentage of expenditure when it comes to these molecules. Certain, we're looking now at cell gene and cell gene therapy and new innovative medications that would really have a skyrocket price tag. We tried to implement value-based healthcare at the Saudi Ministry of Health last 5 years. And alhamdulillah, we have been active in doing this. We have more than 18 value-based healthcare in different disease areas. I'm not going to discuss these models, but definitely the financial is very important, and this is what is being covered by NIPCO. But at the Ministry of Health, we reflect on the value, and this is where we tend to negotiate with the pharma industry, understanding what outcomes that we want to measure, how are we going to measure this in different settings. These are different areas that we are working in currently with the value-based healthcare. So we have different molecules. We have in genetic disorders, we have in oncology, we have in immunology, and in sickle cell diseases as well. Now, we know that value-based healthcare is a win-win situation for all parties, for all stakeholders. Starting from the heart of it, patients. Patients will have an easy access to new medications. Secondly, our providers. Our providers will get knowledge and see these new molecules, how are they working with their patients. For us as a payer and a governmental entities, we need to know, we need to limit the uncertainties when it comes to these new molecules, and we need to pay for what actually works. And for manufacturers, will be a hub for them to provide more and bring new innovative medications to the market. So any value-based healthcare or managed entry agreement have different subsets into it. So we make sure that, first of all, is the clinical outcome that we are going to measure. So this is one component of any value-based agreement between us and the pharma. And the services. So we make sure that, what do we mean by services? We need to make sure that we have a platform that is covering the patient. We need to make sure that we are following the patient from diagnosis until his management, make sure the selection of the treatment is being according to the guidelines that we are publishing. And this is where the beauty comes. If you do something and you needed to see it implemented, and we need to help our hospitals and our healthcare providers in reaching this. Alhamdulillah, Saudi Arabia was not on this map when it comes to value-based healthcare. It was only dominated by Italy, dominated by the UK. Now, alhamdulillah, we are in the 5th place by having more than 28 value-based currently active. And we have also published the first and only managed entry agreement policy that it is already released in the, on the Ministry of Health platform, and everyone is welcome to get a part of this. And this would really give you what is the phases of doing this, and what is whom the stakeholders are, and what are the rules and responsibilities for each one. Now, again, why did we need the local guidelines? And elaborating on what Prof. Musli was talking about, definitely it needs to be an evidence-based. We need to have a comprehensive guide to help our healthcare providers to help our patients and to take care of our patients and capture the journey from start to end. Address the local barriers, and we understand when it comes to diagnosis, we understand when it comes to certain medications. Encompasses the local data. We need to leverage the local data when it comes to reviewing or having our local guidelines. And this, again, will serve all stakeholders, from governmental until hospitals, healthcare providers, patients as well. So this guidelines, it's a beautiful collaboration between the Ministry of Health, between two of the famous societies, the Saudi Gastroenterology Association and the Saudi Society of Clinical Pharmacy. And it has a three-part. The first part was reflecting on the diagnosis and the management of IBD in adults, and we have captured as well in part 2 the IBD in children and adolescents, and the management of IBD in pregnancy. The methodology, we went to adopt and adapt, so we did not reinvent the wheel. Again, we captured and we have viewed different most important international guidelines, as been mentioned by Professor. We have reviewed the ECCO, AGA, ACG, and BSG, so we have addressed these guidelines. And we have multiple waves. So the first wave was to develop the recommendation of the statements. Second wave was the development of the statements. And then the third wave was the voting. So we have viewed the statements. We have modified the statement against what we needed. And then the voting. Last thing is the manuscript, which was for us the most important part to have something to be published. So the strength of the recommendations, everything has been captured in regards to the evidence base and the consideration when it comes to these recommendations. And these statements has been, voted as very strong when it comes to more than 80% of the committee or the scientific committee voted for. And when it comes to only strong, when it comes to only 50% agreed on these recommendations. So as a result, we have came up with the 78 statements. 19 were focused on the diagnosis approach for ICD and UC. 4 statements on the disease classification, and most importantly, 55 statements were around the treatment of UC and CD. Each statement was supported by the quality of evidence and strength of these recommendations, and there were a follow narrative part that describes these statements and further elaborative points. Alhamdulillah, this guidelines has been published in the Journal of Saudi Gastroenterology. And then what are the future? We have also plans for the future points to be addressed. So we are going to have a surgical management of IBD. We're going to reflect on the management of emergency conditions such as ACOC and small bowel obstruction due to complications of CD. Guidelines for the integration between primary, secondary, and tertiary healthcare, which is very important when it comes to the patient healthcare and the ecosystem. Now, as we mentioned, that the diagnosis of IBD in adult has been covered. The management of IBD in pregnancy has been covered. Now, coming soon, inshallah, will be the diagnosis and management of IBD in adolescents and children and adolescents, which is, inshallah, coming very soon. So as Professor was highlighting on the future plan led by the Ministry of Health, so we are already established nationwide centralized IBD registry, and it will be coming very soon for different identifying the hubs that we are going to start with as a wave 1. We have designed a comprehensive referral pathway for IBD, as we've mentioned. We need to capture it from healthcare, primary healthcare, secondary and tertiary within the ecosystem. And developed a comprehensive treatment pathway for IBD. Where are we now? Again, this has been covered that we have already standardized the care plans. We have established measures and goals, KPIs that we are going to reflect on, establish methods to measure our KPIs that will help us taking the data from our registry that would really reflect and get you a full overview of the patient journey. Identifying the gaps in the IBD care thoughts and assessment, and this is where our registry will come in hand. Design intervention to close gap. Again, this will be a second after having identifying the gaps. And by this, I end my talk. Thank you very much.
Thank you very much for our speakers, Dr. Mahmoud and Dr. Hajar. Any questions from the audience? Well, it seems that everybody... Yes, please. Anybody has a mic to give to the doctor?
So, can you repeat the question again?
You mentioned you depend on four international guidelines: ECHO, American College, and the British. What was the most guidelines that you felt that it fit Saudi guidelines?
So we've really reflect on everyone. So we have seen that there is similarity from different international guidelines, and this is where we captured this statement from. I cannot decide which one was the most important one or which was the added that closer to us, but I think we have captured.
I think I will come to the initial subject. There is a committee, right, for the guidelines? How many percent?
Yeah, so we're about 12 to 14 individuals
14, yes.
between physicians and clinical pharmacists.
And everybody had come through all the guidelines?
Yes, so the process was, at the beginning, we did a very comprehensive review of all the guidelines. This took some time, actually. Every single statement made in all of these guidelines in each area, starting from diagnosis to treatment, was reviewed and compared across all four. And then we selected from these statements a unified language that reflects what we think is adoptable in our society. And then we went through one by one. After that, we created the statements. And then like Dr. Hajar said, we voted on them and we graded them according to strength. So we can't really say that we looked at one guideline more than other. It was really a composite of all of them.
Thank you.
In this session, thank you very much for your attendance, and we'll move on. Thank you.
All right, I think we'll go ahead and get started with our next session. It is my absolute pleasure and honor to introduce our next speaker, Professor Peter Irving. He has been trained in medicine at Cambridge University and the London Hospital Medical College, qualifying with distinction in 1995. He conducted his research at the Barts in London on inflammatory bowel disease. He's an internationally known expert in inflammatory bowel disease and leads an IBD service at Guy's and St. Thomas's Hospital, where he also runs a large research and clinical trial program. He has previously sat on the IBD section of the British Society of GI and also chaired the education committee of the European Crohn's and Colitis Organization. Without further ado, I'd like to introduce Professor Peter Irving. Go ahead.
Morning, everyone. Thank you very much. It's a pleasure to be back in Saudi. It's been a while. It's certainly as hot as I remember, if nothing else. Welcome to this symposium in which we're going to talk about. We're going to talk about, if I can get the slides to move forward. One moment. Am I pointing the right way? Can I use that button there? No. Feels like it's frozen here because not even this button is working. Ah, lovely. Thanks. Yeah, lovely. Okay. So here are our disclosures. And we're going to be talking today about a drug that's now available in Saudi. It's the first anti-P19 antibody licensed for the treatment of Crohn's disease, and it is, of course, risankizumab, also known as Skyrizi. So in the next 40 minutes or so, I'm going to talk a little bit about the clinical trial program, particularly focusing on some of the endoscopic and clinical data from the phase 3 program. We're going to importantly look at safety data because, of course, whenever you have a new drug, safety is vitally important. And then we're going to talk a little bit about the dosing schedule. So I'm going to start off with a case. This is a patient of mine. She is originally Algerian. She was diagnosed with Crohn's disease back in 2011 with colonic Crohn's disease. And as was the norm at that time in the UK, we had a sort of rapid step-up strategy. So she started on azathioprine because of steroid dependence. Despite the azathioprine, she had ongoing need for steroids, and therefore she started an anti-TNF fairly soon after diagnosis, which of course is when drugs work best in Crohn's disease. And she did okay on this, but required dose escalation to weekly adalimumab after 6 months because she wasn't doing well. Because of ongoing problems, despite adalimumab, we decided to swap her over to infliximab. And again, she had an initial response, but as we've been hearing earlier today, like many patients, she lost response over time, despite increasing her infusions to 10 milligrams per kilogram. And indeed, by the time I saw her in August 2013, she'd had a recent short admission and had a further course of steroids, and still she wasn't doing well. So you can see, despite all of this, maximal doses of anti-TNF, her CRP is still elevated. We had no other biologics available to her at that time, and I was just starting up our clinical trials program at that time, and this, in fact, was the first commercial trial I did in Crohn's disease, and it was, of course, the trial of risankizumab, although back in those days it was a phase 2 study, and it wasn't even called risankizumab in those days. It was a Boehringer Ingelheim drug, and she was one of the first patients into the study. And these pictures here are the pictures from her endoscopy at enrollment. You can see this study used the CDEIS as opposed to the SCSCD, but you don't need to look at the score to see that she's got fairly marked ulceration. It's probably easiest to see on that right-hand slide there. She's got really quite impressive ulceration, and I can tell you it was fairly extensive, and this is reflected by the fact that you can see her albumin is low, she's anemic, and not surprisingly, her inflammatory markers are high. After the first 12 weeks of treatment, she still had some active disease, although she did have some improvement. Her CRP had fallen, her albumin had gone up, but she wasn't quite there yet. And so the protocol at that time allowed open label extended induction with a further 3 doses of 600 milligrams. And by the end of that, so by the end of December, about 24 weeks into the study, she felt well. And she didn't just feel well, she felt properly well. You can see her CRP had normalized, her hemoglobin had normalized, her albumin had normalized, and so she then went into the open label extension from the phase 2 study. This is the only picture I've got from her colonoscopy at a year, and you'll have to ignore that little adenoma that's sitting there, which is why the person who did this colonoscopy took the picture. But for the trial, it was all videoed. But look at the background mucosa, and you can see there that she's vastly improved. All that ulceration has gone away. So that's a year into treatment. She's feeling great. Her mucosa is healed. That, of course, was June 2015. And now I'm going to flip forward 8 years to earlier this year. And this is how she's doing in February 2023. She's still taking subcutaneous Skyrizi. Her CRP is normal. You can see her fecal calprotectin is 19. Her colonoscopy is completely cleared, and she's doing extremely well. So she's now been on 9 years of treatment. This is what her colon looks like now. You can see that scarring in the bottom left-hand side, but otherwise you wouldn't know that she has Crohn's disease at all. And I think this is very reassuring to me. That this new drug, actually I have a patient who's been taking for 9 years, and it took her from this anti-TNF resistant marked extensive ulceration through to complete mucosal healing nearly a decade later, and she's tolerating it extremely well. So what's new about Skyrizi? Well, of course, it is a different mechanism of action, and it all relates to IL-23. I'm not going to go into the immunology of Crohn's disease, not least because we don't have time, but also because I'm not an immunologist. But IL-23 is important not only in terms of the adaptive immune system, so we know it's important in terms of the Th17 pathway, but it's also important in other parts of the immune system, the innate immune system. And so when we think about things like gamma delta T cells or innate lymphoid cells, particularly ILC3s, as you see over on the right-hand side there, we see that IL-23 has a number of effects in terms of the etiopathogenesis of Crohn's disease. Now, of course, we are not naive to blocking IL-23 because we've been doing it for years using this drug, ustekinumab. Ustekinumab, of course, blocks P40, which is part of both IL-12 and IL-23, and therefore, of course, ustekinumab has effects on both the IL-12 and IL-23 pathway. As we've discussed, IL-23 chiefly important in the Th17 pathway, whereas IL-12 is different and has effects on the Th1 pathway. And therefore, at least in theory, there may be an advantage in blocking P19, which, as you can see, is only part of IL-23 and not part of IL-12. And indeed, there are several drugs out there that are either in late phase development or are licensed. Risankizumab, of course, licensed in Crohn's disease, mirikizumab, licensed in some parts of the world for ulcerative colitis, and several others going through the development program. Why might this be advantageous? Well, again, if you ask an immunologist, they can always come up with an answer for this. And they'll show you a diagram like this, and they'll say, well, if you block IL-12 as well, then it's going to have this effect and this effect and this effect, and therefore blocking IL-23 alone is probably going to be advantageous. Honestly, I think if you ask an immunologist to explain anything they can, they'll always come up with a way that something's going to work. And to my mind, this is interesting. And when we see bits of science that support these bits of evidence, then again, it supports that. But actually, what I want to know is, in clinical practice, is P19 blockade better than P40 blockade? So we'll come back to that a little bit later on. Risankizumab is, of course, already licensed now in 3 conditions: psoriatic arthritis, psoriasis, and Crohn's disease, and therefore there is a growing experience in the number of patients who've been exposed to it and the patient years of exposure. And those numbers that you see on the bottom right there, of course, are out of date now. About 250,000 of patients exposed in December 22, and it will be vastly more than that already. And I think the thing that we take away from this is we have a growing safety experience of this drug. And again, we'll talk about that a little bit more later on. So let's have a look at the clinical trial program and why this drug is now available to us. And we're going to talk about first the induction studies. Now, I'm afraid these slides are always difficult to digest, but I'm going to reassure you that you're familiar with this trial program because you've seen it many times before with other drugs. So as is common nowadays, there are 2 induction studies here, Advance and Motivate. They're 12-week induction studies. And patients who respond to induction are then able to go on to the maintenance study where they are re-randomized to one of 2 doses of Skyrizi. And we're going to concentrate on the 360 dose outcome here because that's the licensed dose, or placebo. So in the maintenance part of the study, it's basically a withdrawal study. Remember, all the patients in maintenance have already responded to the drug, and then they're being re-randomized to continue drug or to withdraw drug. One of the advantages of having two induction studies is that you can start to look at different things. And indeed, AbbVie did this in several of their programs, including the risankizumab program. So the advanced study on the left contained a population of patients who had failed conventional therapy and a population who had failed biological therapy. And the Motivate study on the right, a slightly tougher group of patients because they'd all failed biological therapy. And I think it's always important when we're looking at clinical trial programs to ask ourselves the question, are these the patients that we treat in our clinical practice, and who are these patients who are in these studies? And there are several ways that we can do that, and I've highlighted the boxes here that I think are probably most important. The first is disease duration, because we know absolutely that the longer the disease duration in Crohn's disease, the harder the patient is to treat. One of the things that we've been talking about for years is getting patients early, because that's when they respond to treatment best. If you look at the population, the mixed population in Advance, you see that the disease duration is 8 to 9 years. In Motivate, that tougher population, it's about 11 to 12 and a half years. These are a difficult, long-standing group of patients to treat. And the other thing, of course, that we think about when we're thinking about how hard are patients to treat is what's their exposure to previous therapy. Well, I said in Advance about 40% of the patients were conventional therapy failures. The rest of them had failed biologics, and about a third of them had actually failed 2 or more biologics. And again, ask yourself, how difficult are those patients to treat when they've failed 2 or more biologics? Go over to Motivate, the purely biologic failed population, and slightly more than half of them had failed 2 or more biologics. The data in the middle, I think that just tells us that this is a group of patients with active Crohn's disease that are very similar to the ones that we see in most registration studies. What were the endpoints? Again, a lot of information on this slide, so I'm just going to direct you to the 2 co-primary endpoints. The first is at the top there, clinical remission. You'll see there's 2 definitions of clinical remission. One was used in the US using the CDAI, and the other was used outside the US using the PRO2. I wouldn't get too bogged down in this. They're essentially very, very similar things. They're just measures of disease activity. And then down at the bottom, the first of the endoscopic endpoints was the co-primary endpoint, and that's endoscopic response. And again, this is an endpoint that we've used many times before in trials, and it's a drop in the SCSCD of 50%. So I would say pretty standard endpoints to look at. A number of mucosal endpoints were looked at, and I think that's because we're recognizing increasingly the importance of mucosal healing. I've just told you about the co-primary endpoint at the bottom there, endoscopic response. That was probably the least stringent of the endpoints to reach, but the one that is most commonly used in clinical trials. But if you look right up at the top there, mucosal healing, ulcer-free endoscopy is probably really what we're trying to aim for, ideally, in our patients with Crohn's disease. It's not necessarily easy to reach, getting an ulcer-free, and that includes no aphthous ulcers as well. That's a difficult endpoint to reach, but it is a goal that we think is probably worthwhile getting to if you can get there. So here are the results. On the left, Advance, the mixed population. On the right, Motivate. The first 2 bar graphs relate to the 2 different measures of clinical activity, and these are the patients that reach remission. If you look in that mixed population, it's about 45% of patients hitting remission by 12 weeks. Remember how tough this population is to treat? I think that's a pretty good outcome. And remember, this is remission, and probably about another 20% of patients on top of that will have responded as well. You'll see that there are good deltas over the placebo there of about 20-odd% or so. And if you then look at the endoscopic response in Advance, again, you'll see 40% of patients with endoscopic response with a lower placebo response, which of course is what we'd expect, because endoscopy is a harder endpoint to achieve, and therefore you tend to get a lower placebo response. If we think about the biologic failed population, we remember these are a tougher population to treat. That delta over placebo, depending on which of the bars that you look at in terms of the clinical outcome, is either similar or a little bit less than we see with the mixed population, and the endoscopy delta probably is a bit less. To me, this doesn't necessarily mean the drug doesn't work as well in the biologic failed patients. It just reminds me that those patients take longer to get better, and I think that's true with all drugs that we use. If you have difficult Crohn's disease, it takes longer for you to hit the harder endpoints, particularly the mucosal endpoints. If we split the patients up by the true biologic naive and the biologic failed population in advance, so that's the center graphs there, you see, I think, again, what you would expect to see, that bio-naive patients respond a bit better, and you see the delta over placebo there is greater than the delta over the biologic failed patients. And again, to me, this just rings true. I know these are harder patients to treat, and I don't expect them to respond quite as well or quite as quickly. They're going to take longer to get better, and perhaps fewer of them will get better in the end. And we see something very similar with the endoscopy endpoint. Look over on the right-hand side there. Again, sub-analysis of advanced, looking on the left at the biologic failed patients and on the right at the non-biologic failed patients. And not surprisingly, at 12 weeks, more of those conventional therapy failed patients are hitting that measure of endoscopic response, a drop in the SCSCD of 50% by 12 weeks. Again, I think the other thing I take away from this, and I am a little bit wary about comparing across clinical trials, is particularly in that biologic failed patient population, that delta of 37% over placebo there and an absolute number of 50% achieving endoscopic response, I think is encouraging. But let's put that to bed for the moment before we start thinking about comparisons with other medications. We've talked a lot in recent months about rapidity of response, and that's partly because we now have JAK inhibitors, and we know that JAK inhibitors are rapidly acting molecules. We do have some data here on how quickly risankizumab works in Crohn's disease, and it starts at week 4, and you can see by week 4 there is already significant separation in both of the induction studies between the blue line, that's the patients who received risankizumab, and the grey line, that's the patient who received placebo. And I like to see this because, of course, for my patients, I like them to get better as quickly as they can. But to me, it's not the most important outcome. Particularly in Crohn's disease, what I really want to know about is what's happening in the long term, because I think that's where the damage happens in the long term. So this is good to see, it's reassuring to see, but I'm actually more interested in what happens at a year, at 2 years, at 3 years, and if I think to the patient I presented at the start, at 9 years and beyond, because that's where you're really going to win with these patients. I talked about ulcer-free endoscopy as probably being something that the hardest mucosal endpoint we aim for in life. And again, just to show you that a reasonable proportion of patients actually achieve this endpoint by week 12, which in itself I think is an impressive outcome. Again, you remember the patient that I had in the phase 2 study. She took until week 24 to get there, but even by week 12, somewhere between 15 and 20% of patients appear to be reaching this endpoint. And of course, the other thing that's important is what about patients who are on steroids? And this is just a sub-analysis of the steroid-exposed patients. And what I would take away from all these different bars is that risankizumab in induction works in patients who are on steroids as well as patients who aren't on steroids. Briefly, we're going to talk about safety here. We'll talk about it a bit more at maintenance because I think that's probably where we're most interested in it. And I think, as one would expect, knowing that drugs like ustekinumab have really a very favorable safety profile, I'm not surprised to see that risankizumab and indeed the other P19 inhibitors also have a very acceptable safety profile. The thing I always start to look at first here are things like severe AEs and serious adverse events, and you can see when you look at the comparisons between placebo and drug, there is no signal at all that drug is doing worse than placebo, and in fact, if anything, the patients who are receiving drug are doing slightly better than patients receiving placebo, which we'd expect because their disease is getting better, and so they tend to do better. So let's go on to the maintenance studies. I'll just briefly remind you that the way this study works is patients from the induction studies who have a response are then able to be enrolled into the maintenance study, where they are re-randomized to one of 2 doses of Skyrizi or to placebo. Remember, they've all received drug, they've all responded, and we're going to concentrate on the top line there, the 360 dose, because that is the licensed dose for Skyrizi. I won't go too much into this. This is really just looking at what happens to the patients between induction and the start of maintenance. And if you look just at the top lines there, you'll see that, of course, because they've responded, their CDAI has dropped, their SCSCD has dropped, but they're not completely normalized. Although the mean CDAI is in the remission area, you'll see the SCSCD is still elevated. And it's not surprising, because these people take time fully to get better. And those endpoints are exactly the same primary endpoints as we saw at induction, co-primary endpoints of clinical remission by whichever definition you use, or endoscopic response. I'm not going to show you the secondary endpoints. What I am going to show you is the results. Concentrate first on the blue bars. These are the patients who've received Skyrizi, and this is week 52, and they've been on 8 weekly subcutaneous injections of 360 milligrams. And you'll see of the responders at week 12, about 50% of them are in clinical remission at week 52, and nearly 50% of them are in endoscopic response at week 52 as well. So I think that's pretty encouraging. But you can't look at this graph without noticing something else, and that is the placebo response in the clinical remission. It's enormous, isn't it? 40% clinical remission in the placebo receiving patients. There is, of course, a reason for that, and in fact, we've seen something quite similar before with ustekinumab, and that is that these patients have all been receiving drug and, up until the start of the maintenance trial. They stop receiving drug, but the drug keeps working because they've still got it on board. And in fact, you only start to see any separation in many of the outcomes between the placebo-treated patients and the drug-treated patients at about week 24 of maintenance. So that separation only starts then, and that's why still at when you think about the slightly easier to achieve endpoint of clinical remission, there's not much separation at week 52, but if you then go over to the harder definition, that's endoscopic response, you're seeing greater separation there. I think there's one more important takeaway to think about with a very high placebo response like this, and that is when you put this drug into network meta-analysis, which uses placebo as the anchor between trials, it is not going to perform well because of that massive placebo response. And it's just a caution about comparing between drugs using network meta-analysis. This is splitting patients up by basically the biologic naive and the biologic failed patients. And again, what you see here just reinforces what I've said. In the biologic failed cohort, who are the tougher cohort to treat, you see greater separation between drug and placebo. And that, of course, is because they're more likely to relapse quickly when you withdraw the drug. And here we look at some of those harder endpoints, and again, I think it just shows us that when you start to look at harder endpoints such as ulcer-free endoscopy, again, you see greater separation between drug and placebo because these are harder endpoints to reach. Why are we interested in mucosal healing? Well, it's really a whole talk in itself, but there's a little bit of data from Fortify that helps us to understand this, reminds us why mucosal healing is important. Now, blue and gray here don't equal drug and placebo. Instead, they equal mucosal healing at week 12 and no mucosal healing at week 12. So blue is mucosal healing, grey is no mucosal healing, and look what happens to these patients by week 52. And you can see that if you had mucosal healing at week 12, the blue bars, you were less likely to end up in hospital with your Crohn's disease, you were less likely to end up having surgery due to your Crohn's disease, and in fact, you were less likely to go into hospital or have surgery for anything at all. And it just reminds us, and I echo what Miguel said earlier here about the people who do well are the people who get into a proper remission, and particularly those who get into proper remission earlier. I think this speaks to that. The better healed the mucosa, the better the patient, the better the long-term outcome. So this is just a slide to reinforce that message of longer-term mucosal response. This is a typical patient from Advance. As you can see, he started off with pretty active disease there. He had an SES-CD of 27. By week 12, that had dropped to less than 13. His CDAI had normalized. You can see there's still a bit of active disease there, but by week 52, his colon had pretty much completely healed. We don't know the exact score, but it's less than or equal to 4, and effectively for Crohn's disease, that means an almost normal mucosa. And again, it just reminds us that week 12 is not the end of improvement when it comes to treatment with drugs in Crohn's disease, and this is true with Skyrizi too, that you can get ongoing improvement beyond there, and in fact, you often do. We talked a little bit about steroids in induction, but actually, of course, it's the ability to withdraw steroids in maintenance that really matters. Steroid-free endoscopic remission is shown on this slide here, and by steroid-free, we mean no steroids for about 3 months prior to the end of the study. So it's properly steroid-free, and you can see that of the total population of patients who've responded to risankizumab induction, endoscopic remission is steroid-free in nearly all of them, about 96% of them. So again, reassuring that the drug is working. It's not just a reliance on steroids to hit that endpoint. And then again, really just flipping back to some of those harder endpoints. And I'm going to concentrate on one I haven't talked about so far, but that's the one on the far right here. That's an SES-CD score of 0 to 2. For those of you who don't use the SES-CD score, which I can understand, it's not the easiest score to use in everyday practice. To get an SES-CD score of 0 to 2, you are not even allowed a single aphthous ulcer. A single aphthous ulcer will give you an SES-CD score of 3. So this is just about as good as you can get. And you can see that patients who achieve that at week 12 tend to maintain it, and many of these other endoscopic endpoints at week 52. And this just really reinforces the point I made before. I would forget the placebo line here. What I want to show you on this graph is what happens to the patients who continue on Skyrizi after induction. So that's the solid blue line. You'll see if you take the population, the SES-CD score at the start was 14. It drops to 8.5 at week 12, but it keeps going down. It keeps going down to 4.4 at the end of week 52. So again, I think this is encouraging that we see ongoing improvement from week 12 to week 52. I said I'd talk a little bit more about safety, and here is some more in-depth safety data. You know, I cannot stress enough whenever we have a new mechanism of action, how important it is to consider safety data and to look at it in detail. We only get a certain amount of information from the clinical trials because we only tend to have follow-up up to 12 months within the trial program, but we then get the open label extension data as well, and of course we get the data from the real world as well. But this is the 12-month safety data, and I think again, if you look at the top right at serious infections, you'll see there's no difference there between the placebo-treated patients in maintenance and the drug-treated patients. And if you look down, for example, to herpes zoster, which is a common problem in our patients with inflammatory bowel disease, again, no herpes zoster signal there. And if we go on to some more in-depth data, the only difference you see, and I find this reassuring because it tells me the data are real, they're not made up, is that injection site reactions are more common with the drug than with placebo. So again, I think I would extrapolate from my knowledge that ustekinumab, which has a similar but subtly different mechanism of action, is in my mind a very well tolerated drug. I would extrapolate from the other P19 antibodies, from the data in psoriasis, albeit at a different dose, and psoriatic arthritis. And I would put all of this together, and I feel pretty reassured that P19 antibodies, Skyrizi included, are going to have a safety profile that we will find acceptable, and is probably going to be very similar to that of ustekinumab. So as I come towards the end, I'm going to finish with another case. This is another gentleman of mine, 28-year-old man with ileocolonic Crohn's disease, diagnosed in 2018. If you look on the right-hand side there, you can see he's got really quite marked ulceration in his colon. He also had terminal ileal disease on an MRI and a high CRP. He started steroids immediately, but because of the severity of his disease, we also pretty rapidly put him onto anti-TNF as well, in this case adalimumab. And because adalimumab is a good mechanism of action, it works in Crohn's disease, it wouldn't surprise us to hear that after 6 months he's doing pretty well. He's got marked improvement in his colonic appearances. I don't know how well it projects. Yeah, pretty good. You can see he's still got a few little ulcers there at the bottom right, but we're not worried about that really. We know that that's probably unlikely to represent severe Crohn's disease. He's doing well, and you can see his adalimumab level is not bad, maybe slightly below where one would want it thinking nowadays, but not bad anyway. And he does well for a year. Unfortunately, he starts to lose response, and he doesn't tell us. And then by the time he comes back to see us again, his disease is really quite active again. We do a repeat colonoscopy and an MRI, and his Crohn's is back. And we do therapeutic drug monitoring. And this is one of those cases where therapeutic drug monitoring is easy to interpret because his drug levels are 0 and his antibodies are high. You're never going to rescue this by increasing the adalimumab. You're never going to rescue it by adding in an immunomodulator. You need to change track. And that's exactly what we did. And the logical change here probably is to ustekinumab, which is what we gave him next. And again, ustekinumab's a good mechanism of action. It's a drug that works. And so it didn't surprise us that he did well. We repeated his colonoscopy about 6 months later, and you can see from what I've written here that, again, just a few aphthous ulcers around, but really not much to see. And again, he did well for a couple of years before developing recurrent disease. At that point, we're left with either vedolizumab or infliximab, and because he developed anti-adalimumab antibodies, we went for vedolizumab first. We gave him infusions at week 0, 2, and 6, and because he had Crohn's disease, we were also able to give a week 10 dose, but it did nothing. And again, not wholly surprising. Vedolizumab probably doesn't work brilliantly in this situation. So we went to our last option available, which was infliximab, which of course we gave with azathioprine because of his past history of antibodies. And unfortunately, the azathioprine gave him pancreatitis. We then used thiaguanine as an alternative immunomodulator. Either way, none of it mattered because he had an infusion reaction on his 5th dose. So now we've run out of drugs. So what did we do next? Well, luckily this was the middle of last year, and AbbVie had a patient access scheme for patients such as this. And to get into that patient access scheme, you had to have failed 1, or in this case 2 anti-TNFs, ustekinumab and vedolizumab. You had to have failed all 3 mechanisms of action. But in those patients, we were allowed to treat with risankizumab, with Skyrizi, and that's exactly what we did. And he had a partial response to 3 induction doses at weeks 0, 4, and 8. And so we were able to carry him on subcutaneous therapy, 8 weekly, 360 milligrams. And indeed, he continued to improve. And over time, his HBI normalized, his CRP fell, his fecal calprotectin normalized, and now his colonoscopy is normal. So I'm going to just draw out 2 things from this. The first is, that this patient had failed ustekinumab. And that, I think, is one of the key questions. Can you use P19 in ustekinumab failures? And I haven't shown you the data, but about 20% of patients in the clinical trial program had failed ustekinumab. And if you want to hear more about our personal experience of this, we treated about 35 patients in the patient access scheme, all of whom had failed ustekinumab. I can tell you, just like in the clinical trial program, we saw response in those patients, in a reasonable number of those patients. So that's two bits of evidence that reassured me that maybe P19 is going to be, maybe it's not fair to say better. P19 might work in patients who are P40 ustekinumab failures. But there is, of course, another bit of evidence, which I'm not able to show you today, but I'm able to tell you about it because it's now been released in a press release. And if any of you are going to Copenhagen in 3 weeks' time, you're going to hear about this. And that's the results of the sequence trial. So the sequence trial is a big 500-patient trial in which patients who'd failed anti-TNF therapy with Crohn's disease were randomized to receive either ustekinumab or Skyrizi. And there were two outcomes. There's a week 24 outcome, which was clinical remission, and then a week 52 outcome, which was basically endoscopic. The week 24 outcome, ustekinumab did well. 40% of patients were in clinical remission at week 24. For Skyrizi, it was 60%, an extra 50% of patients. And if you look at the endoscopic outcome at a year, twice as many patients achieved that outcome with Skyrizi compared with ustekinumab. And in reality, for many of us, as we've just been hearing, we will still be using anti-TNF a lot first line just because it's cheaper. And so for me, in those patients in the post-anti-TNF situation where you're making a choice between your different drug options available, there's vedolizumab, there's ustekinumab, there's Skyrizi, and maybe soon for you, upadacitinib as well. I think this is a really helpful trial that shows us that it does appear to be quite a differentiation there between Skyrizi and ustekinumab. So I'm going to finish off just to remind you about the dosing. It's pretty straightforward. There are 3 intravenous infusions of 600 milligrams given at week 0, 4, and 8. And then you move over onto subcutaneous injections just once every 8 weeks, so that's 6 a year. You'll notice here that in the little blue box, the little blue circle, by the subcutaneous dosing, there isn't a syringe. But there is, in fact, this little gadget, and that's called the on-body injector. And that's because you will, if you're sharp-eyed and you're reading, you'll see that the dose of risankizumab requires a volume of 2.4 milliliters. So that's actually a reasonable size volume. And as has been done with other drugs in the past, it's been realized that rather than trying to give that volume in a syringe, which is uncomfortable, it's much more acceptable for patients to use a little gadget like this, which is called an on-body injector. And again, this is something that's available here in Saudi already. It's not available to me in the UK yet. I can't wait to get it. I'm sure in the States you've got it, yeah. And it's there's a little dummy one for you to play with out on the AbbVie booth, so go and have a look at it. It's pretty straightforward to use. The patient feedback that I've heard from other countries, from colleagues, is pretty good. Miguel, do people deal with it okay? Yeah, okay, so Miguel, who's got far more experience with this than I have, is giving a nod there, I can tell you. So it's pretty straightforward to use. It's single use only. It's disposable and very straightforward. So a nifty solution, a good solution, I would say, to a problem that AbbVie have come up with there. So to summarize, Skyrizi is the first IL-23 inhibitor available for use in Crohn's disease. I hope I've shown you that the endoscopic data and the symptom data support its use in Crohn's disease, both in bio-naive patients and definitely in the anti-TNF failed patients as well, and that the safety of the drug has been demonstrated and appears to be reassuring given the limited amount of data we have. So we might have a couple of minutes for questions. If you want to hear more, there's another symposium a little bit later on, and there is a booth out there, and I'm doing a Meet the Expert session later. But I'll finish there. Thank you.
Thank you, Professor Irving. I think we're a little over time, but we will take one question. I think.
Thank you, Peter. Wonderful presentation. Just a couple of challenging questions for you.
Okay.
Is obviously, like you said, immunologists can explain for you anything that you want. Initially, etanercept would work, but now, oh, it doesn't work. It can exacerbate Crohn's disease because of this and that. Is the P19 inhibitors better than the P40, or did the P19 inhibitors get the dose right? Because I think the dosing is significantly higher. Obviously, in the guselkumab trial, they also upped the dose because they learned that you can give more and it's safe. And a indirect proof of that is the placebo response that is phenomenal, that drags behind, which is even better than the single 6 milligrams per kilo given for ustekinumab. That's one question. The second question, if I may, is are you alarmed by the MIRI adverse events in the UC trial? Because there was some colorectal cancer patients, herpes zoster patients, and the mirikizumab.
In the mirikizumab trial. So I'll start with that one. There is a little bit of a zoster signal, isn't there, in the MIRI trial? I agree, and I think that we'll need to wait to see how that pans out. But honestly, I'm used to zoster, and now that we have Shingrix availability increasing, I think it's less of an issue. I think the cancer patients in the MIRI trial, most of those actually are pre-existing colon cancers that were missed during screening. So that specific thing, no, I'm not worried about. In terms of dosing, and let's go to sequence, because that's the crux of the problem and the answer here, isn't it? Is risankizumab better dosed than ustekinumab? Well, I would take you to Stardust, where bigger doses of ustekinumab were given, and it wasn't found to be particularly more effective. And my experience of giving extra doses of ustekinumab, 4 weekly dosing, is it's not amazing. And there's something else that's interesting about the P19 antibodies, and certainly we've seen this in UC, is that you hit that ceiling, and sometimes you actually get a dropping off of response as you push the dose higher with P19. Whether that's real or not, I don't know, but I've seen it in 2 studies now. So that doesn't quite answer your question. It suggests that probably we've got the right dose of risankizumab, but I'm not convinced that ustekinumab is underdosed, actually. And again, if I look over at psoriasis as well, and I see the difference between P40 inhibition and P19 inhibition there, I'm encouraged that actually I think this signal might be real in Crohn's disease. Whether it's real in UC as well, I don't know. I mean, I think that's a separate disease and might have a different answer. But I'm very encouraged, particularly by sequence, and I'm looking forward to seeing that presented fully at UEG.
Thank you, Professor Irving, and apologies as we are out of time, but we'll have some other opportunities during the meeting to ask more questions and interact regarding Skyrizi. Appreciate it. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. It's my pleasure actually to be with you today and actually during this very interesting and very wonderful arranged IBD conference. I'm going to be chairing this session, which is actually a state-of-the-art lecture by 2 of my dearest colleagues that I worked with them during some of the transformation kind of effort that I was trying to help in. Today we're going to have a combined Saudi Gastroenterology Association and the Saudi Health Council lecture about integrated care model of IBD patient, the insight of the health care transformation. And our speakers, Professor Majid Al-Madi, everybody know he's actually the president of the Saudi Gastro Association, and he is a dear colleague to all of us, and professor in medicine and gastroenterology, and also in the King Saud University. Professor Majid, I can't, say more that I actually learned a lot from him during transformation consultations when I was working. His management in health is something that we all kind of learn from. And also our second speaker is a person that is very close. We worked in a lot of strategies, and he was wearing a lot of hats actually, from Majlis al-Dhaman to now Majlis al-Sahhi al-Saudi. Dr. Abdulaziz Rabi'a is a family medicine consultant, the Ministry of Health, and General Director of the National Health Policy and Health Economics. I welcome both speakers, and we'll start first with Prof. Majid and then Dr. Abdulaziz.
Bismillah ar-Rahman ar-Rahim. Thank you for having me, and جزاك الله خير أبو خالد. الله يجبر بخاطرك. ما أظنك تعلمت مني حاجة. But we're here going to give you a small talk, share some insights about healthcare systems, and we're going to zoom out from the genetics in the morning to drug monitoring to biologics and therapy to healthcare systems and pathways. So it's like a bird's eye view of what happens in clinical practice in reality. So we're going to speak about integrated care models, and specifically about integrated care models for patients with inflammatory bowel disease. We're going to share some of the literature and insights on how people approach systems of care. After that, Dr. Abdulaziz is going to take you about the Saudi Health Council as an overview, the healthcare transformation and how it should affect patients in general, and how we can utilize that change to the benefit of our patients. And where are the gaps, and where can we work together to improve the care of our patients? So integrated care specifically talks about bringing the system of care, whether it be diagnostics, therapeutics, follow-ups, and monitoring, from a fragmented system to a patient-centered system. So instead of the patient going around looking for an appointment for a radiology appointment after 1 year for an MRE, which we have in our institution, and then they run out of the medication and say, come back in 2 weeks and hopefully you're going to get your adalimumab. This system is designed to be flawless. It rotates around the patient and gives better outcomes. And why choose IBD for such a model? Our patients are young. They have a chronic disease. They have complications down the road. The current touch points with the healthcare system usually happen when crises happen. So when you have an inflammatory attack, hospitalization for surgery, complications, and it shouldn't be that way. So you're working mostly on stopping out fires in crisis mode. And if you had a better lubricated system, it would be a more smooth journey for both the healthcare provider and the patient. And in the intervention, usually does not involve a single healthcare provider. So patients usually interact with dietitians, psychiatrists, surgeons, nurse care practitioners, pharmacists. All of those are fragmented, siloed systems, and the whole idea of integrated care is having that system rotate around the patient. There are a number of models, names, designations for these models. Some people call them IBD programs, centers, medical homes, which is an interesting concept that Miguel brought to the literature and we're going to talk about, and centers of excellence. Some of these are blurred and not pretty clear what they really mean, and there's no standard definition of how these work. They do come with a cost. The cost is time, setting up these systems, effort and commitment, as well as organizational change and culture change. All of these do come with a cost and are barriers. And maybe even focusing down your practice, so instead of seeing a lot of patients, you really focus on IBD specifically. And I don't think we lack that in our healthcare system. We already have people who are specialized in IBD, and that's their passion. But what does this commitment bring? It brings in better patient outcomes, better patient satisfaction, research opportunities, lowering indirect costs, and definitely there are going to be upfront costs to set up the system, but down the road it's going to pay off as an investment. So if you were going to embark on such a journey and try to get a pathway done, you usually have to have an alignment of the stakeholders that are involved. You have to sit down with your pharmacist, your institutional leaders, say, okay, we're going to need such resources. You're going to have a look at the risk assessment. If you take on too many patients, too little patients, are you going to open a fellowship program? You're going to have a certain number of flow. All of these things need planning. Then mapping that plan with a timeline, with endpoints, with milestones, and securing the commitment, whether it be financially or politically within the institution or on a macro level, as we're going to see on a cluster level, or even on a healthcare level across healthcare sectors, which we're going to see in the second half of the talk. And then even rolling out that program needs iterations and tweaking. So just initiating a program, you're going to have to keep on monitoring and changing according to the system you have and the outcomes. And hopefully that would succeed. Definitely there are barriers. The first thing when you talk to the government, it's going to be funding. So money is an issue, and it's an issue everywhere. And I think healthcare systems do have a strain with funding. Human capital. And although you might think of, okay, we've got enough physicians, even if you claim you have enough physicians, you have other allied healthcare professionals that need to be trained and accommodated to that sphere of IBD specifically. Experience, I think these meetings carry some of that experience and wisdom from abroad, locally, and sharing experiences within our healthcare system and what works and what doesn't. And I'm sure maybe the digital transformation contributes to the decreased lifespan of physicians with all that documentation that needs to be done, but it's here to stay. And I think we can capitalize on that and have better outcomes, and we measure what we're doing exactly. And also the current century's oil is data, and they really need to capture that data. And I think there was an initiative, I think last week, with the Unified Electronic Health Record in Saudi Arabia. It was launched, and hopefully that would be a good source of data of really what we're doing with our patients and what's happening. So Miguel had this concept. It's been in the ecosystem for a while now, since 2016. And you can see, as Sarah mentioned in the beginning of the talk in the morning, the patient is in the center of the house. And I enjoy the concept that the surgeon is outside. So he's never let in until he's needed. Keep him away. These concepts are interesting. Really, there's a lot of interaction, and it's more of an environment that grows with time, and people find their right places with different positions and roles and responsibilities. And Miguel did a really good job in describing those roles and responsibilities and job descriptions, and with specific loads, ratios, responsibilities. Hopefully when these turn into a complete program, you have a better outcome. Another issue that we've been struggling with, all of us, either on an institutional level or on a government level, whether it be private or public system, some of these medications are held back till they fail a medication or two. And you can say, okay, I want to start this patient on such a medication, and the pharmacist says, well, you're going to have to go through this line of medication first. Some of our institutions are more liberal, others are more restrictive, and these are, I think, based on BNT committees and how their medications are dispensed. Also, this may be more prominent in the private sector and achieving these medications to our patients. And that's what's called step therapy, and there's a lot of literature around it, mostly in the US and Europe. It causes access cost, although it's supposed to be cost saving, but in the long term it might cause more costs, and suffering for patients and resentment of patients on how they're treated when they need these medications. It's not unique to IBD, and I think rheumatology and other chronic conditions do have it, and we can learn from these aspects and emulate it. So this is a intro to the second part of the talk, and is how we can fix this. We talked about individual physician management of patients with IBD. Next, we'd like to look at it from an institutional level and policy and strategy level. And Dr. Abdelaziz is going to take us about how to optimize these care pathways, how to institutionalize it, disseminate it, keep KPIs and monitor it, and hopefully maybe even start registries on a government level, looking at different healthcare sectors and have a more accurate measurement of what's happening in the healthcare system. So with that, I'll just give the mic to Dr. Abdelaziz.
Assalamu alaikum. Good afternoon. Thank you for having me today. Special thanks for the organizing committee, scientific committee, and also special thank, and I would like to take it at the stage for Prof. Majid. He was a great leader to us previously. I'll start with just setting the stage about what's the Saudi Health Council. Basically, some of you are from outside the country, and some of our physicians have been interacted with the council for a limited journey. So the council basically started in 2002, 20 years back, with a vision that to establish an inspiring reference for a world-class Saudi health system, and with a mission to establish a regulatory that ensures coordination and integration between different stakeholders. Now, as you can see, we have a very powerful and strong mandate that usually support the system to improve and move forward. So what we do at the Saudi Health Council, we set up strategies for the national health direction. We also do integration policies and implementation and programs monitoring. We evaluate policies that have been done. Also, at the council, we review some legislations that can promote healthcare and introduce it to the Royal Court for improvement and changes. Also, on the other hand, we support in creating some national committees that support in solving different challenges in the system and trying to come up with different solutions. Now, if you look into the council itself, there is different members of the private sector, public sector, military, civilians also. And then you look into the health sector allies, like, for example, Ministry of Finance, Ministry of Economic and Planning, Ministry of Human Resources and Social Affairs. All of these are part of the healthcare planning. You need them when you plan. We need them when you direct your services. I just want to show you the national centers that we have. So we have like 10 national centers. Saudi Center for Accreditation of Health Services and Institute. It's similar to GCI, but it's locally in Saudi. We have the National Center for Organ Transplant, Patient Safety Center, National Heart Center, National Diabetic Center, also the National Center for Evidence-Based Medicine, which we'll talk about it also, the National Center for Growth and Development Disorders, also research, also the National Center for Cancer, National Information Our Health Center. The ones that I selected on blue squares, basically these we think that are potential interaction with you guys and the committee or and experts who deals with IBD. Because you will have a lot of things in common to the system and to introduce to the system. Now, if we have a zoom out on the new transformation program, some of our colleagues from outside the kingdom, we'll give them just an overview. So it started with the goals, with having a vibrant society, thriving economy, and ambitious nation. If you look into it, there is three zones or three levels of strategic objectives. Our transformation focus basically on level 3, which is facilitating access, improving quality of care and efficiency to healthcare services, promoting prevention and risk prevention, and also enhancing traffic road accidents. Now, these come from challenges that we faced previously. So if you look into the average annual death rate from premature death rates, we have around 90,000, and we're behind in 2016 from most of the G20. So we're lacking around 5.2 years behind them. Now, the recent published life expectancy, we are above the average of the G20, which is thanks to the transformation efforts that has been captured. Also, in 2016, we had 4.6 million of diabetes patients registered, and this is expected to double by 2030, and that's an extra burden to the system. Growing population, that will also have a burden to the system. So all of these come with a cost. Now, the other thing is the governance of the system. So our system basically is multifaceted. Every organization has sometimes mandates that overlap. So now the transformation comes with a structure that they want to correct these things. High death rates from road traffic injuries. In 2017, we used to be the last in the G20. Nowadays, with the interventions, legislations that have been introduced, cameras, safety belts, we came next to the average of G20. Also looking into the overlapping regulator function. So basically, Ministry of Health does provision, does payment, and also regulation. So all of these has a conflict of interest. So that's why we will see that it's completely has different, and we see now a new payer. Duplication of health services by providers. So we have patients are double tapping in the system. So they can go to private insurance, they can go to different governmental sectors. And that's a challenge and a cost by itself. And also supply and demand. Dr. Majid was just earlier mentioning that we need the new forces or new workforce that can accommodate the needs for the future. And these are basically the contributors, like having fragmented health services between primary and secondary, lack of infrastructure and IT, and others. Now, these are the domains that the public policy will cover. Basically, looks into the risks and security. So we have a complete pillar around that. Health financing is another issue, how we can move from line item budget into capitated future-wise. Value-based health innovation. We started last week. We had a biotech workshop, just looking into innovation and supporting it. Looking into also health and health policy. Now, currently, we have a new established council for health and health policy that is also chaired by members from all ministries, and also higher representation from ministers. We have also looking to improve the value base and the workforce enablement, and finally the road traffic accident. So this is the 8 structural branches of strategy where most of the initiatives are located around them. So you can also look into these and also think how you can design from IBD perspective committee or a community, how can we link to these future-wise? Now, the whole concept comes around the evolution of a new model of care. The new model of care comes into, it's in the center, but it needs a lot of enablers, which is basically corporatization, where we can see now the health holding companies and the ACO, Accountable Care Organization. Governance model need to be also changed. Payer, now we start to see the Central National Health Insurance, the CNHI. Private sector, how do we can contribute to them? PPP. Dr. Majid showed us in a while the home care concept. So how can we bridge that also to private sector? How can we collaborate with them? Workforce, it's also a challenge, and we saw that obviously with COVID-19, with the stretched resources, and how can we locally help it? Then the digital transformation, which we'll be talking about it shortly. Now, this is the mindset that what has changed. So previously, we used to work into hospital base. We need to go to more of a home care base or a community base. We used to look into activity-based outputs rather than outcomes of the patient. So we can produce numbers of patients, but without the guaranteed or the wanted desired outcomes. From treatment-based into prevention, from also institutional to more of an integrated. So we used to have more of a fragmented system. Each level of care talk in separation with the other. We also recently saw the first and the largest hospital, the digital hospital. So we're moving from physical buildings toward more digital, and also toward more integration, and how we can activate the participant, which is the patient. How do they enable them? So the digital file or the unified file is one of the pillars. You'll start to see digital solutions now in the future with Sahati. So how do you enable patients, and how you as a community can plug there and help them? Now, this is just to show you what happened with the model. So the MOH used to provide purchase service and also to regulate the service. This now doesn't happen anymore with the new mandate for the health holding company and the CNHI. So we saw that the Ministry of Health will be just regulating. CNHI will be responsible for purchasing healthcare services and the cluster to deliver the health services and all around the beneficiary. And this is basically structured around something called the triple aim, which is patient experience, population health, and cost, reducing costs for healthcare. This is an overarching for you just to understand what is the health holding company. So it's basically a company that will own the assets of the hospitals in the kingdom, especially MOH hospitals. They will have business units. These business units will help the acceleration and facilitate the transformation of the clusters. We're basically located in 5 regions. And then we have 21 clusters that will be launched across the kingdom with advisory board that can help and facilitate. They will be accountable for the integration of care, the service delivery, and the outcomes of the patient. And this is what we desire, that we have a care that will look into value, deliver value, and it's a patient-centric. So what do we mean by that? Our model of care will be something that we can export outside the kingdom. It's a state of art. Also, we have a transparency on data and visualization, incentivizing good outcomes, and also controlling the cost in a way or another. When it comes to patient-centric, we're looking into having design the services around the patient. We start to see a movement around population health needs, surveys around reaching out to communities, enabling patient groups, communicating their voice. Also activating the patient by choosing their providers down the road, so they can choose between public or a private provider. But that will need a journey to go there, to reach there, a maturity of the system. Now, on the left side, you can see the patient is in the center. Usually, he has to figure out himself. So no case coordinators. He has to move between each department, trying to figure out what's next for him. And there is no home care activated. So you can see what they call it the flower, or basically it shows the different levels of care, from primary care to virtual care to specialized care. And then right side, you can see the wanted or the desired outcome from the system. So you can integrate home health care, you can integrate the unified medical record. All of the providers comes to serve the patient, so the patient is in the center. And how we also enable primary health care as a gatekeeper for them to reach out. This is in a way how the pathways. So you can see there is a standardized 10 pathways that looks into structured for main KPIs. They look into structural outcome and also process. Now there is another 200 pathways. So these pathways usually customized based on the level of care, based on the maturity of the cluster. And I urge you also as a community to look into your pathways. How do you connect it? How do you communicate it? Because this is really going to have an impact on your patients. And what KPIs can we plug in? And basically this is an iterative process, so we go and improve as you go. Each one of you will have a different setup based on their hospital and their level of care. Now, someone will ask, why did we choose this pathway? Basically, this is based on the calculation of life saved from total death. The priority came from stroke, STEMI, breast cancer, and colon cancer. And to show the way that how the system become more transparent, they start to put targets and numbers. So you can see that the target of 2022, we reached around only 70% on colon cancer. And the other way, also in breast cancer, 73%. And that's the way how the system gonna be. And you can see it across even different providers in the system. This is just to show you what the direction of the HSTP looking for to achieve. So when you talk about workforce, we saw the ratios that just presented earlier with Dr. Majid. So what would be a standard productivity? That's a challenge because you need to link it with also your financial incentives. How would you set up the targets? How do you work for work plans? Some of you have problems in asking for more staff. How you justify it? So you need to look at this from a service delivery point of view. Also, there is a lot of initiatives, which is specialization like IBD needs to return some of their staff. How can you think about it in a joint with the transformational program? Increasing the number of Saudization is also a priority nowadays in the country. This is one pillar that is really a priority, and we need to, together we can work around it. Also in digital transformation. So how do you enable quality and standardization? You will start to have Saudi Patient Center putting standards, KPIs. How can we enable it? Also patient tools that can help your patient be proactive instead of reactive coming to your clinic. How do you educate them? How do you really activate them? Ensuring effectiveness of operation and monitoring it. Basically now there will be a complete monitoring of assets, workforce, and better planning. And that also experts from your side need to be available in these committees. So what are we missing? So I did a little bit literature review, so to see what do we have and what can we bring to the table together. So I couldn't find really some policies around different domains. So we show you the different 10 domains, the transformation looking at it. We didn't see really policies touching any of these. Even we can start with some policy brief. Basically, you raise the concern. So what do we want? What do we want from policymakers to look at, and they start to communicate it and institutionalize it? I'll give you an example. Home health care was not covered by insurance. And with the push from the Saudi Health Council and with the community of home health care, we start to see some services has been covered. I think one of the good opportunities, for example, the STEP approach, Dr. Majid's approach, how can we look at it? Can we push the agenda for that? Other thing is the burden of disease. Basically, you will ask for funds. And if you don't have a clear burden of disease, clear epidemiological studies, you cannot negotiate that basically with policymakers. And also, you have to anticipate the growth for 2030 population. Clinical pathways. We have in the Saudi Health Council evidence-based center. And I think you could, as a community, approach them and look at collaboration in terms of localizing and make it a national level clinical pathways. And you can take it also into digitalization, because now health holding companies and others started to plug these into their systems. We recently, last month, saw the the Saudi National Institute for Health. It's a wonderful place to start with for your research. They have a huge funds. I urge you all to go and apply for it. It's very, very, very attractive area to start with. In terms of digital health registries, all the registries are coming from the Saudi Health Council. I think that's an area where you can also look at, click in it, and also start to create some needs for your community or your patients. This is just something that we created at the council. We finished last year, a manual, how do you create policies for different domains. So basically it goes with you step by step. And if anyone is interested, we can share it and communicate this with you. And this is the ongoing policy brief. So we're working with the community for the Heart Association community to create policies around valvular heart disease, performance-based incentive, rare disease. We have a community and we started to work with them to initiate some policy briefs. And also we're urging you to come and work on policies related to IBD. And with that, I conclude. Thank you very much.
Thank you so much, Dr. Abdulaziz. I think I invite Prof. Majid and Dr. Abdulaziz to come here for if there is any questions from the audience. Maybe I'll start with, a kind of question for Prof. Majid. We talked about integration. Is there any downside of integration as well from the other side?
Yeah, downsides. I think if you don't have clear alignment with your colleagues, friends, and personnel, these things really need commitment, and a mal-aligned individual can drag your whole system down. So let's say the nursing department isn't committed to assign a nursing coordinator, or your physician colleagues say this is going to be a lot of work. I think we had one experience. We tried to create a digestive disease center in our institution, and what happened is there was a lot of up costs, so the surgeon says, okay, I need to move my clinic next to yours during the same time and see your patients simultaneously. I really don't want to do that. I'm happy as I am, leave me alone, we're just going to do what we're doing. If it's not broken, don't fix it. So yeah, there are downsides to doing it, but I think it's a well-intended investment.
The other question, it's a challenge usually that we always come when we have, trying to go to integrated care and all that thing, is the fragmentation of the system. And, different resources everywhere is not the same. So what do you think the most important things to overcome this challenge?
I think we can draw some wisdom by the healthcare transformation, looking at healthcare clusters and how they assign responsibilities and duties at different levels. So instead of every patient coming with pain in a clinic and given a diagnosis of IBS, using calprotectin, and I think the red flag pathway that the SGA disseminated to primary care physicians, trying to pick up people at an early stage, is activation of primary care. And at the same time, tertiary centers having the appetite of accepting those patients who are complex, and those who are less complex to be sent back to secondary and primary care. So the patients with proctitis who are not willing to be seen in a primary care center just because it's UC, I think is unacceptable.
Okay. Dr. Abdelaziz, you mentioned something very important about, data collection and registry. How do you assure, the security risk, because not only the security risk, also the willing of people to share data, because this is something that I've been seeing for a long time now. Every institution wants to have its own registry, and then if the registry somewhere else, sharing of data is not that optimal. So how we overcome that to have a registry, solid data collection?
So thank you, Dr. Faisal. I think it starts with cultural change. Because basically, you as a community or providers, we need to understand more of our patient. We need to outreach them. We need to plan. Because at the end, you need to have a representation of the community. So financial planning is important. Workforce planning is important. And also, recent regulation has endorsed this. For example, the National Health Insurance Center has a mandate to do that. And also the HSTP basically has it's not a royal decree, Amr Sami, that to support every
care and the multidisciplinary team around transformational care that we've seen in the States that you're working.
Can we have the microphone back on?
So my question is, one of the challenges, and it's interesting you alluded to, when it's not broken, don't fix it. That was one thing we encountered and still encounter. The other is around behavioral health. And that has been a challenge variably for a variety of reasons. From our patients' perspective, there was a stigma around psychology and behavioral health. But then there was also the ability to adapt and find professionals that would be willing to work in that team. I think when I was looking through your models, how is behavioral health, how are you incorporating that? Is that a challenge that you're finding here, similar to what we found in the States?
True. So for the first part of it's not broken, don't fix it, at least we think we're doing a good job. But when we go to patient satisfaction surveys and patient outcomes and looking at hard-end numbers, hospitalization, rehospitalization, surgeries, we're not doing a great job. So it's really broken. Although you don't see it, if you kick the box, it's going to come down in different pieces. So I think that's a different, and I agree with you, it's a cultural change. At least that's when we talked about the digestive system. They're happy with what it is and don't change it. So I think that's going to come as a mandate because organizations are going to be held accountable for outcomes, not volumes or surgeries or hospitalizations. So I think that's going to come with time. The issue of, honestly, cognitive behavioral therapy, psychologists, psychiatrists, in our center, we do have a different division for psychosomatic medicine, and they've taken upon themselves to provide services to our patients. But again, even then, the burden is higher, the demand is higher than the supply. There isn't a lot of resistance from patients per se. I think they suffer, and they, at least in IBD, they really know they're suffering and they need help. And we can't really, we can't keep up with the demand, and it's an issue of demand more than, with supply more than demand.
The only other final comment I'll make from lessons we learned, when it's not broken, don't fix it, that attitude, that culture change. We actually found that when some of our colleagues who are resistant to working in that team-based environment worked in the team-based environment, now they'll never go back. Actually, the burnout is less. The interest in healthcare and working in medicine is higher. So some of the most resistant physicians that we had at saying, we do not want to do this, this is a terrible idea, once they started to adapt that, they actually found that this was quite valuable, not only from a value-based care, but value in terms of the joy of medicine.
If I want to add something about how do you link even teams. So in primary care, we have this, and it's a big issue, to be honest. Sometimes I join the clinic, I don't know who's my team. But it needs multi-facets that address it. So for example, now we're trying to move to outcome-based. So how can we link these financials to a group? How do you endorse it through regulators so they become more of assurances these things happen? And I think, as you clearly mentioned, once they start to have a change culture, they enjoy the teamwork, they will actually be part of this change. Thank you.
I thank you all for these important questions, and I thank our speaker, Prof. Majid, and Dr. Abdulaziz for this intelligent sharing. Thank you so much.
Assalamu alaikum. Good afternoon, everyone. We'll start our satellite symposium sponsored by Takeda. So our speaker is Dr. Ahmed Al-Ghamdi. He's known as a gastroenterologist and IBD specialist. He's working at King Fahd Medical City. He has good experience, excellent experience in IBD, treating IBD and IBD patients. Dr. Ahmed, the floor is yours. Dr. Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the nice introductions, and thank you for the organizing committee for inviting me. And also I would like to thank Takeda for electing me to talk about the possibility of reaching multi-layered remission in Crohn's disease patients. So here is my disclosures. And the presenting agenda for this talk, we will start with IBD principles and target. Then the factor that influence the biological choice, vedolizumab efficacy data in Crohn's disease patients, and we will end up by clinical decision supporting tool. So as we know that the principle of IBD evolved, and by incorporating the personalized IBD, that's mean one size does not fit all, and the smart therapy for the right patients, precision of IBD by optimizing the therapy based on the TDM level instead of the guesswork, prognosis, risk assessment, and disease progressions, and of course the monitoring of the IBD in the term of the short-term short-term targets and long-term intermediate target and long-term target. So as we know that there are two main endpoints in the management of the IBD, STRIDE and SPIRIT, STRIDE for the disease control and SPIRIT for the disease modification. So here is the STRIDE 2, the endpoints in the short term symptomatic response by improvement of the symptoms more than 50%, and the symptomatic remissions and the normalized of the CRB, those are the short term. In intermediate target, decrease the fecal calprotectin to the acceptable range and most of the study less than 250, and the long term target endoscopic healing, normalized quality, and the absence of the disability. So we can consider the transmural healing, but this is still not a formal target. So this is not something new. We know that there is poor correlations between the symptoms and endoscopy in Crohn's disease patients. So it is better to combine the symptoms improvement with some objective markers like the biochemical or endoscopy findings. So sometimes we did not achieve the target. Either we start the treatment very late, or the therapy is not working, or maybe we did not optimize the therapy based on the level, or we are treating the wrong issues by giving anti-inflammatory medication for stricture or fibrotic disease. So what is a perfect drug? All of us, we are looking for the perfect drug. Perfect drug is the most effective and the most safest drug. But unfortunately, this does not exist. So this is the Crohn's disease approved medications. As you can see here, we have 3 anti-TNF medications, 2 interleukin medications, and 1 small molecule upadacitinib. And we have the gut-selective alpha-4 beta-7 vedolizumab. So this is the choice between the medication is not easy. So the factor that influence the therapy of a choice, something related to the efficacy, onset of the action, disease location, presence of extraintestinal manifestation, and prior treatment failure. And the factor related to the safety is drug-related adverse event, disease-related adverse event, need for the concomitant therapy, pregnancy planning, history of infection, malignancy, and also the convenience, mode of the delivery, oral, subcut, IV, or frequency of the dose. We have medication that taken daily basis, or every 2 weeks, or every 8 weeks. And also the access to the availability of the drug and the availability of the TDM level and, of course, the cost. So it is very important to assess the risk stratifications, and those patients with age less than 30, extensive disease, those patients with perianal disease and severe rectal disease, deep ulcerations, prior history of resections, and those patients with the damage to the bowel in form of stricturing or penetrating behavior, those are high-risk patients. So the factor that influence the pharmacokinetics of the biological therapy, presence of anti-drug body, concomitant use of immunomodulators, low serum albumin and high CRB, and the high baseline TNF concentration, that means there is high inflammatory burden, and the male sex and the high body size by increase the clearance. So here the database of the 3,300 patients showed that at the mid of the 80, there is a peak of the the Crohn's disease surgery, and after that start to fall down with the introductions of the biological therapy. Now we're going to move to the Gemini trial design. So as we know, there is Gemini 1 for induction and maintenance UC patients, and Gemini 2 and Gemini 3 for the Crohn's disease patients. So this is the study design and endpoints. In the cohort 1, there is 2 arms, placebo arm and antivio arm, and the primary outcome was the clinical remission CDI less than 150 at 6 weeks, and the clinical response by achieving more than 100-point decrease in the CDI from the baseline. Those patients that respond at week 6, they will be re-randomized to the 3 groups, placebo, antivio Q 4 weeks, and antivio Q 8 weeks. So the primary endpoint was clinical remissions, and the secondary endpoint, clinical response and steroid-free remissions at week 52. Gemini 3, mainly, they include the anti-TNF exposed patients, 2 arms, placebo group and anti-FU group. So here is the result of the Gemini 2. As we can see, the clinical remissions was achieved at week 6 and statistically significant, but the CDI 100 response was higher in the vedolizumab group, but was not significant. Among those patients that respond at week 6, they continue to have the response up to week 52 in terms of the clinical remission, clinical response, steroid-free remission. So this line chart showed that those patients in clinical remissions from week 6 up to week 52. And this is the same for the Crohn's disease activity index response. Here is not something new. There is no signal and showed that excellent safety profile for the vedolizumab. For those patients, subgroup analysis for anti-TNF naive patient versus the anti-TNF failure population. So the response of vedolizumab in anti-TNF naive patient was 31%, and it was dropped up to 15%. So there is a reduction more than 50% in those patients exposed to the anti-TNF. Among those patients that not responding at week 6, so they, around quarter of them, 25% of them, they will respond at week 52. So allow for 10 to 14 allow for the 10 to 14 weeks for the maximum induction response. So those patients, sometimes they are delayed response, and around 25% they will respond after continue the medication at week 52. So here is some comparative effectiveness. It is a retrospective observational and cohort study, and by using the propensity scoring matching to compare between the vedolizumab and anti-TNF. So as we see here in the overall, there was no difference statistically between the vedolizumab and anti-TNF in the clinical remissions and in steroid-free clinical remissions and in endoscopic remission. With the subgroup analysis and the comparative effectiveness based on the disease durations, so those patients that disease duration less than 2 years, the vedolizumab was doing better than anti-TNF, while those patients with the late disease, more than 5 years, the anti-TNF doing better than vedolizumab. So the disease durations, it makes difference when you choose between the medications. This is the persistence of the drug, and it was higher in the anti-TNF group comparing to the vedolizumab group. This is a similar design of the study called the Evolved Crohn's disease. It is a 24 retrospective medical chart study. They include both UC and Crohn's disease patients. But in the chart here, we see the Crohn's disease, as there was no difference in the clinical remissions between the group at 12 months, 18 months, and 24 months. And also, the achieving mucosal healing in both group, vedolizumab, anti-TNF, were similar. For the treatment persistent, was doing better in vedolizumab, and it is statistically significant at week 12, at 12 months, but after that, they are similar. So as we know that the first biological therapy is the best therapy, and the second and the third biological therapy, they will decrease the efficacy by 10 to 15%. So maybe here we will see something interesting in the Evolve Crohn's disease, that those patients that receive anti-TNF as first line or anti-TNF as a second line after the vedolizumab showed that the efficacy of anti-TNF after the vedolizumab does not decrease, and in the treatment persistent, treatment clinical response, and clinical remissions. And this may help us how to position those medications. So we know that burden disease has, the perianal disease has huge burden on the patients. So around 20% of the Crohn's disease patient, they develop perianal fistula within 10 to 20 years of diagnosis. So here is the enterprise study. It is randomized, double-blind phase 4 study, and they include the moderate to severe active Crohn's disease, draining fistula from 1 to 3. And they are two groups, both two vedolizumab intravenous regimen. The first group is around 16 patients, and the second group is 18 patients, but they include the 10-week dose. So the fistula response at week 22 and 30 weeks is around 46%, and the fistula closures is around 50% at 30 weeks. So as we know that intestinal resection is one of the most important modality in the management of the IBD, and around 70% of those patients, they will have resection during their disease. So the risk of the surgery within 1 year is around 16%, and 5 years is 33%, and reach up to the 47% in 10 years. So this is a prospective placebo-controlled randomized trial called RePreview study, and the around 80 patients, two groups, vedolizumab and placebo group. The primary endpoint was the endoscopic recurrence of the Crohn's disease patients. So as we know that the post-operative Crohn's disease patient endoscopic recurrence is high, reach up to the 90% in those patients without treatments, and those patients that receive prophylactic treatment reach up to the 30%. So from this study, we show that 43% of those patients in vedolizumab, they was in endoscopic remission comparing to the 3% in the placebo group. So it is around 78% patients in vedolizumab group, they had a chance of having lower Rutgert score versus the placebo. So the classification, low risk I0 to I2A versus the high risk I2B to I4. So 77% in the vedolizumab group comparing to the 38% in the placebo group with statistically significant p-value. Regarding the clinical recurrence, there was no difference between the two groups, placebo and vedolizumab group. The CDI rise more than 70 versus the baseline, and this is, as we know that the clinical recurrence sometimes need a time to develop. So mucosal healing, it is an important endpoint to achieve in our patient, and this is what we learned from the CALM study, that those patients with no endoscopic remission, they have more disease progression comparing to the endoscopic remission with a statistically significant p-value. And also the deep remission versus the no deep remission and the disease progression difference between the two groups. So Versify study, phase 3B, open label, multi-center study, addressed this point that patient number is around 100 patients, and more than 55% they failed at least one anti-TNF. So in all patients, 25% they achieved the endoscopic response at week 22 with the vedolizumab, and anti-TNF naive patients, 28% versus 22% in anti-TNF failure patients. So the endoscopic remissions in all is 12%, anti-TNF 20% versus the 6% in anti-TNF failure patients. So it is very important to know that the complete mucosal healing, it can be different based on the disease location and the disease segment. So the lowest here is the ileum to heal is around 21% versus the transverse colon is reach up to the 51%. And overall, the endoscopic or complete mucosal healing in Versify study at around 15%. So are we ready to treat the Crohn's disease patients with the disease locations and the segment? So the conclusion of the Versify study that endoscopic remissions is 20% in anti-TNF naive patient versus the 6% in anti-TNF exposed patient. So the endoscopic response 28 versus 22. Mucosal healing by disease location in the ileum is around 20%. In the colon, it's from 32 to 50%. And the mucosal healing usually is easier in the colon comparing to the ileum, because we know that ileum usually is complicated by fibrosis and fistulas. So what about the later and early disease? So this is a retrospective multi-center study of the patients with Crohn's disease, around 650 patients. So at 6 months, they compare the rate of the clinical remission and the steroid-free remissions and endoscopic remissions between the patients with the early stage, less than 2 years duration of the disease, versus the later stage, more than 2 years patient Crohn's disease. So those patients with the disease duration less than 2 years, 38% comparing to the 23% in disease duration more than 2 years clinical remission. Steroid-free remission in those patients with the disease less than 2 years is 43% comparing to 14%, and endoscopic healing is around 30% versus the 13%. So the disease duration is a make difference when we choose the medications, and the make difference even for the response to the therapy. So what about the combination therapy? I mean to combine vedolizumab with immunomodulator. Is there any evidence about this? As we know that one of the most advantage of the vedolizumab is the safety. So do we need to combine with immunomodulator or no? So here is the retrospective study of patients including Crohn's disease and ulcerative colitis for both vedolizumab and ustekinumab, with the follow-up is at least for 1 year. And so the primary endpoint was the clinical remission and the response at week 14. And in this study showed that when you compare the combination therapy, vedolizumab or ustekinumab with immunomodulator, comparing to the monotherapy, there was no difference in terms of the clinical remission or clinical response, endoscopic remissions, and the therapy failure. Even this is seen in the ustekinumab. With the subgroup analysis, even those patients that they are not on primary medication, those patients already exposed to the anti-TNF, and we start the vedolizumab or ustekinumab as a second line, so also there was no difference from adding the immunomodulator to the vedolizumab or the ustekinumab to the immunomodulator. So this is the tool, the Crohn's disease clinical decision supporting tool from the Olfactory Consortium, and this tool can help us how to predict a response to the vedolizumab response. So here is the factor. If there is no prior bowel surgery, 2 points. If no prior anti-TNF exposures, 3 points. If no prior fistulizing disease, 2 points. Baseline albumin plus 0.4 point per unit, and the baseline CRP. So as we see here that those patients with the high response, 19 points, the clinical remission achieved in a 38% 8% comparing to 10% with the low response 13 points, and even the steroid-free remission, mucosal healing, deep remission. So this is the line chart showing that also this tool can help in the Harvey-Bradshaw index, and there is good response in those patients with predictive value more than 19 comparing to the low risk with the point less than 13. So thank you. I think I finished early.
Thank you, Dr. Ahmed. Probably I will ask you to join me for any questions. Any questions? Okay. So probably I will start with one question, Dr. Ahmed, regarding, you show us the benefit of vedolizumab as start early. So probably we'll heard from Prof. Rigoro tomorrow about positioning of biologic. But in your practice, how you position FIDO, and we have multiple biologic nowadays, so how you position FIDO in Crohn's disease?
So first of all, this is not an easy question because we have very little data about the head-to-head trial. So we have only one head-to-head trial in Crohn's disease called CFU between the ustekinumab and adalimumab. But I can say the patient profile for the vedolizumab in Crohn's disease, those patients with the mild to moderate disease, colonic, naive patients, so those patients with less inflammatory burden, low CRP. So I think this will be the best choice for FIDO in Crohn's disease patients. Yes, because as we see here in the EVOLVE study, that those patients that early disease, less than 2 years, the response was better than those patients with late disease. And I think this is also with all biological therapy because we know that the damage to the bowel is irreversible in IBD patient.
So another point, it probably we read it a lot. It's adding extra dose of FIDO probably at week 10. But in real practice, I know you have good number of patients on vedolizumab and they are doing excellent. So in your practice, you consider evaluating your patient at week 6 and consider adding extra dose?
Short answer, yes, because I think the most important management of the IBD is the monitoring the patient. So we know from the study that those patients that responding early and they achieve the biomarker remissions and fecal calprotectin is less than 250 within 6 weeks, those patients, they are doing better at week 52. So I think the early monitoring those patients is crucial and can help us that those patients with not responding and with partial response, we can add week 10 dose, and the response, usually they are doing better than those patients without week 10 dose.
Any questions? So probably I will end by one question extra. Nowadays I think the trend, probably and you will see it in coming years, a combination of biologic. So where to put FIDO as a part of combination? Can we use it as a base because it considered as a gut selective? Safety data is very nice on it. So shall we use it as a combo, as a base, and then you add extra systemic biologic?
So as we know that combination therapy is not the standard of the therapy now, and if we use it, but we use it as off-label indication. But recently there is a study published called Explorer Trial about the combination, and they include vedolizumab, adalimumab, and methotrexate up to the week 26. Then they continue the vedolizumab and showed they are, the result was promising. So I think if you do it with very selective patients. But maybe we are do it before the introduction of these small molecules and the approved new small molecules. But personally, nowadays I will not do it until the patient maybe fail the small molecules.
Okay, thank you. I think with this we'll end our session. We'll start the coming session. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the faculty and the scientific committee for this kind invitation. I would like to congratulate them for this successful meeting. We are so happy to be reconnected back with IBD Masterclass in Riyadh. I would like also to extend my thanks to Dr. Majid Madi and Dr. Nahli Azam, and also to Dr. Mahmoud Mosley and Dr. Uthman Al-Harbi for this kind invitation. Now, it's my pleasure to invite the IBIS group, and I will start by introducing Professor Christian Masser, lead of the IBD Center and the head of the Department of Geriatric and acting chair of the Internal Medicine Department Hospital in Germany. He received medical education at the University Marburg and Hamburg, as well as New York and Johannesburg. He went on to complete his internal medicine and gastroenterology training at University of Minnesota and spent 2 years as a postdoc in the laboratory for mucosal immunological at the University of California. He is one of the founding members and the current chair of the International Bowel Ultrasound, IBIS Group. And also he is a member of the steering committee of the German IBD study group. He was the chair of the ECO Guidelines Committee and a member of ECO Educational Committee, as well as part of ECO Congress in 2022 Organizing Committee. He is and has been a member of various international and international IBD Guidelines Committee. One of his major research focus is to explore the role of intestinal ultrasound and monitoring in IBD. Kindly welcome Professor Christian, who will give us a talk about positioning the patient with ulcerative colitis, either monitoring or for diagnosis their disease. Dr. Christian? Dr. Hiba also would like.
السلام عليكم ورحمة الله وبركاته. جمعة مباركة للجميع. Hello everybody, my name is Abdulaziz Shahrani. I'm a consultant, gastroenterologist, associate professor at Najran University and IBD specialist. It's my pleasure to introduce Dr. Ahib Al-Farhan, who is a consultant gastroenterologist and hepatologist, and she's advanced IBD specialist in Al Amiri Hospital, Kuwait. She's the vice president of Kuwait Gastroenterology Association, and she is executive board member of Common or vice chair at the International Bowel Ultrasound Group. She also did a training for the gastroenterology at Calgary University. She's also a member of Royal College of Physicians and United Kingdom. Dr. Ahaba, please.
Thank you very much, and thank you very much for the invitation. It's an absolute honor to be here and to speak to you today. And Hiba and I decided we will do it like I'm used at home with my family. I get to say the first words, but the last words I never get to say. So Hiba is going to finish, and when we changed in between, because what we want to show you today is I basically was born with intestinal ultrasound. So I'm doing it now for 20 years. It's part of the clinical training in Germany to become an internal medicine specialist. So we do it from the beginning on. And Dr. Hiba, she started introducing it to Kuwait. It was a much bigger challenge for her to get started than for me, and to prove you that it's actually doable in countries where it's not commonly used yet. Let me start with the first case, and I asked Dr. Sarah today already the question about this woman, what she would do in her daily clinic. And that was a 32-year-old patient, Crohn's disease, clinically asymptomatic. She was sitting across from me. I haven't seen her for several months, and she was doing absolutely fine. So what I did was, like Sarah mentioned, I drew blood for CRP, and I got the stool sample for fecal calprotectin. Now, those results I don't get back right away, and that patient came from 2 hours away, which in Germany is like a world travel to drive for 2 hours. So if I would have had those results, the CRP was normal and the calprotectin was 180. So I would have probably said, okay, that might be mild inflammation, but not much going on. I performed an intestinal ultrasound in that patient, and what you can see here is let me see the pointer. You can't see it up here. What you can see here is actually terminal ileum with an abscess. Let me see if I can just go in here. Oh, you can see it because I want to show it to you. Not coming up here. I will walk over here. This is the terminal ileum right here. This is the dish with a small abscess. So, in a patient that is completely asymptomatic, what you see here is right away that is a patient with a severe disease. And if I would have just talked to her and would have just gotten the lab results, this outcome of that patient might have been worse. So clearly, clinical remission, especially in Crohn's disease, is not always transmural healing. We will not reach transmural healing in all of our patients that we have from Sarah today, but this would be our ideal aim that we want to reach for normal bowel. And then if we need some cross-sectional imaging, the question is always which cross-sectional imaging is non-invasive, requires no preparation, is without radiation, can be performed by the treating physician right at the spot, immediately delivering data, including the real-time observation of bowel wall movement. And you already know the answer. It's not CT, it's not MRE, but it is intestinal ultrasound. And once you learn intestinal ultrasound, you will see you can do it right at the spot, and it only takes you a few extra minutes. And this slide you have seen several times today and in the past probably, because it's a very important publication. If you look at the details in the publication, you can see that cross-sectional imaging using intestinal ultrasound, CT, MRE, has been increasingly used in addition to endoscopic assessment as one of those additional sentences. The use of bedside bowel ultrasound has revolutionized our ability to assess the degree of inflammation in IBD and allows frequent assessment and has the advantage of assessing the entire gastrointestinal tract, including transmural healing. So already in the text of the STRIDE guideline, you find a few sentences indicating the usage of intestinal ultrasound. And we have learned a lot about intestinal ultrasound. If you look at the publication, you enter intestinal ultrasound and IBD. Until 2015, there are only a few publications. Since 2015, it's a rapid increase in publication on intestinal ultrasound and IBD. So we are learning a lot on how to implement, how to use the method, and what to make out of those results. Now, what, how, when, and which consequences before I hand over to Hiba? Because that's important to understand what do you need to look for. And it is very simple. The most important parameter is bowel wall thickness. And as the pointer unfortunately doesn't work, I hope you can see it with the arrows. This is normal bowel wall. The probe is on the top of the picture, then you have the abdominal wall, and then you have the 3 layers, which is black, white, black, mucosa, submucosa, muscularis. That's a normal bowel wall. And I think everyone in the room can see the difference between normal and abnormal. That is abnormal. Those are 3 layers, 7 millimeters. It's still the stratification is intact, but it's inflamed. And in all the clinical trials, that's the most important parameter. Then we look for stratification. Left on the picture, you see the 3 layers. Towards the right, it's just blackish, no stratification. Then we look at vascularization. No vascularization means lots of fibrosis, not so much inflammation, lots of color, lots of vascularization, more inflammation. And then we have one very important additional thing. It's first the mesenteric proliferation, the fatty proliferation around, which helps you find the inflamed bowel, but also it's a sign of more intense inflammation. And we can see motility. So on the right of the picture, you see a terminal ileum, which is the whitish thing that's in the middle of the picture moving over. And it's not the bowel that actually moves, it's the probe that's moving. And then on the left, you see a normal small bowel that's moving back and forth. That's how a normal bowel should look like. And that's the difference between a CT and MRE currently. The intestinal ultrasound, you can see motility, you can see activity, you can see if a stricture is a real stricture or just functional because there was just a contraction. And there's an expert consensus explaining all the different parameters, how to look for and how to grade them, and I very much recommend to look at that paper. And then you have to look for anatomical landmarks, and I often get told, oh, can you do small bowel ultrasound? Yes, but we are doing intestinal bowel ultrasound, which means small bowel plus large bowel. And you can see here in the cartoon that we are looking at the different parts, sigmoid, descending, transverse, ascending, and terminal ileum. And you have landmarks to actually find the right parts. Now, just one short image on how you find the bowel and what you do. That's on the sigmoid. That's my colleague examining the sigmoid. And you can see her probe moving over the bowel. And she's doing it very slow. That's slower than she usually is doing it. And still, it only takes a few seconds to look at the bowel. So that's done, and that's the sigmoid. That's how you look at the sigmoid, and that's what you then see by ultrasound. Again, in the middle of the picture moving. This is in the middle of the picture, the sigmoid moving all the way across. And if you haven't seen intestinal ultrasound, you will not understand the image probably right now. If you have done a few, you will see completely normal sigmoid. So you don't have to worry about that sigmoid because that's completely normal. Now, what's the evidence? And we are not going to show you many data slides. There are lots of publications out. One showing the TRUST study in more than 200 patients, normalization of bowel wall parameters as early as 3 months after start of therapy. We have the STARTER sub-study, IUS response to therapy as early as 4 weeks after start of therapy. Crohn's disease and transmural remission at baseline has significantly better outcome at 1 year. So those patients that you scan in your clinic and that have a completely normal bowel ultrasound, those are very likely to be at 1 year in remission, no hospitalization, no steroids, compared to those where you find pathology. IUS response as early as 4 weeks post-start of therapy predicts endoscopic response at 3 months. And IUS can identify post-operative recurrence. And there's lots more to read, but Hiba, how are you actually using now, with all the data in the clinical, with your patients, the intestinal ultrasound?
So thank you very much, Christian, for this overview. And you people, you would think that, is it like doable in our region or no? We doesn't have like enough practice because during our training program, we never like get exposed to intestinal ultrasound. So in real clinical practice, what do we do, especially like in my center and my region? Let's take an example for a patient. So I have Mr. F, he's a Fahad. He's 25 years old gentleman who presented to me in the clinic in 2019. He was diagnosed as a case of terminal ileal Crohn's disease. He was a regular dosage of adalimumab every 2 weeks. The patient is very energetic, asymptomatic, had no problem. So he presented to my clinic, like I would say, a couple of weeks back, and he said, "Doctor, I'm doing well, I have no problem, but I have to tell you one thing, that I stopped taking the medication, I'm not taking it on a regular basis for around 6-month duration." So I asked him to go to the next room, and this is what I found. As Christian told us earlier, that because we doesn't have a pointer, but if you're familiar with the ultrasound image, you can identify, you can see that we have like some sort of bowel wall thickening where you can see the markers there. One is the longitudinal cuts, and the other one is the cross-sectional cuts. And in this bowel ultrasound, I found that the patient is having a bowel wall thickening of around 6.9, I would say 7 millimeter. And there is, I would say, sluggish or reductions in the bowel stratification despite it's still there. And the motility was slightly affected, and the vascularity was slightly active. We sent a blood work, and we found that he has an element of anemia with elevation of CRP. So I told him, why don't we proceed and do colonoscopy? And this is what I found in his colonoscopy. He has an ulcerations. Right after I intubated his ileocecal valve, I found the deep ulcerations with some sort of inflammations. And here it comes that in our clinical practice, we confirm the clinical based evidence. I know that the primary author of this ECO-ISGR guidelines is Christian. However, his recommendations is applicable in our clinical practice. So if we have asymptomatic patients with abnormal biochemical parameters, they may have some sort of disease flare or activity despite being asymptomatic. So after ruling any sort of infection, it's always good to proceed with endoscopy or cross-sectional images. It's not only about the disease flare, disease monitoring, but it's only an intestinal ultrasound can help us in identifying complications in our patients. So I have this Mrs. Munira. She's a 41-year-old lady. She was diagnosed in 2018 as a case of simple inflammatory terminal ileal Crohn's disease. She was at that time at infliximab combination therapy, and then she decided by her own just to stop taking the azathioprine. Then upon follow-up, she came out all of a sudden telling me that, well, I'm going to stop the medication, I'm going to follow a strict diet control, and I'll just follow herbal medication. I tried to convince her to carry on, and I guess most of you doctors are exposed to such kind of patients. I tried to convince her to continue taking the same medication, but she insisted, and she disappeared for around 4 years. Then, out of the blues, I received an email from her just to inform me that, "Doctor, can I see you in the clinic because I have a recurrent abdominal pain and weight loss?" She came to my clinic, and when I took further history from her, she was admitted 3 times to the surgical site because of some sort of bowel obstruction. So we did the ultrasound immediately for her, and this is what I found in the cross-sectional image, that we have a bowel wall thickening in her, and there is some sort of loss of stratifications, and also you can see the surrounding inflammatory fats available. And then we don't have no pointer. And then when I check the vascularity also, it has some sort of pexels, and that is compatible, as Christian showed us earlier, with lumbar score 2. And at the end, while I was following the bowel and the bowel wall thickening, I found this lesion. This lesion, that means that we have like bowel ileal loops that's got connected together, and this is a fistula. So the fistula is a hypoechoic lesion that you can identify it connecting the 2 bowels. So I told her, now we're not dealing only with just fistula, but we're having an active disease and penetrating disease with some sort of complications. So I sent her for MR enterography to confirm this finding, and this is what I found, and I think you can see it genuinely, even in the pre-contrast images from the MRI, that the ileal loops are connected together, and there's a fistula between it. So again, back to the recommendations of Christian, that cross-sectional images can, and one of them is intestinal ultrasound, can detect the penetrating disease, including the fistulas and intra-abdominal abscesses, and also you can monitor such complication using intestinal ultrasounds. Other complications also can be identified using intestinal ultrasound. And this is a real patient that we can scan and you can identify it. And yesterday in the hands-on training and our symposium, we found 2 patients with abscesses. Usually abscess look like hypoechoic or anechoic lesion. As you can see, it's black with surrounding inflammatory fats. It can have some debris and air inside, and it has like a posterior echo hypodense area. And then if we compare, like a lots of prospective trials, they were looking about the accuracy of intestinal ultrasound in identifying such lesion. And out of 3 prospective trials, and with a total number of 240 patients, they found that the pool sensitivity was 84 in identifying such a lesion with a specificity that can reach 93%. Why this low sensitivity of 84%? Simply because sometimes with the ultrasound, we can't identify deep pelvic abscesses or like I would say something that's close to the gastric abscesses. And again, this statement has been confirmed using the ECHO-ESGR guidelines that cross-sectional studies, intestinal ultrasound is a good modality to identify such a lesion. 30% of our patients, and most of the gastroenterologists are aware that 30% of our patients, they will develop like stricture after a decade of the diagnosis. And 70 to 90% of the cases that we sent usually for a surgical intervention are a patient with a stricture. And the strictures, they have like mixed between inflammatory and fibrotic. Our ultrasound machine can identify strictures. And for people who are familiar with some ultrasound images, I guess you can appreciate that we have a long segment of bowel strictures with loss of the echo stratifications, and also the bowel wall thickening is more than 3 millimeter, and the strictures is less than 1 centimeter, and after that, the peristaltic dilatation with sluggish fluid in the lumen. So one meta-analysis had showed that out of 2 prospective trials with a total number of patients of more than 80, they found that, again, ultrasounds can identify strictures in with a good accuracy that carries sensitivity up to 90+% and a high sensitivity. And this statement has been also confirmed with the ECHO-ESGR guidelines that cross-sectional images can detect small bowel strictures, including the CT, MRI, and ultrasound. And ultrasound and MRI has a favorable options because it's radiation-free. And now back to Christian, because he has to give you some overview about intestinal ultrasound and ulcerative colitis.
Thank you, Eva. I think everyone would probably agree for Crohn's disease, cross-sectional imaging is important because it's a transmural disease. I think that's out of the question. But then when we get often asked, ulcerative colitis, why do we need ultrasound? We have SIGMO, we can see it with SIGMO, it's a mucosal disease. Why would you want to use a cross-sectional imaging for a mucosal disease? And all of us who are doing intestinal ultrasound frequently, they know that in moderate to severe ulcerative colitis, it is more a transmural disease. You see all 3 layers involved, and you often see the mesenteric proliferation. So it really helps you to understand the extent of the disease, the intensity of the disease, and it's easy to perform. And we have very good clinical data now on UC as well. So correlation of IUS and endoscopy, bowel thickness of 3 millimeters or more identifies inflammation on endoscopy. We have the TRUST-UC trial, more than 200 patients in 40 centers, normalization of bowel parameters as early as 2 weeks after start of therapy. And then we have the acute severe ulcerative colitis. You have a patient in your clinic with an acute severe flare, you start steroid treatment, and you want to know, is that a patient who responds or who doesn't respond? And the trial from the Copenhagen group, the patient having had an ultrasound 48 hours after steroid start, they can differentiate between responders and non-responders. So already 2 days after start of a treatment, ultrasound helped them to guide their future treatment. And there is more and more data coming out on ulcerative colitis. And again, the question, Hiba, are you using this in your daily clinic in UC as well?
Yes, I do, Christian. So, and this is a real example of one of my patients. This is Mr. M or Mr. Muhammad. He's a 20 years old gentleman. He was diagnosed with a case of ulcerative colitis managed by one of our colleagues, and he was just taking like 5-ASA and frequent, I would say, prescriptions of steroids. He came to the clinic and he said that, doctor, I have a lot of bloody diarrhea, abdominal pain. I came to you for a second opinion. So and he came with his blood investigation that showed that he has a fecal calprotectin of 880, and he was having elevation CRP, anemia, and also he had like a pan-septic cultures, including stool cultures, and everything came back negative. And, sorry, how can I go back? The video is not working. Can you play the video, please?
What's wrong if you click again?
No. Okay, no.
Go back twice, two.
Again.
One more back, and then forward again.
Yes. So now you can see this, I would say the black shade, this is the sigmoid colon, and you can see it clearly that it's thickened with lots of stratifications, it's ulcerated and and even it's like extramural inflammation is there and some sorts of lymph nodes. So all the way I scanned the patient and I found that the patient is having some sort of sigmoid, left-sided inflammations. We scoped the patient with the flex sigmoidoscopy and we found that he was having elements of severe ulcerations and he was like easily to bleed. So we gave the option that in this case scenario, I was trying to convince him to go with biological therapy. The patient was like a bit iffy and he decided to go with oral medication instead of having an injections or infusion. So I started the patient on tofacitinib. Upon the follow-up, I decided to repeat the intestinal ultrasound after 3 months, and you can see the difference because initially there was a bowel wall thickening of 0.5 millimeter, and after 3 months, you can see a complete resolution and preservations of the hostrations with the normal air artifacts and absence of the extraluminal fatty infiltrates. And this has been confirmed also by doing the colonoscopy, and you can appreciate the follow-up colonoscopy. So we do use bowel ultrasound in our regular clinical practice. So back to you, Christian.
Yeah, without going into too much detail, I would like to recommend 2 more publications. The one is Defining Transabdominal Intestinal Ultrasound Treatment Responsive Remission in IBD. It's a systematic review and expert consensus paper, and you can read the different statements of what to look for, how to measure it, at what time points to measure it. That's from last year. It's probably going to be updated again after a while, but right now that contains all the current data. And the second one is we often get asked, how do you document? And there's an ECHO-ESCA topical review on optimizing reporting cross-sectional imaging, not just ultrasound, but also MR and CT, and I recommend to look at that paper as well. One point I want to make is the big difference between CT and MR. In MR, the patient goes into the room, goes in the machine, comes out of the machine. In Germany, the radiologist doesn't even talk to the patient afterwards, only the technician. Ultrasound, if you do point-of-care ultrasound, the patient is right next to you. You are talking to the patient. You are explaining to the patient, look, you are feeling fine, but there's still inflammation ongoing, and my patients very easily understand the images, what's inflamed and what's non-inflamed, and they're very disappointed if they don't see it, because they are taking a drug, they read Google and say, okay, it can kill me, and they want to know that this actually helps, so they want the follow-up. And we have clinical data here from Andrew Friedman, who showed that IUS may improve adherence with treatment and clinical outcomes, because it's for the patients a better understanding on what's happening in the bowel. So it is a very good interactive tool for point-of-care ultrasound. Let us finish off with an algorithm that we would suggest to use with intestinal ultrasound, and then a few comments on what you can do if you are more interested in learning more intestinal ultrasound.
So to wrap up this presentation, I would have asked, like, how can we monitor this patient and what's algorithm that we need to follow up our patient? And this is, I would say, like a wonderful proposal because it's a summary of multiple prospective trials that they were trying to know when can we monitor our patients. So if we have a patient with active inflammatory bowel disease, for sure we need to go with the gold standard, which is the endoscopy. But in addition to that, it's really a good idea to follow up, to do an intestinal ultrasound with some biochemical markers. Upon week 4 and week 6, you can it's an optional, but you can do intestinal ultrasound to see if the patient has developed any sort of improvement or a reduction in his bowel wall thickening. And then in 3 months also, you can do the intestinal ultrasound with the CRP and fecal calprotectin. And I guess if you're following this treat-to-target approach, you should see your patient on a regular basis with 3 months interval, so you can insert our machine in between. In month 6 also, because you need to do endoscopy, so you can also scan the patients with some biomarkers, and after a year, to make sure that the patient is in a deep remission or he's responding very well, you can do intestinal ultrasound plus minus MRI. And the idea behind this is to determine the transmural response at the short term, to monitor with a good objective markers, to rule out any complications. You can optimize your therapy during following up the patients, and to determine endoscopic remissions and transmural remission in the long term. So I would have said this is a basic introduction about the intestinal ultrasound and the usage of intestinal ultrasound in our clinical practice. And here it comes like, what's IBIS? Because Dr. Mariam earlier, she said, welcome IBIS group. So IBIS group, we're like a group of multinationality and international doctors who are really interested in using this tool. It's a non-profit organization, and the aim is to advance intestinal ultrasound in researches, educational, and in clinical practice. And how can we use this tool in our IBD practice? And to improve the personalized patient's care and to help to contribute the management and the decision outcome. So if you are interested, because I've been approached by a lot of my colleagues, like how can we learn about ultrasound and how can we do ultrasound? IBIS has a good training curriculum that has been a good training curriculum that we can give it to you, and you can just have a good training to practice this intestinal ultrasound in your IBD patients. So we have Module 1, Module 2, and Module 3. In Module 1, it's just like I would say 2 days hands-on. This will give you a clue about intestinal ultrasound in our IBD patients, in which you're going to have a dedicated presentations and theoretical knowledge about how to use these machines and how it's applicable in your clinical practice. After that, we do subdivide our candidates into subgroups for hands-on training, so they can have the sense of how to hold the probe and how can they scan the patients. And also, we can use a simulator. We can show you with simulator any sort of complications. So if you visit our website, you can see that what's our plan and what is our curriculum for the upcoming Module 1s in year 2023 and 2024. After passing Module 1 or after attending Module 1, then it comes for Module 2. Module 2 is a 4 weeks intestinal ultrasound training in a certified IBIS center. You can find this in everywhere, worldwide, all over the world. So you go there, you spend 4 weeks with a certified tutor to teach you how to scan your patients for 4 weeks durations. The last module is the IBIS Echo Advanced Workshop, in which it's going to be a half-day workshop with advanced talk about intestinal ultrasound and the usage of the intestinal ultrasound. And at the end of this workshop, you will sit for an exam, and then you will receive your certificates that you completed the 3 modules of intestinal ultrasound. IBIS, it's not only about like giving knowledge and teaching doctors and the candidates how to do this technique. However, also we like to socialize and we like to have some sort of networking. So IBIS came up with the get-together gathering for all of their members. So kindly register and be a member with the IBIS and come and join us at the UEGW at Copenhagen in October 15 for the get-together social gathering, and at the DDW in 2024 and 19th of May. In addition to that, after having a membership, you will be able and eligible to attend our webinar modules, because we do have like modules to give you more information about the usage of intestinal ultrasound in your clinical practice with our experts. Also, we do have the membership meetings, and it's going to be like virtual coming this October 25th, and also in February 21st, 2024, it will be at ECHO meeting. So to conclude this tandem talk, and thank you, Christian, for joining me and being with me and supporting me to start practicing intestinal ultrasound in my region. So objective disease assessments in IBD at the time of treatment initiations and monitoring has become like a gold standard. It's part of our treat-to-target strategy in managing our IBD patients. Intestinal ultrasound is a good, accurate tool, cost-effective and non-invasive, and patient-centered tool to monitor our patients. It can be performed bedside, and you can have a quick answer upon what's going on and how the disease situations instantly and in a timely manner. IBIS has proposed the first international recognized curriculum for learning intestinal ultrasounds, and more works is going on with the IBIS group and IBIS team to have a better learning curve and competency measures. Follow us, come with us, and join us, and follow us into our social media so you can know more about IBIS. And thank you very much.
Dr. Hiba and Professor Christian, can you join us, please? We would like to open, first of all, we would like to thank you for this excellent presentation. And I think, as Sarah said, you open our appetite to start learn intestinal ultrasound. Nahla, you have a question?
Yes.
Go ahead.
Thank you for this excellent talk and the excellent workshop done yesterday at our center. Actually, you give us clear data and evidence to support the use of this very interesting tool. But I would like to hear about the limitation of, what are the limitations of this tool?
It's like every method, you have to learn it, and you have to be dedicated to do a good job. So I sometimes see colleagues going like this over the bowel saying everything is fine. But if you do that, you can only say the bowel is there or not. And that's not what we want. We want that you really go step by step and look at the different parts. So that is the limitation, that you have to take your time. But it's like an endoscopy. It's not a challenge to take the scope out of the bowel. The challenge is to be patient enough to withdraw slowly, go step by step and look at every detail. The second limitation is that if you have a deep-seated abscess, that could be challenging to see in the full extent. Proximal jejunal involvement can be challenging. So we always recommend that if you have a patient at initial diagnosis, you always do another cross-sectional imaging, MRE preferably, and then you see if that's a patient that has upper involvement as well. If that is not the case, then you can, and you see everything by ultrasound, then you can use intestinal ultrasound for follow-up. So those are the limitations.
So if you allow me to add something, in our region, Dr. Nahla, you know, like the limitation is not only like technical limitations, the limitation is to access for the ultrasound machine. So I hope that now things will get changed, because now everybody's using international intestinal ultrasounds. And as long as this machine has invaded, if Prof. Riguero agreed, US and North America, so I hope that near it will invade our region too.
I agree. I think it is invading the world. Maybe that sounds aggressive, but I do think it's starting to uptick across the world. Two quick questions. Maybe Hiba for you first, and then Christian for you second. Do you ever foresee this replacing endoscopy? In your guideline, you still have endoscopy at different time points, and it's still invasive. So the question is, are we ever going to get to the point where we don't need a colonoscopy and we can rely on ultrasound? And then Christian, AI, could we have a tech one day do this and have the computer and artificial intelligence read out what we're seeing and take out some of the human element? I agree, the bedside hands-on and discussion, that's invaluable. You can't replace that. But I foresee that as we do this more and more, you could have a room set up in clinic with a tech basically doing this with an artificial intelligence computer actually generating the report. So will it replace endoscopy and the role of AI in ultrasound?
So thank you, Miguel. Most of the evidences and the literatures had showed that it's a helpful method that can be used with the endoscopy. So endoscopy up to now, it's still, I would say, the gold standard, because you need a histopathological diagnosis, histopathological confirmation that the patient is deep remission, hopefully in the near future. So we're at the end of 2023 and we're reaching 24. I don't think it will replace, but it will be like, it will have a very important role in confirming the transmural remission and confirming that the patient is, I would say, in a deep remissions without any sort of complications. So it's a helpful method more than replacing. I don't know if you have something else to say.
we do less endoscopy in our patients. It's not that we are not doing it, but if we see patient response clinically by lab results and we see a nice response in ultrasound, we do not the follow-up as we suggest in the algorithm. It's just an add-on that you can do. It's not completely replacing it, but definitely reducing the number. But it also, what we do is not just that it's not supposed to completely replace, but we want to do short-term follow-up. So our patients usually don't get scoped after, unless 6 months are passed. So for 6 months, nothing would change. With ultrasound, if it's a severe case patient, we do ultrasound after 4 to 6 weeks, and then we already adapt therapy. Now to your second question, AI, we are seeing and trying if ultrasound can be done by AI. I right now think it's challenging, but I would never have thought that 10 years ago I would move around the world with Google Maps and find my way around. So maybe it works one day. Currently, since we don't have clear measurements and the extent and the severity of the disease cannot be expressed by just one number, I hope that it's not going to move to the text too quickly, because text will be able to do an ultrasound, but what they would write down might not reflect the severity of the disease, and the interaction is missing. So I do hope that the first step is now that we as medical doctors learn how to do point-of-care ultrasound, and then in the long term, if we have a clear algorithm, a clear measurement activity score, then maybe we can move it on to the technical side, technicians.
Thanks a lot for such amazing workshop from both Heba and Christian. I think one of the obstacles also the type of the machine of the ultrasound. If the new generation is much better than the old ones. I want to ask, what's the difference between intestinal ultrasound and contrast enhanced ultrasound?
So it's all ultrasound, but the contrast enhanced ultrasound is a technique or a method in which you inject a contrast with either it's like air bubble contrast or other form of contrast to see it can increase the accuracy of this technique, but like not every single doctor, especially the gastroenterologists, they have exposed to such technique or to such procedure. But when we talk about the ultrasound in general, we talk about the B mode ultrasound, which means the gray and black, the one that you've seen. So it's different, but it's extra helpful method that can increase the accuracy of the ultrasound machines, and they can identify more complications and more finding in your scanning. So I wouldn't say they're different, but I would say it's extra methods and parameters that you can use in your IBD patients.
This might replace?
No.
Thank you.
But one comment to the machine, because I think that's important. The machines get smaller and cheaper. And if you want to start doing intestinal ultrasound, there's always the tendency not to spend too much money, because you might not know if it's going to run or not. Please don't go for the handheld machines right now. There are 2 publications out saying that they are as good as the bigger machines. But those are done by experts, and if you talk to them, that's what they say. In the expert eyes that are trained, the handheld machines are good enough, but the resolution is not as good yet. So if you get started, please invest in a decent, doesn't have to be a high-end machine, but a decent machine, have a separate room that is darkened to get started. And then in the shorter term, you can then go and have an additional handheld machine, and they get better with resolution. But right now, please don't just start with a laptop with a probe attached to it. That's very important.
Okay, thank you, Heba and Christian, for the great talk. I have just 2 questions, and quick. The first one, how come in your practice you do perianal assessment and transrectal ultrasound for the patient in your practice? The second question, since you are doing a dynamic imaging, is there any recommended time for the patient post-perineal to just minimize the peristalsis?
Okay, for the perianal, I'll leave it for Christian because he's the expert on this. But regarding any preparation, this is I would say this is the magic of the intestinal ultrasound. You doesn't need any sort of preparation for the patient. You can just leave them and you can just scan them. There was an old belief that we should have kept the patients like MPO for a certain number of hours, but now it's no more applicable and you can just scan the patients immediately. So it doesn't matter if he's eating or no. But sometimes if the patient, like after colonoscopies, if they take some sort of preparation, there will be like an increase in the bowel motility. So we avoid like scanning the patient after scopes immediately, but otherwise you can scope at any time.
Thank you.
And regarding the perineal ultrasound, that's a very good question. I use it frequently. If a patient comes into my room and says, I have new perineal pain, I take the patient right away to my ultrasound room, ask him to please lie on your left side, and then I put some gel on the probe, glove over the probe, and then some gel on the glove. And then the patient shows me where it hurts, that's where I put the probe, and that's what helps me to see is there an abscess or not. Very simple, it takes 3 or 4 minutes. If you're experienced, you can even follow up on perineal fistulas. That I'm not doing frequently, but for finding an abscess perineal, that's a very, very helpful method. And it really changes the way you can treat your patients at time.
Thank you so much. Just one last question. How many probes you have? I mean, we are facing a lot of obese patients, and it's sometimes difficult to get their bowel, especially when we are talking about small bowel. So how many probes do you have for this machine?
Very excellent question, because if a company person comes to you, you will get 10 different probes or so. You need 2. One for the overview, one high-frequency probe, and that's enough. And we often get told you can't do intestinal ultrasound in obese patients. And sometimes, or often, you do ultrasound in obese patients and get wonderful images. And then a very skinny person comes in and you think, oh, that should be easy. And then it's so difficult because there's no fatty tissue in between the bowel. So please, if you see an obese patient, don't think it doesn't work. It works very often. And in pregnant patients up to week 20, it works very well as well. And you don't need extra probes, those 2, and that's enough.
Enough, okay. Thank you so much, Christian. Thank you so much, Hiba. And by that, we would like to go for the next session. Before that, we would like to have a group picture. Thank you all.
Hello, everyone. Welcome to AbbVie Satellite Symposium. I want really to thank everyone who's being here and actively participating in this conference. We are very excited to have a new molecules introduced in Saudi Arabia for patients with Crohn's disease, which is Skyrizi. And we have 2 eminent speakers today talking about Skyrizi, how we could benefit our patients in Saudi Arabia. The title of this satellite symposium is Control is Everything with Skyrizi in Crohn's disease. And we'll start with Dr. Mahmoud Mosley, who's Associate Professor of Medicine, known IBD specialist in the region. And he will give us, introduce the talks, then will be followed by Professor Peter Irving from St. Thomas Hospital in London with some real cases. Dr. Mahmoud Mosley, floor is yours.
Thank you, Dr. Uthman. I'd like to thank AbbVie for inviting me to speak, and I'd like to thank you all for being here so late in the afternoon. It's been a very informative day with lots of really nice lectures covering most areas of IBD. I'm hopeful that I'd be able to tie things together with this talk. Now, this is a couple of disclaimers and disclosures for myself, Dr. Uthman, and Professor Irving. Now, the objectives of this talk is to focus on the following. Number one, understand the importance of mucosal healing as our ultimate treatment goal in IBD to achieve optimized patient outcomes. Second, to understand the impact of suboptimal disease control and how earlier introduction of therapies and timely clinical action using a tight monitoring approach can support achieving mucosal healing in practice. And finally, reflect on how clinical decisions are made in practice and consider strategies for optimizing decision making. So we'll start with a little bit of talk about mucosal healing. So these are the contents. I'm just going to skip through this. So number one, we'll focus on how endpoints have evolved over the past decade. First of all, let's try to differentiate between a few terminologies. So number one, endpoint. So endpoint is a clinical definition of success at predefined time points. So this is a point that basically may have an impact on disease course, and it's used mainly for comparison in clinical trials and for regulatory approval. So this is the language used when you read an article reporting on, for example, the efficacy of a certain drug. Target, on the other hand, is a short-term ambition that must be achievable and will impact outcome if met. It's modifiable with therapeutic optimization. Hence, the treat-to-target strategy. So this is kind of common language between physicians and what we consider something that has to be achieved in order to be able to help our patients. Finally, a goal. So goal is a long-term ambition of treatment defined by an individual patient and by the physician. So this is common language between us and the patients. How have endpoints changed over time? This is a really nice illustration showing clinical trials in Crohn's disease for advanced therapies since 1997 all the way to 2022. You can see from the start point with studies like the Targon study and Accent-1 for infliximab and Crohn's, how we used to rely on subjective endpoints, namely symptomatic response based on CDAI as was used in the Targon study. Moving forward, as you can see with drugs that were subsequently evaluated, such as natalizumab, adalimumab, certolizumab, all anti-TNF agents, you see a gradual trend towards more objective endpoints. And finally, you can see the real change happening somewhere between 2014 and 18, where all of a sudden you're seeing endoscopic endpoints coming in as something that you want to rely on when you're evaluating a drug, because this is more objective. So finally, you can see in 2022, the studies for risankizumab and upadacitinib relying on both co-primary endpoints of clinical and endoscopic endpoints together for Crohn's disease. And this is the first time this is used for induction and maintenance studies for Crohn's disease. Now, let's take a look at ulcerative colitis. Although these are different endpoints, but it means the same thing. You can see in 2005, when the first drug or the first advanced therapy for ulcerative colitis was evaluated, infliximab in Act 1 and Act 2, we used the Mayo endoscopic score 0-1. And then moving forward, as you can see through time, we started to rely on more tighter forms of remission. So we moved forward to use, rather than a Mayo of 1, we now look at a Mayo of 0. Then we started looking deeply into histology until finally in 2023, we're focusing on mucosal healing defined by both endoscopy and histology, reflecting how we thrive for deeper forms of remission. And this is exactly what we are describing in this illustration. You can see starting at the beginning with symptomatic improvement to clinical remission, steroid-free remission, a really important endpoint, Mayo endoscopic subscore of 0-1, Mayo endoscopic subscore of 0, and then finally mucosal healing. Now, why? Why did this change over time? Why did these endpoints go towards more objective forms? And why did we focus on endoscopy and specifically mucosal healing? There has to be reason behind this, literally something in the literature that tells us that this is the right thing to do. So you can see the literature is very supportive of mucosal healing. This is a very nice meta-analysis that included 673 patients from 12 different studies, and they compared between those who achieved and did not achieve mucosal healing at the time of the first assessment. So those who had mucosal healing demonstrated sustained clinical remission, so beyond 50 weeks, in 69% of patients versus only 43% in those who did not demonstrate mucosal healing. A very huge difference between these two patient subsets. Now on the right side, there's more outcomes that came along with this endpoint. So you can see lower risk of disease progression, lower rates of steroid-free remission, a decrease in future need of steroids, low risk of relapse over 5 years, decreased risk of hospitalization, treatment failure, and surgery, all in favor of mucosal healing. These are the individual studies included in this meta-analysis, and as you can see on the right side, the forest plot showing us a higher odds ratio, closer to 4.5 in favor of mucosal healing, favoring mucosal healing and associated with a higher odds of long-term clinical remission. There's more studies out there that support mucosal healing. For example, this is a retrospective analysis of data from the CALM study. And here you have patients with moderate to severe Crohn's disease, so 122 patients. On the left side, you can see how there's a differentiation between those with endoscopic remission and those without, starting early on in the course following the introduction of therapy, with 59% reduction in disease progression with time in those who had mucosal healing or endoscopic remission, compared to those that did not. On the right side, if you look at a more stringent endpoint, which is deep remission, combining CDAI-defined remission along with endoscopic remission defined by the CDAIS and absence of deep ulceration and no steroid use for at least 8 weeks, now you have 81% reduction in the risk of major adverse outcomes. So this is all in favor of going with deeper forms of remission. Now, there's a lot of other benefits. So when a patient reaches mucosal healing, they're more likely to be and remain off steroids. You can see this again in this analysis on the left side. So you have steroid-free remission 3 to 4 years based on assessment of SES-CD at 2 years. And you can see the huge difference between those who did demonstrate this outcome, whether or not they were treated with anti-TNF or not. Now, obviously, when you treat patients with these advanced therapies, what you would hope to be able to promise your patient is that as long as you receive this treatment, not only are you more likely to be in sustained clinical remission of steroids, but more importantly, you're less likely to need to be hospitalized in the future. And you can see that in this analysis. This is a retrospective study of patients with Crohn's disease who achieved mucosal healing followed treated with multiple biologics or multiple forms of biologics. On the left side, you can see in this figure how there is a clear separation in the Kaplan-Meier curve early on in the course of follow-up between those who demonstrated mucosal healing and those who did not. On the right side, you can see the risk of treatment failure also being very different between these two patient bases. Now, obviously, when patients have complicated disease, when they fail treatment, and they go for long periods of time with disease activity, they become at risk for complications, which ultimately translate into the need for surgery. So if you eventually need to go for surgery, that reflects a longer period of uncontrolled disease or failure of therapy. And what you can see with the literature is patients who achieve mucosal healing are clearly less likely to require surgery with time. This is a systematic review and meta-analysis that demonstrated association of mucosal healing at the first endoscopic assessment with the Crohn's disease related surgery-free rate. You can see on the right side in the forest plot, mucosal healing is clearly associated with a higher odds of not needing surgery with time. Again, you can see that in these studies, on the left side, a study which is from the Ipsen database. This is a population-based cohort study involving 227 patients. And on the right side, another retrospective study involving 84 patients, comparing those who had demonstrated mucosal healing and those who did not, and showing the same results. What about ulcerative colitis? And we all treat ulcerative colitis differently in a way. So this is a meta-analysis that involved over 2,000 patients from 13 studies comparing mucosal healing versus no mucosal healing, and again looking at sustained outcomes. So long-term clinical remission for at least 52 weeks and at least 6 months after mucosal healing assessment were achieved in 65% of patients with mucosal healing versus 34% in those with no mucosal healing, so almost the double. So it's almost like you're telling the patient you have half or 50% reduction in the need or in the chance of developing relapse during the time of follow-up. Furthermore, there's higher increase in steroid-free remission, lower rates of hospitalization, decreased need for surgery, and ultimately better quality of life. Here are the individual studies that were pulled together to give us this odds ratio, again, of about 4.5. There was lots of debate that we've seen over time in many meetings about whether you'd want to go with a Mayo score of 0 versus a Mayo score of 1 endoscopically in patients with ulcerative colitis. And ultimately, it was very clear that a Mayo score of 0 brought a lot of benefit compared to a Mayo score of 1. So obviously, a deeper form of endoscopic response remission can lead to better outcomes. And you can see here in patients with MES of 0 on the left side versus those of 1 on the right side, there's a huge difference in terms of the risk of clinical relapse over time. And the right side, you can see how this is also different depending on the extent of the disease. Now, being off steroids, it's really important. I'm sure we've all had that patient where you're, evaluating in clinic, you're asking about symptoms, the patient has no symptoms, no blood, no diarrhea, so you're happy, the patient's happy, and all of a sudden the patient says, well, when do I get off steroids? So, this is sometimes something that we overlook, and I think it's really important to always make sure that you wean patients off of steroids in time. Because being on steroids while on a biologic or requiring steroids while on a biologic is, in a way, considered failure of therapy. This is systematic review and analysis, again, the one I showed, highlighting the association between mucosal healing and steroid-free remission in patients with ulcerative colitis, and you can see almost an odds ratio of 10, which is fairly significant. I'm just going to skip through this one. So moving on to hospitalization, we talked about this in Crohn's disease, in ulcerative colitis. There's a clear benefit in terms of the risk of hospitalization being lower in patients who reach the endpoint of mucosal healing with therapy. Of course, colectomy, which is considered a very hard endpoint, and requires a long time to evaluate and prove. You can see here in this meta-analysis and comparing patients with mucosal healing and those without, there is, again, an odds ratio of about 4 favoring mucosal healing over no mucosal healing in terms of risk of colectomy. Now, finally, as we all agree, ultimately, the patient's quality of life and ability to function on a social level is really important. And you can see mucosal healing offers a better quality of life. Ultimately, over time, patients with mucosal healing tend to do better in terms of work productivity, less absenteeism, and overall social engagement. And this is something that has been reproduced with multiple biologics and multiple studies over the past decade. Now, that's what I think we can say about the relevance of mucosal healing and how it reflects on other outcomes. Now, there's some points we need to focus on when we talk about monitoring patients. We heard Dr. Sarah this morning talk to us in depth about how to monitor patients. We heard about STRIDE 2 guidelines and tools available to be able to monitor patients in clinic. So I'm not going to spend too much time, but I'd like to touch on a few important points. So there are two main misconceptions that in a way prevent the adoption of the treat-to-target strategy and mucosal healing as an endpoint. One is that symptoms are good enough. You don't need to really, focus on endoscopy. And number two, even when you convince people that symptoms are not good enough, the second argument is that we don't have therapies that can achieve mucosal healing, which is absolutely false because we have lots of therapies that are able to induce mucosal healing. This is the STRIDE 2 algorithm that we've seen today multiple times. We've heard how this strategy is followed, the difference between short, intermediate, and long-term targets, and how this not achieving these targets triggers escalation and then subsequently reassessment and so on and so forth. These are the immediate, intermediate, and long-term targets that are used. Now, why do we follow a treat-to-target strategy? Why do we aim for mucosal healing and deep remission? In Crohn's disease, we know that this is a time-sensitive disease and that prolonged periods of active disease and delay in introducing effective treatment can lead to bowel damage and ultimately complication that lead to the need for surgery. You can see on the left side the famous Lehmann Index paper figure that we've seen in many IBD meetings. But the reason this figure is really popular because it really reflects the reality of Crohn's disease. You can see the black line fluctuating, reflecting periods of disease activity and how it drives the progressive increase in the blue line, which reflects bowel damage with time and then ultimately the development of complications and stricture. And of course, we know that when patients are in the phase of an inflammatory type of phenotype before stricturing, fistulization occurs, that is the time when you'd want to introduce an effective therapy that prevents subsequent transformation into the more complicated phenotypes reflecting bowel damage. On the right side, you can see that window of opportunity. So ultimately, this is what we're looking for. We're looking for a flat curve and no complication, which ultimately decreases the risk of surgery. Now, a holistic monitoring approach is required when you have patients with IBD seen in your clinic. We do know what the ECHO guidelines say with regards to the need to wean off steroids. We've talked about this before. It's really important to be able to get patients off steroids and not use steroids frequently due to the side effects associated with this medication. Now, of course, we've heard about monitoring and the use of or utility of non-invasive biomarkers. We've heard about ultrasound today, and clearly it is obvious that patient preference is towards these non-invasive tools. I'm sure patients would rather do an ultrasound compared to giving you a stool sample or even undergoing colonoscopy. And you can see this demonstrated in this nice survey reflecting patient preference for different forms of evaluation for Crohn's disease and ulcerative colitis. We talked about quality of life and how paying attention to this part of patient's life is really important. It's really important to be able to look beyond symptoms, biomarkers, and endoscopy, and focus on patients' quality of life and contribution to society. And this is something that is proven to be very important to patients themselves. There's the IBD disc that can be used easily in clinic to be able to evaluate patients with IBD. So thank you very much for paying attention. I'm going to hand over to Professor Irving to give us a case that highlights mucosal healing?
Thanks very much. Well, we're coming to the end of the day, and as Professor Mosley just said, I'm just going to do a little case just to demonstrate the relevance of mucosal healing as we come to a close. So again, this is a real patient of mine, a 42-year-old gentleman who was diagnosed with Crohn's disease at the age of 28, about 15 years ago now. Initially, he was treated with steroids and azathioprine, but then moved eventually onto infliximab, and progressed to a limited ileocecal resection after 10 years of disease. He came under our care after that operation, and we had a chat with him about post-operative biologic therapy, and because he'd progressed through azathioprine and infliximab, and indeed, as far as we could tell, his disease had worsened on infliximab, we decided to give him post-operative biologic therapy, and we gave him ustekinumab. And initially, that had a good effect. And I'll just pause here to remind you that, in fact, what we did next, doing a colonoscopy at 6 months and 18 months after his colonoscopy, after his resection, is what we've been debating for years, and that's treating to target. That is what a post-operative colonoscopy is. The patient feels well, you're doing a colonoscopy and you're looking at the neo-terminal ileum to see if there's active disease there, and if there is, however the patient feels, you change what you do. This is not a new concept to us. We've been doing it for years. We just need to think beyond what we're already doing. Anyway, he was doing fine at that point. You can see his biomarkers are okay, his CRP is normal, his Calpro is pretty much normal as well. And then we subsequently lost him to follow-up, and you'll see if you look at the dates there, I'll just go back one slide, that 18-month colonoscopy is about March 2019, and then we next see him in 2021, and of course what happened then, it was COVID. And in fact, I'm sure like many of you, had problems with many of our patients being lost to follow-up. But something else happened during that time, and that's he got very worried about COVID, and so he stopped the ustekinumab himself. Unfortunately, therefore, by the time he came back to see us, he had active disease again. He had symptoms of active disease. He had a high CRP, a high calprotectin. Now, at the time, our abilities to endoscope were still limited, and we had a huge backlog. So we made, having excluded an infection, we thought, okay, we know what this is, and we put him straight back onto ustekinumab with an infusion, and then back onto 8-weekly subcutaneous ustekinumab. Unfortunately, he didn't do brilliantly well. We did manage to scope about 6 months after that, and you can see he had Rutgers I3 recurrence, so we started him on vedolizumab. Reassessment after 6 months, he really hadn't made much progress there. He was opening his bowels even more. He had more abdominal pain. He had weight loss, and you can see on his colonoscopy, he's got clearly active ileal disease. And I think if you look at that middle picture, you can see that there's some fairly large ulcers there. And on the other two, you can see that he's pretty much got 100% of the mucosa affected by disease. So clearly active disease, and we clearly needed to do something about it. So what did we do? And I've talked about the early access scheme before that was available to us at this point for patients who had failed 3 biologics and had active disease. And so he received risankizumab. In fact, he started to feel better by about week 8, and his stool frequency improved, his abdominal pain improved, and we did this rescope at week 30. And I think you'll agree, as you can see there is a vast improvement in the appearances of the terminal ileum. There's a little bit of ulceration there, a sort of linear ulcer there, but it's not deep, and most of the mucosa is healed. So he now remains on maintenance treatment. He's now about 2 years or so into this, and his last CRP and his last fecal calprotectin were fine. So I'm going to summarize there, close this session down. I'm just going to really remind you what we've heard over the last half an hour or so, and I think we've heard 2 important messages. We've heard that mucosal healing is associated with long-term improvements in patients with inflammatory bowel disease. We know that with Crohn's disease, we see a decreased risk of treatment failure. We see a lower risk of disease progression, and we see a decrease in the need for steroids. With ulcerative colitis, we see a lower risk of rates of relapse, and that translates into an improved life in terms of impact on work and leisure activities. And then, of course, importantly, in the long term, we see with both Crohn's disease and ulcerative colitis, decreased risk of hospitalization and decreased risk of surgery. And that's why mucosal healing is part of our targets in Crohn's disease. Again, the STRIDE 2 guidelines here, mucosal healing being part of that in both Crohn's and ulcerative colitis. But let's not forget, it's not the only target. And when we're thinking about our patients, we need to think about these short-term targets of the patient feeling better, with the intermediate targets of objective evidence of disease improvement with biomarker normalization, mucosal healing, and in children, normal growth. And then in the longer term, we want to see people returning to a normal quality of life. We want to prevent disease complications and reduce long-term complications. And the way we achieve that is by looking after our patients, thinking about steroid use, by using biomarkers such as fecal calprotectin and CRP to monitor the patients. We've heard about intestinal ultrasound today, and I certainly know if I was a patient, I'd be preferring that as a mechanism of monitoring my disease rather than the more invasive, more expensive, and potentially less available alternatives of endoscopy and cross-sectional imaging through CT and MRI. And it's through that sort of monitoring that we can see what's happening to the patient on an objective level, but we mustn't forget that if we don't talk to our patients, then we won't hear the other side of the story, and that's about quality of life, and I think we should all be thinking about monitoring that as well. So I'll finish there, and we may have time for a question or two, I think.
Yes.
Okay, I'll wander over and join you, shall I? Okay, sure. Thank you.
Thank you, Dr. Mosley and Dr. Irving, for this excellent presentations. The floor now open for questions. Maybe I will start with maybe first a question for Dr. Mosley. Dr. Mosley, if we're looking for a mucosal healing in Saudi Arabia, you're practicing in both government and private centers. If I go to your clinic, how do you monitor mucosal healings? What are the things you use to ensure that your patients reach mucosal healing? Something that could be done in a busy endoscopy unit in the government hospital, and also will get an approval in a private clinic.
Yeah, so very nice question. So it's really important to be practical. And I know that, implementing the treat to target strategy is not as easy as it might sound, depending on the setting you're in. Now, if you have a more comfortable setting, not so busy, easy access, patients are cooperative, you'll probably be able to be very, let's say, compliant to this algorithm the way you would want to. So you do your, visits every 6 weeks initially, you do like your calprotectin every month or two, and then you do for ulcerative colitis a flexig or a colonoscopy in 3 to 6 months, and for Crohn's disease in like 6 to 9 months. But in reality, you might not be able to do that if you are in a governmental center or hospital. We're very busy, booking endoscopy is difficult. I think as long as patients are not forgotten and they're not left without any evaluation or objective assessment, you can maybe play with these timelines a bit. So for example, I'm sure not all of us do a colonoscopy in Crohn's disease exactly at 6 months. You might be able to do it at 9 or even 10 months, depending on your booking. But the idea is that eventually you will, and it's on file as something that is necessary. Seeing somebody in clinic, it's not so difficult. You are able to see an IBD patient every 2 months at the bare minimum, right? You can do a I personally do a fecal cal with every single visit, and I stress on the importance of doing that even by sending them a reminder before they come through my coordinator, or doing it when they come to the clinic and then following up on the results later. So I think the idea is implementing the treat to target strategy in essence, and modifying it a little bit is not so bad.
Thank you.
I don't know what you think. What do you think, Peter?
Dr. Irving?
Yeah, I totally agree. And I think one of the problems when you see things like the stride targets and things is we all know if you take them as an inflexible thing, they are unachievable. And I think that puts us off as clinicians. You think, well, I can't do that. And equally, when you're told you have to reach mucosal healing, we know we don't always reach mucosal healing because it isn't possible in all. We got some great drugs out there, but they're not perfect. And so you're right, you have to adapt them to your own situation and to the individual patient. And you're right, a colonoscopy at 6 months is not that much better than a colonoscopy at 9 months, but a colonoscopy at 6 months or 9 months is a lot better than no colonoscopy at all. And so, I think it's about understanding what these guidelines are for. They're to encourage us to think about what we're doing, to assess what we're doing with our patients, and to do the best we can with the tools that we have available to us.
Question?
I had a question. If I had two patients, one of them Crohn's and the other one is ulcerative colitis, endoscopy for both of them were normal. I got biopsy and both of them, they got deep mucosal healing. Let us say one of them on azathioprine alone, the other in biology, or on both. How I will treat them, how I will manage them regarding treatment?
So I'll check I've understood correctly. You've got a patient with Crohn's and a patient with UC, and they're both doing very well on endoscopy.
Yes.
And sorry, they're both on azathioprine?
No, these are scenarios, whether the patient on AZA alone, or whether on AZA and biology, or in biology alone. How I will follow them up by regarding the treatment? Shall I stop? Shall I continue?
Yeah, okay. So really good questions that, there are no definitive answers to these. What's really good is that your patients are well, okay, whatever treatment they're taking. And I'll take you back to Miguel's comment from earlier in the day about the patients who get to that point of deep remission, whatever we mean by that, they're the ones who do well. So you've achieved that now. So your decision about whether to carry on or stop a drug really is a balance of risk and benefit with the individual patient. We know that in both ulcerative colitis and Crohn's disease, when you discontinue treatments, a significant number of your patients will relapse over time. And the longer you leave it, the more that relapse, whatever the treatment is. The problem with azathioprine is, even though, particularly in ulcerative colitis, it's quite a good drug at keeping people in remission, as you go through life, it becomes a less attractive drug because of the side effects associated with it. Some biologics, in contrast, have very nice safety profiles associated with them, and there are some biologic classes where I would be quite happy for people to stay on the drug for the rest of their life, and really I wouldn't be very worried about that at all. So it's a balance of the risk of continuation and the risk of stopping. Where they're on two drugs together, on a biologic and azathioprine, for most biologics, the only risk of stopping the azathioprine is that the azathioprine is doing something to keep them well. With anti-TNF, you face the additional problem that you may allow immunogenicity to occur. The reality is, and we do have a trial here, at least in Crohn's disease, the reality is that majority of patients on infliximab, and that's our most immunogenic drug, who stop azathioprine actually continue to do well as long as they stay on the infliximab, and if they stop doing well, you can reintroduce the azathioprine. So it's a very long answer, but it wasn't a simple question. And I think the key thing is here, you always need to think about risk of benefit of continuation of treatment and loss of response.
There was a literature to keep them for 2 years after, and then stop it.
So I missed that, I'm sorry.
There is a study to keep them on the same treatment 2 years more, and then you can stop it.
There are many different studies that look at different aspects, and there is always a proportion of patients where you stop the drug, where in fact they do stay in remission. But the majority of studies, even with patients who've been on drugs for a long time, if you stop them, most patients relapse with time. And maybe that's okay, because you can always restart treatment, but for many patients, they'd rather stay in remission.
Okay, thank you very much. Just because of the sake of times, I would like to thank Dr. Mosley and Dr. Peter Erfings, and we'll continue with the next session. So thank you. Maybe we'll take a pictures in the middle.
Good afternoon, everybody. It's my honor and pleasure to be here today. I'd like to thank the organizers for inviting me. I'm Mohamed El-Burai. I'm an associate professor of medicine and gastroenterology at Al-Azhar University in Cairo. It's my honor and pleasure to co-chair this session with my colleague, Dr. Man Al-Khattabi.
Good afternoon, everyone. My name is Ma'an Al-Khattabi. I'm assistant professor in King Abdulaziz University, Rabigh campus, and consultant gastroenterologist and IBD specialist. I would like to introduce the first speaker in our session today, Dr. Iman Slace. She's a consultant gastroenterologist and inflammatory bowel disease and intestinal rehab specialist working at King Fahd Specialist Hospital in Dammam. She completed clinical fellowship in Cambridge University Hospital in UK. She has interest in research, particularly IBD related. She has several publications in this field. Floor is yours, Dr. Iman.
Assalamu alaikum. Thank you so much for the nice introduction. So my talk today, it is not appearing here, the screen. So my talk today will be about approach to refractory IBD. In this talk, I'll talk about some definitions, and then we'll talk about the mimickers of refractory disease, and then we'll talk about the predictors of disease severity. I guess the data on drug sequencing was amazingly covered in the previous session, so I'll just pass through these slides, and then we'll shed the lights on some of the new modalities in IBD treatment. So starting with case for Crohn's disease, Mr. M is a 27-year-old gentleman with fistulizing Crohn's disease diagnosed in 2015 on a clinical background of bloody diarrhea and occasional abdominal pain. He was treated initially with course of steroid followed by azathioprine. Then 1 year later started on adalimumab, but then he was switched to ustekinumab due to immunogenicity to adalimumab. Seen in our service in 2018, so we decided to do disease reassessment and we did colonoscopy. The colonoscopy showed inflamed terminal ileum with stricture. The colon was fine and the biopsy showed a moderate chronic active inflammation in the TI. And we did also MRE, which showed progression of the disease, which involved more ileal lobes proximally. At this point, we discussed this case with the colorectal surgery, and the plan was to go for laparoscopic ileocecal resection electively, which was done in 2019. And the surgical biopsy showed severe chronic active transmural ileitis. The plan at that time was to optimize the azathioprine dose and to start him on infliximab. In late 2020, the patient presented again with flare, with frequent bowel movement, and the colonoscopy showed multiple ulcers at the new terminal ileum compatible with rotigreet I4, as you can see in these pictures. We did TDM, and it showed high antibodies and undetectable drug level, and he was switched to vedolizumab Q4 in combination with the azathioprine, but he's again symptomatic, and the plan to start him on obadasitinib. So what do you think? Is it refractory disease at this stage? By definition, refractory IBD when the disease is not responding or losing the response to all the classes of the licensed immunosuppressive and biologic therapy. And in refractory Crohn's disease, additionally, the disease must be not amenable to surgery, and in case of perianal Crohn's disease, it is when there's a failure of at least one surgical intervention and one anti-TNF. So what we have as predictors for disease severity in Crohn's disease, we know that when the patients need steroid at the time of the diagnosis, or when we diagnose a patient at an early stage, or when the location is ileocolonic with perianal and upper GI involvement, and from the genetics, when there is no 2 gene mutation, we know that the patient will have more severe and complicated course. What about the need for surgery? We know also that the patient who have jejunal, ileocolonic, and upper GI involvement, and obviously if the behavior is penetrating and structuring, and the smoking, as well as extensive and deep ulceration by endoscopy, and we mean by extensive when there is more than 10% involving at least one segment of the colon, we mean by that the extensive ulceration. All of these can give you a hint that this patient will need surgery at some point. Okay, so before we label patient as having refractory disease, what we have to keep in mind. One, you have to, whenever you have symptomatic patient, you have to confirm the disease activity by objective parameters, whether it is CRP, fecal cal, plus endoscopy, plus or minus imaging. Two, you have to not to give up the medication easily. So whenever you have a chance to optimize the drug and obtain TDM, please do. Three, and it is really important thing to think of any treatable conditions like infection. And I'll mention in the bacteria side, C. diff, viruses like CMV, protozoa like Giardia. Also, it is really important to think about sexually transmitted disease like chlamydia. Also, keep in mind that your IBD patient, it is like the other population and other patients, so it may come with other entity like drug-induced enteropathy, including NSAID and mycophenolate. And also, it is important to keep in mind, especially in patients with history of ileal resection, bile acid malabsorption and SIBO. It is also important to keep in mind medication non-adherence. And in one study, the medication non-adherence in patients with IBD can reach up 20%, and it is higher with the oral and topical formula. So you have to visit the history again and make sure that the patient is taking the medications regularly or not. Lastly, and it is really important thing to keep in mind, when did you start the medication? Is it when the significant bowel damage has been already happened or not? For example, if there is fibrotic structure is already there, you don't expect that the medication will work on that. So you have to send the patient to surgery and then reuse the same agent. Don't give up that agent and call it failure. Okay, what about when we are done with all the mimicals of refractory disease and we already know that the patient have refractory Crohn's disease? What surgical options we have and what medical options we have. From the surgical side, we know that we have a structuroplasty to be used for structuring Crohn's disease, especially in the small bowel or the upper GI involvement, and it is preferable than the going for resection, as the short bowel syndrome is a risk there. And when it is a Crohn's disease in the colon, it is always preferable to go for segmental colectomy rather than total colectomy or proctocolectomy. And also keep in mind that endoscopic dilatation with CRE balloon is always an option there whenever it is amenable to endoscopic intervention. What about the medical options? I'm sure that most of us face this scenario at least once or twice in the clinical practice, where the patient already used all the biologic and he is not a good candidate to be sent for surgery at this point because he is malnourished, needs nutritional support, and he is also have heavy inflammatory burden, and you have to downstage the disease. So what to do? In this study, they tried to reuse the infliximab in patients who already failed infliximab and adalimumab. And guess what? Regardless of the mechanism of failure, whether it is intolerance, PNR, or secondary loss of response, the infliximab was able to recapture the response in about 40 to 60%. So I guess it is good chance and good opportunity to go for in a patient like this. All IBD patients need psychological support, no doubt of that. But when a patient reaches refractory stage, he's really in need of psychological support because, he has a negative impact of the multiple treatment failures. He has the realization that the disease outcome might be not desirable, and he is already exposed to so many medications, including opioids, and he's also stressful by the ongoing symptoms. Moving to a second case, patients with ulcerative colitis. Ms. S is a 21-year-old lady with diagnosis of ulcerative pancolitis. She's obese with BMI of 44, diagnosed at the age of 12, and clinical background of bloody diarrhea. She was treated originally with adalimumab, but it failed, and then we switched her to infliximab, and she did well initially. Upon the transfer to our service, she was already having ongoing symptoms, and we did at that time TDM, which showed subtherapeutic infliximab level. So we increased the infliximab to 10 mg per kg, and she achieved remission initially. Later on, she had again symptoms of flare in terms of bloody diarrheas, like 3 to 4 times per day, and CRP was high. Unfortunately, that happened during the pandemic of COVID-19, so we didn't have a chance to do endoscopy or TDM, and we decided to go for ustekinumab. She did well initially, and then unfortunately, again, she presented with another flare in terms of bloody diarrhea 14 times per day. Stool for C. diff was negative, and the FlexSig showed Mayo-3 disease, and the biopsy was negative for CMV. At that time, we started her on tapering dose of steroid, and we discussed the case in the IBD MDT. The option either to go for tofacitinib or to go for surgery. The patient preferred to go for medical treatment again, and she started on tofacitinib, but that failed, and eventually the patient sent for surgery. So what do you think, refractory disease or not? I guess it is so refractory disease, and the predictors with disease severity in ulcerative colitis include extensive disease at presentation, proximal disease extension after index presentation, younger age, presence of BSC, longer disease duration, and steroid-dependent disease. Just keep in mind that the patient who present in early stage, in early age, and presenting with coexisting BSC, those are the patients that you expect they will have proximal disease extension at some point. I'll just go through these slides because it was covered amazingly in the previous sessions. So whenever we talk about positioning and sequencing, we have to talk about VERSITY trial, which was published in 2019 and showed superiority of vedolizumab over the adalimumab in ulcerative colitis in both clinical and endoscopic parameters. And then in 2022, CView, it was negative studies where it showed no difference between ustekinumab and adalimumab in patients with Crohn's disease. And then very recent, we heard about the sequence trial, which compared between risankizumab and ustekinumab in moderate to severe Crohn's disease, and it showed superiority of risankizumab over the ustekinumab in both clinical and endoscopic parameters. This was also mentioned in the morning session, so I'll not spend time, but again, it showed superiority of the ustekinumab over the vedolizumab in patients with the Crohn's disease when it's used as a second-line therapy. But in UC, there was no difference between the agents you used. Okay, I guess you will hear about this abstract in details in the upcoming UEG after 2 weeks. So this UK data include about 13,000 patients, and it confirmed what we already know, that the vedolizumab is the winner in ulcerative colitis when it is used as a first line. It is again the winner when you use it as a second line after a failure of the anti-TNF. It is really important to mention that anti-TNF showed similar effectiveness when it is used as a first line or after failure of vedolizumab in case of ulcerative colitis. As you can see here, the vedolizumab in purple color showed superiority over the other anti-TNFs. And when it's used as a second line, again, vedolizumab in blue color showed superiority over the infliximab and adalimumab as a second line in UC. What about in a Crohn's disease? The results was not that exciting. It is what already know. Infliximab was superior to adalimumab in case of perianal Crohn's disease, and non-anti-TNF biologic like ustekinumab and vedolizumab were superior to anti-TNF agents in case of delayed loss of response or intolerance. Moving to the last section in my talk, we'll just shed a light on some of the new modalities in IBD. So tacrolimus in UC, tacrolimus is not a new drug, but it is not widely used in case of IBD. So in one study used oral tacrolimus in case of moderate to severe UC in extensive colitis, and the clinical response rate was about 55% in 2 weeks. And we know that the concerns in using tacrolimus is the immunosuppression in immunosuppressive and biologic patients, about the safety, and this patient is already immunocompromised. What about if we add tacrolimus to this stage? So in this case, another study was done, and it showed that it is safely and well tolerated, and the remission rate achieved in 40% of the patients. What about in case of topical tacrolimus and in case of proctitis? In one study, topical tacrolimus and proctitis showed a clinical response rate of 60% at 4 weeks. And I can say that using topical tacrolimus can save the patient a lot of switching between biologics. So it's worth trying a topical tacrolimus before you switch the patient, at least to induce the remission. Moving to the laparoscopic appendectomy. Starting with the PASSION study, it was a prospective case series of 30 patients used in treatment of refractory ulcerative colitis patient, and it showed clinical response rate of 30% at 12 months. It is exciting result, and we are awaiting to hear more about the RCT's result. We have the ACCURE and the ACCURE-UK trials ongoing. Hyperbaric oxygen therapy, the concept of using 100% oxygen is to increase the tissue oxygen saturation, and by that you will modify the pro-inflammatory cytokines and you will increase the tissue growth factors. The initial studies showed benefit in both Crohn's disease and ulcerative colitis, but these studies had huge selection bias. And then another study was published in 2018. It was like a proof of concept study. It showed that using hyperbaric oxygen along with the steroid in patients with acute severe UC result in a clinical remission of 50% at day 5. Fecal transplantation, it was done till now 4 induction studies and 1 maintenance study. The meta-analysis of the induction studies of total of 140 patients showed a statistically significant clinical and endoscopic remission rate. What about the maintenance study? We have only 1 and included 31 patients who already achieved the clinical remission after using the fecal transplantation. The primary endpoint in this study was not achieved, which is the clinical remission, but the secondary outcomes, which is the endoscopic and histological remission, it was achieved. So to wrap up, before you label a patient with refractory IBD, you have to think and rule out all the treatable conditions. Don't give up your drug easily, and when you have a chance to obtain TDM, please do and optimize the drugs. Always in these cases of the refractory diseases, the MDT is the right answer, and please involve the psychiatry to support your patient. We are still waiting to hear more and more about the sequencing and positioning of the drugs. A lot of promising modalities are on the way, so please stay positive. Thank you.
Thank you, Dr. Iman. I'm going to move on to the next speaker, Dr. Ahmed Al-Ghamdi. He's a consultant gastroenterologist and advanced IBD chairperson in King Fahd Medical City, Riyadh, KSA. He graduated from King Saud University in 2008, Saudi board certified in internal medicine in 2012, and Saudi board GI fellowship in 2015, and then advanced IBD fellowship in McMaster, Hamilton, Canada. The floor is yours, Dr. Ahmed.
Assalamu alaikum. Thank you for the nice introductions. So I'm going to talk about the malignancy risk in IBD and how to minimize it. So here is my disclosures. So my objectives for this talk it's a very simple. 2 questions from our patients. The first question is, does my medication cause a cancer? And the second question is, does my disease cause a cancer? If yes, how to prevent it, or at least how to minimize it? So we will start with the web-based survey study, including UC patients, around 460 patients. And in the survey, they asked them about some questions, and they found that 37% of the patients, they are worried about the risk of the colon cancer, and 14% about the side effect of the drug. So the classification of cancer in IBD patients, we classified either cancer related to the immunosuppression therapy or cancer related to the inflammations. Also, we can classify it as intestinal malignancy or extraintestinal malignancy. So IBD disease is not a disease for gut only. So the other system can be involved. So there is association with the CNS tumors, respiratory, cholangio, thyroid, pancreatic, in addition to the hematological, reproductive, and urinary tract cancer, and the non-melanoma and melanoma. So it is a multi-system disease. So the risk of the colorectal cancer rate in IBD patients per 10,000 comparing to the general populations. So the data showed that IBD patient 10 to 50 per 10,000 patient year versus 4 in the general populations. So this is a meta-analysis. It's done by Eden, and it includes more than 116 studies, and showed the risk of the cancer is 2%, colorectal cancer 2% at 10 years, 8% at 20 years, and reach up to the 18% at 30 years. So 10 or 13 years later, there is another meta-analysis that includes 13 studies and showed there is drop around 5% risk of the cancer in the patients more than 20 years. So regarding the time trend of the colorectal cancer, it was increasing with the time, as we see in this population-based cohort study. You see 96,000 patients. So the colorectal cancer started to decrease since 1990 up to the 2010. And this is related to the introductions of the therapy, initially with the immunomodulator, then the biological therapy. So there is an evidence of decrease of the colorectal cancer with the control of the disease by the medications. So what about the colorectal cancer in Crohn's disease patients? So the overall will estimate Crohn's disease either in a small bowel or chronic. It's the relative risk is almost 2.5%. But when we include the study only for the Crohn's colitis, the risk increased to the fourfold. So regarding the risk of the colorectal cancer in Crohn's disease patients in small bowel only, there is 3 studies report the incidence of colorectal cancer in the ileal disease patients is 1.1, so statistically non-significant. What about the small bowel cancer in Crohn's disease? This is a meta-analysis, include more than 8 studies, and showed that the overall estimate relative risk is reached up to the 31.2 with, and the p-value was significant. So risk factors that lead to the development of inflammatory bowel disease-related colorectal cancer, there are many factors, including the disease activity, diet, and male gender by 60% higher risk, primary sclerosing cholangitis, and the risk of the colorectal cancer in UC patients, the onset of the disease in the young age, family history of colorectal cancer, and also the geographical location is important and differ from one region to the other. So as we can see here that different regions, the risk will be different. So what about the chemo prevention? Initially, we know that the 5-aminosalicylic acid can decrease the risk of the cancer, and this is a study include 31, and there is a significant reduction of colorectal cancer and dysplasia for both case control and the population-based in those patients that use the 5-aminosalicylic acid, but there was no effect of 5-aminosalicylic acid in Crohn's disease patients. So thiourine, also, the study include 27 patients, and there is also significant reduction of colorectal cancer and dysplasia for both. So those studies showed that 5-aminosalicylic acid and thiourine can decrease the risk of the colorectal cancer in IBD patients. So the time trend analysis in those 93,000 patients with UC, as we see here in the line chart, that with the use of the biological therapy in UC patients, there is decreased risk of the colectomy. So there is association with the introduction of the biological therapy and decreased risk of the colectomy at 2014. So what about the guideline? The guideline mentioned that no medical therapy has demonstrated sufficient prevention of dysplasia or colorectal cancer to avoid the colonoscopic surveillance in UC. So we do believe that any drug that can decrease inflammation will help to prevent the cancer. So what about the risk factor associated with colorectal cancer in UC? There is modifiable and non-modifiable risk. So modifiable risk to be by controlling the inflammatory activity, backwash, ileitis, pseudopolyp, prior history of dysplasia, presence of the mass and the stricture. And there are a factor that we cannot control it: male gender, disease duration, disease extent, family history of colorectal cancer, primary sclerosing cholangitis, and the young age of diagnosis. So what about the colonoscopy surveillance? So the colonoscopy surveillance, in summary, that if you did scope in a time of the next scopy when the dysplasia detected at present colonoscopy, there is no dysplasia detected at present colonoscopy if the scope is normal or Mayo score 0. So it's depend on the low risk, intermediate risk, and high risk. So the low risk, you will do the next scope after 5 years, and those with more than two consecutive exam without dysplasia, and there is no disease activity. And those patients with high risk, those patients with active disease, PSC, family history of colorectal cancer in the first degree of the family, history of the invisible dysplasia, and higher risk visible dysplasia. And between those, there will be intermediate 2 to 3 years. So what about the risk of the lymphoma with IBD patients? So in summary, we tell the patient that those patients that not exposed to the therapy, the risk is 2 per 10,000. And those patients in monotherapy, either thiopurines or anti-TNF, the risk 3 to 4 per 10,000. And when you combine the therapy, the anti-TNF with immunomodulator, the risk was doubling up to 6 per 10,000. So the risk of the lymphoma with thiopurines, there is 3 types of the lymphoma with thiopurines. 2 of them associated with EBV infection, post-transplant-like, it's EBV positive, and the early post-mononucleosis, and this is in young men less than 35 with EBV negative, and the hepatosplenic T-cell lymphoma, young men less than 35, and patients that receive Imuran more than 2 years with or without anti-TNF. So as we see here, there is 2 EBV-related post-transplant-like lymphoma and the early post-mononucleosis lymphoma. So the risk increase with thiopurine exposure if it is more than 2 years, and increase with thiopurine combo therapy with the anti-TNF. So after you discontinue the thiopurine, the risk back to the baseline with the cessation of the medications. So the point here that I want to mention that in the most of the recommendation and in the Western, they did not recommend to check the EBV. But why? Because the EBV is almost positive in those patients that reach age 18 and 20. But in our region, we see our patients, the pediatric age group in some hospital, they start from the 13. So I think based on our region and the pediatric age, we need to check the EBV status before starting the thiopurine. So to minimize the risk of thiopurine-induced lymphoma in young patients less than 30, so giving the risk of post-mononucleosis lymphoma alternative to the thiopurine therapy should be considered in a young male patient who are EBV seronegative. So avoid more than 2 years of duration of the combo therapy in young male with control IBD to decrease the risk of the cancer. So what about the thiopurine risk of the skin cancer in IBD? This is another meta-analysis and showed that there is increased risk of the non-melanoma skin cancer in thiopurine exposed versus the thiopurine unexposed group. What about the biological risk of the skin cancer in IBD? As we see that biologics increase risk of melanoma, but does not increase the risk of non-melanoma squamous carcinoma. The risk of the cervical neoplasia in a woman with IBD, there is a conflicting data. So this is a meta-analysis in 2015, 5 retrospective study and 3 case control study showed there is an increased risk of the cervical neoplasia, while the other meta-analysis in 2022 showed there is no decreased risk of the cervical neoplasia. So the potential, there is a potential confounding factor in those studies, that is smoking, human papilloma virus status, human papilloma virus genotype, variability of the outcomes such as there is cervical dysplasia, cervical carcinoma, or cervical abnormalities. So the ECO guideline regarding this suggested that women in thioberine therapy participate in screening program available for the general populations. So what about the cancer risk in a patients underlying the PSC? So there is increased risk of hepatocellular carcinoma from up to the 2.8%, and also the gallbladder cancer increasing up to 3.5%. Also, the cholangiocarcinoma in those patients with the PSC 400 to 1,500 risk over the general populations. And the colorectal cancer increase up to the 4 times over patients with the UC. So the surveillance is if patients with PSC and IBD present, we will do the colonoscopy annually, and IBD absent, so those patients with primary sclerosing cholangitis, and you do colonoscopy and it's normal, we need to repeat it after 5 years also. So for the cirrhotic patient, this is the HCC surveillance program, and if not, the cirrhosis is just only for the gallbladder surveillance testing annually. So this is a summary of the therapy. So the red arrow, this is a strong evidence. So the strong evidence of non-melanoma skin cancer and lymphoproliferative disease with thioberines. And in yellow, this is weak or moderate evidence, as you can see here, that increase of melanoma, non-melanoma with methotrexate, cervical cancer, urinary tract cancer, and lymphoproliferative with infliximab and adalimumab. In the green, there is no evidence for the associated risk, and those with the yellow, blue is that mean insufficient evidence. So the conclusion is the patients with IBD are increased risk of the malignancy. Primary chemoprevention is possible, but doesn't change the need for the colonoscopy yet. So control inflammation is the most effective primary prevention. Disease duration, extent of the disease, activity increase the risk. And the risk of thioberine-induced lymphoma can be limited by restricting the use of thioberine in EBV seronegative patients and older men. And the risk-benefit communication with the patient is the key. Thank you.
Thank you very much, Dr. Ahmed, for this excellent presentation. We'll go straight to the next speaker. It's my honor and pleasure to introduce Dr. Shakir Bakari. Dr. Shakir is the current gastroenterology consultant and advanced therapeutic endoscopist at King Saud Medical City and IBD specialist. He is the head of the local committee of gastroenterology fellowship program in Riyadh, and is a member of the scientific committee of the gastroenterology and member of IBD steering committee in the Saudi Gastro Association. He has a long professional experience, started since 2004, and he had advanced inflammatory bowel disease fellowship at University of Alberta and advanced therapeutic endoscopy fellowship from University of Ottawa. The floor is yours, Dr. Shakir, please.
Thank you for a nice presentation, and thanks organizing committee for inviting me for this wonderful conference. So my talk will be updating and visualizing Crohn's disease in 2023. So this is my disclosure. So learning objective for this talk will be describe the burden and unmet need and management challenge associated with visualizing Crohn's disease, evaluate the most recent clinical data associated with the newer emerging therapies with the visualizing Crohn's disease, implement coordinated and patient-centered management strategies based on the most recent evidence and consensus-based guidelines. I will go through the definition of fossilizing disease, prevalence, epidemiology, clinical burden of disease, treatment goals, and ongoing challenge, recognition, treatment, and diagnosis and classification, current and emerging therapies, strategies, available target and biological medication we have, monotherapy versus combo, emerging therapies and clinical trials, and strategies in coordinated and patient-centered care. So we'll start with the definition. Definition of fistulas, usually inflammation at near anus, including tags, fissures, fistulas, and abscess stenosis. Symptom usually pain, itching, bleeding, purulent discharges, and fecal incontinence. Treatment usually anti-TNF plus or minus immunomodulator agent plus or minus ketone insertion. Prevalence based on population-based cohort, the prevalence probably at 10 years of patients with Crohn's disease, at 4 years, 14%, reaching almost 19% at 10 years. Patient with the Crohn's disease and renal disease presented at 12%. Those patients who has colitis, Crohn's colitis and proctitis, they have higher risk to develop renal disease. Most of them, almost 2/3 of them, they require minor surgery, either fistulotomy, ketone insertion, flap insertion, and other minor surgery. And only 6% they require a major surgery like proctology, like colostomy, proctotomy, and diversion ileostomy. The burden, how is the burden of renal disease, renal Crohn's in patients? If you look at it, we have burden of symptoms, including fatigue, restricted motility, discharges, pain, and they will have a negative impact on well-being. You will have patients with the renal disease, absence of work because of this renal discharges. Social, they will be more isolated other than normal population. Emotional consequences, you will have more depression on those patients. And physical restriction because of discharges and impact of this. And you have a burden of treatment as well. We have difficulties, and sometimes we know the most of treatment is a biologic. So accessing to the treatment sometimes will be difficult. Alhamdulillah, in Saudi here, we have no problem as Saudi to have most of medication. Probably in some center you have limitation, but most of medication are free, even biologic. However, you have in non-Saudi and non-insured patients, they will have difficulties to get this biological treatment, and we inform them in charity organization. Understanding and tolerating the treatment is also burden and side effect of medication as well. Treatment goal and challenges, suboptimal disease remission and outcome. So we'll try to define, know the anatomy of the renal anatomy. So we have internal sphincter and external sphincter, and in between you have intersphincter space, and you have supraelevator space and isorectal space as well. So this is the renal anatomy in general. Classification. So if we look for the BAL classification of renal disease, most of patients or most of sphincter fistulas, it will come to the like intersphincteric fistula, about 45%, 30% transsphincteric fistula, suprasphincteric about 20%, and only 5% extrasphincteric extrasphincteric fistulas. And 25% of patients, they have renal disease, only 5% they have isolated renal without any luminal symptoms. Another classification looks simple or complex. Simple is usually single tract, low below the dentate line, single internal or single external fistulas, opening, sorry. Complex is a multiple tract, high above the dentate line, multiple internal and external openings, anovaginal or rectovaginal fistulas, associated with abscesses, structure, and recurrent. And most of the 70% of the Crohn's disease, they have complex fistula. A new classification, it came to 2022 by AJA. This is classify patient into 4 classes based on disease prognosis, disease severity, and what you call it is a proactive approach between the surgical and medical to reach the target. So they classify, class 1 is minimal disease, minimal symptoms, and minimal anorectal disease burden. They require minimal control, minimal intervention of the time. And you have a class 2, which is defined, subgrouped to class 2A and 2C, and 2B and 2C. Class 2A is repair. So you have a symptomatic fistula suitable for combined surgical and medical closure, either ketone and biological therapy. And you have 2B, which is you don't concern about, is not suitable for surgical intervention, but you try to control the symptoms. So related to the fistula, pain or discharges that improve quality of life. And you have class 2C. Class 2C, either you go with class 2C A or B, or 1 and 2. So early rapid progressive disease that dramatically progressive and destruct the perineum and you disturb the quality of life. In this situation, you cannot manage this patient with surgical or medical. You go with the defunctioning, meaning resting them by doing ileostomy. Class 2C2, which is gradually depleting, is not severely progressive, but gradually at the end, probably you end by defunctioning. Class 3, which is you need severe disease with exhausted perineum and with adverse features, and end by proctectomy. And then class 4, which is 4A and 4B, these come after doing proctectomy. This is the new classification. I feel it looks like more details. It's not a simple. We didn't use it actually in clinical practice. So diagnosis, you diagnose fistulas based on examination, symptoms-wise examination, and you need imaging evaluation by MRI and examination under GA. So we'll go to the treatment, medical treatment of fistulizing Crohn's disease. So we'll go through gradually by moving on from antibiotic to biologic. So antibiotic here, Metro and Cipro widely used, but evidence is limited. Small randomized control trial of 25 patients was negative. Efficacy is combination with a biologic, Cipro plus infliximab or infliximab alone. First response as 18-week, it was 73 versus 40, which is not significant p-value. However, if you look for another study, Cipro plus adalimumab or versus adalimumab monotherapy, its response was significant at week 12 by 70% versus almost 47. So the role of antibiotic is as adjunctive treatment to decrease the drainage and improve quality of life. Immunomodulator, evidence is limited, primarily evaluating azathioprine 6 mercaptopurine, and tacrolimus. Meta-analysis subgroup improved the fistula healing with azathioprine or 6 mercaptopurine versus placebo by 50% versus 20%. Tacrolimus, a high rate of fistula improvement with tacrolimus over placebo, but remission almost the same between placebo versus tacrolimus. What about biologic? So the only RCTs we have for it's for infliximab. So infliximab RCTs has shown been effective in closing fistulas. We know it's 5 milligram versus 10 milligram versus placebo, and patient with infliximab achieving almost more than 50% reduction in number of draining fistulae at 2 consecutive study visits. And if you look for perineal disease activity index improvement, there is improvement at week 2 and week 18 significant p-value versus placebo. What about higher infliximab trough level? We heard about today in the morning by Prof. Ruggiero that probably you need a TDM and achieve more drug at fistulizing disease. So it's clearly here shown by the study, which is correlate between the fistula drug level, infliximab drug level and fistula response. So you need probably in fistulizing disease, you need more than drug on board in their body to achieve the clinical response and fistula closure. What about ketone? Ketone plus infliximab. So here there is a clear evidence that combo therapy, ketone plus infliximab, improve the response, decrease the recurrence by significant p-value, and the time between the time to until you have recurrence, it takes more time if you have a combo therapy, meaning that ketone plus infliximab versus infliximab alone. What's the optimal timing after starting ketone? So after putting ketone, so you have a patient that was seen by the GS, colorectal GS, and he put a ketone. So, and he referred back to you. So is it early or late or doesn't matter? So who will choose A, who will choose B, or who will choose C? Choose A, early. So B, okay. C does not matter. So most of the people, they said early. So we'll see the evidence. So this is retrospective analysis reviewing patient. Either you start early, defined early, in this retrospective, define early less than 6 weeks or more than 6 weeks. So early less than 6 weeks is 73%, 73 patients, and late more than 6 weeks is 44. And their primary endpoint was surgical reintervention. So if we look for the data, it was not significant. But if we look for the numbers, there is a trend toward if you do combination, early combination, it may reduce the number of surgical reintervention. So it's clearly here, though it's not significant, but it's a good sign that you start early, you prevent the reintervention or decrease the reintervention. Another study of 76 patients looked for recurrence of perineal fistulas. This is their primary endpoint, and secondary endpoint looking for clinical remission. There is meaning that there is no fistulas or partial response, decrease the number of fistulas more than 50%. And their definition of early, less than a month or more than a month. So early, less than a month by 49 patients, and long and late, more than a month, 27 patients. The p-value is not significant, but there is a trend also. If you start early, you may, the recurrence, the number of no recurrence is more than if you start late. And if you look for the secondary endpoint, which is induction, clinical remission at induction and maintenance, so there is a difference between the start early or start late, though the number is not significant, but the intervention, the complete recurrence and complete response and partial response is toward the early starting infliximab after ketone. So now we'll move on to the new biologic. So do we have now ustekinumab, new biologic ustekinumab? So there has been no RCTs looking for primary endpoint of their studies looking for fistula response or fistula healing regarding ustekinumab. But from that, we have some post-hoc analysis from the trials that use in ustekinumab, Unity 1 and Unity 2 and Certify, and show there is a fistula resolution at week 8, it's about 24%. So there is a improvement, and though the number is low, but we have a signal that ustekinumab, it may be good for fistula resolution. However, the fistula response as week 8, there is no significant p-value. Another retrospective cohort of 27 patients They look for 6-month follow-up of prenatal, they assess the prenatal fistula improvement, and 1 year. So there is in 27 patients, the prenatal fistula improvement at 6 months about 48%, with 55 or 56% at 1 year, as well as there is improvement in symptomatic fistula, symptom of fistula. What about vedolizumab? Vedolizumab as well, has not been RCTs addressing the primary or addressing the fistula response as a primary endpoint, but we have exploratory analysis from Gemini 2, published in Crohn's Colitis 2018, and showed there is probably in 153 patients, the fistula closure is about 28% at week 14 and 30% at week 52. In systemic review and meta-analysis, in 4 studies in 198 patients, the overall, the response, the complete remission of the prenatal fistulizing disease, almost 28%. We heard from Dr. Ahmed about enterprise study, which is RCTs. It's a double-blind phase 4 double-blind randomized trial, evaluating. Actually, if you look for the studies, the primary endpoint was not a fistula closure versus comparing the two regimen. They compare the two regimen, either you give extra dose as week 10 or continue the same regimen as standard, 0 to 6, and then you continue, or 0 to 6 and then 10, and then you continue. So there is a 50% reduction in number of draining fistulas at week 30 by almost 64% versus 42% at almost week 10. So there is no add value, and the fistula response was 42, almost 43%. So here they conclude either you add extra dose as week 10 or the continue the regimen will be the same. What about new molecules or small molecules? Do you have data on supporting small molecules on fistulizing disease? So we don't have enough data. However, we have data on filgotinib, which is JAK1 inhibitor. It's phase 2 double-blind randomized studies, and this study was not completed because of recruitment issues, because of COVID pandemic. However, we see the trend or see the number is going difference between the 200 filgotinib versus placebo at combined fistula response at week 24 and fistula remission at 24. So probably there's filgotinib could be a good option, or in the future. It's not now, so it was terminated, not completed. Do we need to use a combination to optimize the outcome on fistulizing Crohn's disease? So do we need to combine the antibiotic with the fistula, with the anti-TNF to optimize? So we have data from Adafi, published in GUT 2014, in 76 patients. After starting infliximab, start Cipro or versus placebo. Cipro was used for 12 weeks. And if we look for the response, is a good, really, with a big significant p-value at 12 weeks. However, if you look for week 24, either regard of reduction and 50% reduction or complete response, there is no difference at week 24. So you may add antibiotic as short term. So adding antibiotic to anti-TNF is more effective than anti-TNF alone in short-term fistula response, but is not in maintenance, in maintaining remission with the long term. Combined anti-TNF with the immunomodulator. Shall we use it or no? A, yes. B, no. C, I don't know. So who will go with A? Okay. Who will go with B? Most of us going with A. Okay. So the efficacy of immunomodulator fistulas in healing has not been evaluated as a primary endpoint in RCTs. Data regarding utility of fibrin is derived from the subgroup analysis on RCTs. A meta-analysis showed no statistically difference in fistula response between fibrin monotherapy versus placebo. I'm talking about here for combo therapy. So this is this is a bold factors from retrospective evaluation looked for the factor that's associated with more of fistula closure. The combination of immunosuppressive plus infliximab is one of the key factors in for patients with a naive to the immunosuppressive, one of the key factors that has played a role in that associated with the response of fistula or fistula closure. Another one was negative, really. So a variable using azathioprine or mercaptopurine was negative to show any benefit of complete or partial response. So if you look for the guidelines, this is guidelines, Canadian guidelines, the advice to use when starting anti-TNF, they suggest combined azathioprine with a methotrexate or monotherapy, and this is low quality of evidence. If you look for echo guidelines in patients with Crohn's disease and complex perineal fistulas, there is insufficient evidence regarding the effectiveness of adding immunomodulator agent to anti-TNF. And if you look for the ECG, maybe effective and should be considered in treating fistulizing disease. AJA did not mention it. So it's up to you, but you have evidence supporting and evidence not supporting. Combination of dual biologic, do we have good evidence on this? It was really bold analysis from retrospective cohort of 22 patients. At baseline, the 50% of patients they were present with fistulas. Post-treatment combination with dual therapies is 33%. So there is a trend that you maybe use it. I think I'm looking for the combination therapy and biologic. It could be in the future, near future. Is CETON required for long treatment or short? Because I think because of time, so I will go through. CETON is showing that one of the factors, a key factor that play a role in closure of fistulas is CETON duration less than 34 weeks. So you don't keep it for a long time. This is BISA study, randomized patient, either CETON insertion alone for a long time or surgical intervention or anti-TNF, and showing that if patient has long CETON, then you have more re-intervention. So think about using CETON for a short period of time. This is guidelines, or this is statement from the ECHO guidelines and European Society of Coloproctology. They advise to remove the CETON after induction of anti-TNF and show that about resolution proctitis. Surgical management, do you have time? So I will not go through in details about surgical management. So we have a CETON, we have flap, and we have another mini surgical approach to approach it in fistulas. This is allogeneic stem cell transplant. It's been good, probably a potential therapist to use it in complex fistulizing disease. This is a real life data showing that clinical healing about 52%, with MRI also radiological healing about 52%. I will end by this, putting a diagram looking for management of fistulizing disease. Clinically suspected abscess, you should drain the abscess, drain the infection, treat the infection, and then you evaluate your patient. If you have a complex fistulas, then antibiotic CETON plus anti-TNF, continue TNF, consider TDM as we mentioned it earlier in the morning, that it's and do proactive in this group of patients, and then optimize anti-TNF, and you evaluate your patient, keep harmony, and management plan should be clear, and then you consider another alternative. Thank you.
Thank you very much, Dr. Shaker, for this very extensive, informative lecture. It's my honor and pleasure to introduce the next speakers. My friend and brother, Dr. Muhammad Malik. Muhammad is a consultant of gastroenterology and IBD specialist at Hayal Habib Gastroenterology Center in Kuwait. Muhammad Malik is a member of the Royal College of Physicians and the United Kingdom, and he completed his fellowship of gastroenterology and advanced IBD at Royal London Hospital, Queen Mary University, UK, and he is a board member of the Kuwait Gastro Association. The floor is yours.
Thank you, Dr. Mohammed, and I want to thank the organizing committee really for asking me to present today. It's such an honor. This is my first time in Riyadh, and it's lovely. So it's the last lecture. I know Friday, you're all tired. Just bear with me because Dr. Nahle told me you have 15 minutes, so hopefully I'll finish in 15 minutes. So this is my disclosure. Let's start with a case. We have a 17-year-old Kuwaiti boy who presented to your clinic complaining of abdominal pain, diarrhea, weight loss, and some joint pain. He has a very strong family history of IBD. His brother has Crohn's disease, his cousin has Crohn's disease, which is quite common in Kuwait. So you investigate that patient. You found out that he has anemia, his CRP was high, albumin was a bit low, and a fecal cal of more than 1,000. So we proceed for an OGD that showed gastritis and H. pylori, and a colonoscopy that showed moderate ileitis with SCS-CD of 9. So usually, how do you manage that patient? I know I have lots of options here, but in that situation, usually we start with anti-TNF biological, or maybe azathioprine in certain countries. Let's see the evidence behind that. So this is the efficacy of therapy in inducing remission in patients with Crohn's disease. This is a huge meta-analysis, network meta-analysis, 15 clinical trials, more than 2,900 patients, bio-naive, were studied, and you can see that anti-TNF, anti-TNF in common, infliximab plus thiopurine or adalimumab, do better compared to other biologics. So that's what we did. We started him on adalimumab, the usual regimen, and he was on monotherapy. And we heard a lot about the evidence today. Will you do EBV in such patient? Yes, that's common. All patients, all male patients in my clinic will have EBV IgG serology, and that patient was EBV negative. So in these situations, you have to ask yourself, do I want to give patients azathioprine or not? And in that case, you can start adalimumab monotherapy, which we did. He was regularly follow up in clinic, but he only showed partial improvement. There's still some abdominal pain, his biomarkers were high, and an MRI showed moderate mural thickening of a long segment of TI with multiple skip lesions involving the ileal loop. So despite he's being treated with biologics, he's still having symptoms and still has active disease. So what we did, we optimized his therapy. We increased the dose to 40 milligram every week, and I sent for therapeutic drug monitoring, which came back at a level of 3.8. That was on the fortnightly. So every other week, the dose was suboptimal, so we increased the dose. He underwent a colonoscopy at week 30, which showed an ulcerated ICV with narrow terminal ileum, but it was possible to push through that terminal ileum. And it showed severe ileitis with ulceration and an increase in SES-CD of 11. Remember, we started with 9, now it's getting worse. So despite being on 40 milligram every week, his levels were high, he is clinically in relapse, he lost weight, and his biomarkers showing a flare. So in these situations, you have to discuss the issue with the patient. But first, let's see the effect of adalimumab in patients with symptomatic small bowel stricture. This is a multi-center prospective observational cohort, the Creole study, 97 patients enrolled. And the primary endpoint was success. Success was defined as having continuation of adalimumab, no steroids, no dilatation, no surgery, and no dropout because of side effects. And you can see that 64% of patients reached success, i.e. they continued adalimumab and the symptoms improved with no obstruction. And if you can see, I just highlighted why I want you to notice, because the maximal small bowel diameter proximal to stricture, what we call pre-stenotic dilatation, that was a prognostic factor indicating patients will improve symptom-wise if the patient's small bowel diameter did not go beyond 29 millimeter. So we know that adalimumab does work in patients with symptomatic stricturing disease. This is another trial done in Australia. It's an open-label, single-center. Roughly 120 patients were screened. Roughly 70 patients were divided to 2 groups, 1 to 2. So the first group on your left, on your left, they were assigned to regular regimen of 160, 80, and then 40 every other week, and they were followed up. The other group were given an intense regimen in which the patient will receive 160 milligram every week for 4 weeks, and then 40 milligram every 2 weeks, and then you add also azathioprine. So we're really trying to optimize and push boundaries in managing such patients. And you can see, unfortunately, the highlighter doesn't work. So you can see the green bars. The trend is it's always better than the blue bars. So patients did better symptom-wise. The treatment failure was less in patients on the intensive group. And the cross-sectional imaging, the last thing on the right, showing improved stenosis markers in patients with the intense group. So giving more medication sometimes might be helpful, but we heard today also from Miguel and the team that sometimes giving more medication does not affect the patient. So there are a lot of things in IBD we have to find out maybe with time. But let's go back to our case. That patient, now we agreed he failed adalimumab. And the failure was maybe primary, maybe secondary. He did not improve totally, but his levels are high. So in such situation, ideally, we step out of anti-TNF and go to another molecule, which we did. But at the same time, maybe yesterday we were discussing, I usually refer most patients with Crohn's to surgery. I have a very nice colorectal surgeon. He's a dear friend. I'll call him. The good thing is his clinic is the next day. So my clinic is on Tuesday. His clinic is on Wednesday. So I'll call him and say, I have a patient for you tomorrow. And he will see them. Every patient with fistula, every patient with stenosis, I'll refer to him just to have some rapport. So he's aware about the case. And sometimes the patient will go to him before coming to me. So we switched that patient to ustekinumab, and on further follow-up, he was still complaining of abdominal pain with occasional diarrhea, but he gained weight, and he's feeling generally better. His biomarker did not normalize, but it was still better. So I said, hopefully you will do better. He was always coming with his father. Then week 36, regular follow-up. His father actually WhatsApped me saying, my son is not doing well. So I told him, bring him to clinic. I examined him. He said, I don't like eating. I'm starting to reduce my food because I'm having bloating, some nausea after I eat. And his biomarkers showed still active disease. We arranged an MRI, and the MRI showed long segment of ileitis with 2 significant stenosis and pseudocirculation. These are poor prognostic factors. If you have 2 stenosis, if you have pseudocirculation, these are poor prognostic factors. Scoped, ulcerated ICV, but this time I was not able to get to the ileum because of a stricture. So what do we know about ustekinumab in patients with small intestinal lesion or stenotic lesion? This is a Japanese study done in a single center, 50 patients. They were examined before and after ustekinumab. And you can see on the right graph that those who responded to ustekinumab did better in terms of SES-CD, so they have less symptoms, less obstruction, but you have to respond to ustekinumab. And our patient responded, but he was not in remission despite that. So what do we know about stricture? We know that the luminal diameter of a normal small bowel, and we know that inflammation increases the thickness of the wall. So when you increase the thickness, we know that it decreases the luminal diameter. But also we know that some patients will have fibrosis and will have inflammation on top of that fibrosis. So when you treat the inflammation, they might have less symptoms because ideally you will increase the luminal diameter. And unfortunately, some patients will develop permanent fibrotic stricture. And we heard today from all of the colleagues, the risk of developing stricture is around 50%. And unfortunately, despite having biologics, new molecules, small molecules, all the advances in IBD, the risk of undergoing surgery is still high at 75% during the lifetime of patients. So what is a stricture? The CONSTRICT group defines stricture as the inability to pass an adult colonoscope through the narrowed area without prior endoscopic dilatation with a reasonable amount of pressure applied. So you don't need to do heroic measure pushing through that stricture. If you try, then that is a stricture. Do an MRI. And you can see in the MRI, you have a stricture, then you can measure the length and so on. And I'll tell you why we need that. But if you see IBD patient, some of them, they develop stricture, some will develop a fistula. We don't know why some patients will change phenotype, change disease behavior. This is a Danish population-based cohort, 213 patients with Crohn's were followed up for 7 years, and 15% of patients will change disease behavior with time, from B1 to B2, and so on. And it was noted that, you can see the graphs down there, and it was noted that having a B2 phenotype, which is fibrostenotic, or having change in disease behavior or location were poor prognostic factors. So those patients are more likely to undergo surgical resection. So phenotype, location, and behavior. Now, I'm not a scientist, and I like that, but to some extent. When you see that, we all get worried, what is that? So this was published last year, actually. Strada and his colleagues did a wonderful thing. So I'll try to explain it without a pointer. So what he did, he took pluripotent stem cells from patients with stricturing phenotype, and he added human intestinal organoids, which is a way of growing tissues in labs. And they found out that if you need to have not 2 mutations. So the gene should be mutated. So the fibroblast ultimately will differentiate to myofibroblast at the cellular level. And this is what causing fibrosis. But you need other factors with it, not only not 2 mutation. You need high tryptase that is secreted from mast cell. You need low vitamin D receptors at the epithelium, and you need something called anterior receptor gradient, which is a protein also secreted from the epithelium. So you can tell that it's multifactorial things, but you need that NOD2 mutation. And once your fibroblast is changed or differentiated to myofibroblast, you will have the fibrosis. So it's a complex thing, but this is the first time we have some evidence that NOD2 mutation is the reason to have fibrosis. What are the predictors for having stricturing disease? This is the treat registry, and you can see the highlighted in red, having steroid as a new therapy, ileal disease, moderate to severe disease, and longer disease duration were predictors of having stricturing disease, while having colonic disease as a kind of a protective, protects patients against developing strictures. So back to our case. This is actually our surgeon. I found his picture. So what will we do in such case? A patient with impossible stricture, having still active disease, will you continue ustekinumab? We know that he's now coming with symptoms. So anyone? I know it's wrong to ask an audience at the end of the day. So how to manage such stricture? So I told you that inflammation can cause stenosis. So if you see inflammation in imaging, i.e. increased bowel thickness, edema, enhancement, Coombs sign, these are signs of inflammation. Or if your patient has increased biomarkers like high CRP, high fecal cal, try to optimize your therapy if you can. These are all suggestive of inflammatory part causing stenosis. But you can also do other things. We gastroenterologists sometimes enjoy doing other things, not only medication. So we have endoscopic balloon dilatation. And if you have it in your center, if you have someone doing it in your center, try doing it for patients with obstructive symptoms. There are two ways. I do the first one. There are two ways, retrograde technique and anterograde technique. So basically the antegrade technique is you open your balloon and you push it through the stricture, and the retrograde, you pass the stricture, you inflate your balloon, and then you withdraw your scope to the stricture. But there are things you have to know before doing that. The indication, the stricture has to be short, less than 5 centimeters. It can be either naive or anastomotic, that's fine. Usually we do it for anastomotic, and it shouldn't be angulated, and of course, you should be able to access it by endoscopy. What are the contraindications? Always, just key points, always take biopsies from the stricture. Because if you have dysplasia or malignancy, that will change the outcome. And the potential complications are there, and I'll show you in the next slide. The risk there is bleeding, perforation, and infection. So this is a pooled analysis. 1,400 patients were analyzed, more than 3,000 procedures were done. Very good results, 98% of strictures, successful procedure, and 89, success procedure, and with clinical efficacy of 80%. So patients will improve after having the balloon dilatation. The complication occurred in 2.8% per procedure, but keeping in mind that you sometimes do more, for 2 or 3 times for one patient, and the cumulative risk per patient was 6%. What's interesting is that they all agreed on 5. So 5 centimeters or less is a good thing, so you can go ahead and dilate that. But if you have more than 5 centimeters, and with every 1 centimeter increase in length, the risk of surgery increased by 8%. And of course, duodenal strictures are quite bad. They're more likely to undergo surgery and resection compared to ileal or jejunal strictures. So what about echo? So echo will tell you if you have acute intestinal obstruction, treat the patient and then refer to surgery. And the surgery is the preferred option in patients with localized or limited ileocecal with a disease with obstructive symptoms and no significant active inflammation. So ideally, you want to treat those patients with chronic pre-stenotic dilatation, fecalization of the small bowel, upstream fistula, and abscesses. These are all complications of stenosis. If you have any of those, ideally, you will send your patient to your colleague, the surgeon. So what we did, I referred him to surgery, and he underwent 60 centimeter resection. He is doing remarkably well now on stickionamab every 4 weeks. He gained weight, he's in uni, he's enjoying his life, he's eating everything, and his father is extremely happy. So let's go through an algorithm, because Prof. Nahla asked me for an algorithm. So this is by Kathy Liu from Calgary, and it's a very nice algorithm, actually. So if you have Crohn's disease with obstructive symptoms, first you need to assess, do you have obstruction, acute obstruction or not? If you don't have that, then you evaluate for any inflammation. If you have inflammation, treat that, and I'll tell you now through the algorithm. And always discuss your patients in an MDT. If you have MDT, that's a plus thing. Discuss it with your colleague, discuss it with other IBD specialists, discuss with the radiology and your surgeon. So if you have inflammation, then we'll go on the left. So you try anti-inflammatory. If your patient responded well, then you continue. If the patient did not respond well and you optimize, so maybe this is a fibrostenotic or fibrotic stricture. And in these cases, we'll divide patient to 3 different ways. If the stricture is less than 5 centimeter, non-angulated, accessible, and we already took biopsies, made sure that there's no malignancy, no dysplasia, no fistula, then we can go ahead and dilate that patient if he is symptomatic. If the patient stricture is less than 5 centimeter, but he has fistula, abscess, malignancy, dysplasia, or phlegmon, these are poor prognostic indicators, and it's best really to go for surgical resection. And if you have the luxury of structuroplasty, especially in patients with repeated surgical resection, you can go ahead and do that if the stricture is less than 5 centimeter. And that concludes my talk. Thank you.
Thank you very much, Dr. Malik. And I'd like to thank all the speakers who will open the discussion with my colleague, Dr. Man. Yeah, please join us, speakers.
Can I start?
Dr. Ahmed Al-Ghamdi.
Dr. Ahmed.
Yes, please, Dr.
Yes.
Prof.
Thank you for excellent talks by all the speakers. My question to Iman, you did a great job on refractory IBD patient. One of the algorithm you proposed that to optimize the first line or optimize the first biological. But my question about how long do you wait till you move to the second line? We know we have different biologic now, small molecule. Any timeline and when exactly we move after and we said this is optimized? Now it is the next step.
Thank you, Dr. Nahla. Very good question. So I usually stratify the patient. If he's low risk or at least not that high risk, I'll wait for 6 months. Otherwise, I'll go at 3 months and change my plan.
Okay. Any more questions for Dr. Iman? Please, mic here, please.
To Dr. Shakir, the perianal disease with a complex fistula, are there any predictors that would tell you that this probably needs an additional, not CTOD or anything, but a diversion or stoma? Any predictors that these patients probably will need a combined sort of maybe surgical and then medical?
Thanks, Prof. Gary, for this good question, really. We have some predictor. I am probably at the end of my study, I was planning to present a case that he has some indicator that he may need a further. It's not only ketone, it's not only anti-TNF, it's not only antibiotic. Probably those patients who has a proctitis, they have a risk factor to develop diversion elastomia. Those patients who's a smoker, they have high risk to develop they have poor prognostic factors and they may need a surgery or diversion at the end. Those patients who has deep ulceration, so probably smoker, proctitis is mainly present, and deep ulceration is those patients, they have high risk. You treat them and probably you have a predictor that this patient, he will not respond well to your anti-TNF or biologic in general. We know that a biologic is a maximum response is a 40% or 30% or 40% in good situation. And those patients, you may need to go with a diversion. My patient, he ended by diversion. He was giving infliximab. He had prominent responder to infliximab. He has a severe proctitis that he has, despite that, with anti-TNF, he partially responded to the proctitis issue. I started him in Stelara. He didn't respond well. We end by divergent ileostomy. So those probably a predictor, proctitis, smoker, and deep ulceration.
Any other?
The other question regarding refractory IBD, the use of JAK inhibitors in the setting of acute severe ulcerative colitis. If we have a biologics that is very quick to act and usually we see response very quickly, where do you see it in the armamentarium of a patient with acute severe ulcerative colitis?
Thank you, Prof. Very good question. So we have at least case series about tofacitinib in the use of acute severe UC, and it's really showed promising results. But still, till now, it is only a case series. So I guess if the patient already in biologics and we have any other option, I guess tofacitinib is the right answer to go for.
Any other question? I have a question, Ahmed, for you. It's maybe more of practical issues in the private sector. When we have a patient with ulcerative colitis and we need to do screening for surveillance, what do you do with the extensive biopsy protocol? Because I found it challenging when we take biopsies, when we take 8 jars, and then in the private sector, they do charge the patient on each jar. So do you have any idea what other alternative we can do?
So it's depend on the risk of the patient, how you will do the surveillance. So those patients with high risk, like primary sclerosing cholangitis or previous dysplasia, those patients, they will be high risk. So now the type of the surveillance may be different. So do we need to take biopsy every 10 centimeter, or do we need to take targeted biopsy, or we will use chromoendoscopy? So this is different, but in the study showed that in the non-randomized control trial, the chromoendoscopy is better, but in randomized control trial, so there is no difference. So it's depend on. But what we are doing now, it's those patients that PSC or patient that disease more than 10 years, actually we do targeted biopsy because all the scope now is not light scope, it's high definition scope. So we're doing the scope, but I didn't have any problem with the, you mean with the biopsy?
I mean with the insurance coverage. So when I have someone in the private sector and they're covered by insurance, if I do the colonoscopy, let's say it costs around 4,000, and then if I do 8 jars of biopsies, like every 10 centimeter or segmental, it's around like 500 per jar. So it will increase the cost up to 8 to 10,000 just for the extensive biopsy protocol for the screening. If I have a patient after 10 years, I'm doing colonoscopy every 3 years. So that's the issue.
Yeah, actually I'm not the right one to answer this because I'm not doing private at all.
Okay.
But for me, I will do the best for the patients and the most safest. So in the government, I take biopsy.
Perfect.
Yes.
Any other
Yes,
questions?
please. It's Mike.
It's Yasser Al-Ghazar from King's College London in Dubai. Just a quick question to Dr. Mohammed Malik. Did you need to stop the ustekinumab before the patient went for surgery? And how long did you stop it? And how early did you restart it again after the surgery to prevent recurrence? And another question to the panel, if a patient going for ileal resection for Crohn's disease, do you start the patient routinely on biologics like vedolizumab? There is an evidence that this will reduce the recurrence, and how early would you start that as well?
Thank you.
Sorry, Doctor. The first part I did not get. The second part, how early you will resume ustekinumab post-surgery?
Yes, the first question, did you need to stop ustekinumab before surgery? And for how long?
Okay, interesting. Very good question. So ideally in anti-TNF, yeah, you need to stop according to ECHO. Ustekinumab does not increase the risk of infections. So perioperative, you can continue. That patient stopped because the surgeon want you to stop. Roughly 2 to 4 weeks. So, and afterwards, I usually give them 2 weeks and then we resume ustekinumab if there is no complication. But in anti-TNF, ideally you have to stop at least 4 weeks.
And did you use ustekinumab again or vedolizumab, which has superiority in prevention of recurrent growth?
So you mean up post-surgery? Post-surgery, we continued on ustekinumab because he was doing partially well. So his complaint was mostly obstructive, and after surgery, he did well. Now, in terms of vedolizumab, after the surgery, we can, if he failed ustekinumab, you can shift him to vedolizumab. But to be honest, because I always look at it that way, I'm very close to my patients, and that patient is in university. So when we give vedolizumab, they have to skip a day of university. And ustekinumab, he can take it at home. Humira, that's why we started Humira. You can take it at home. So always look at that part of, because if your patient is not willing to come to hospital, at some point, they will be non-adherent. They will not come. And you want the medication that will work in your patient rather than the medication that will work in theory, but the patient is not taking it.
Thank you, Dr. Malik. Any more questions from the floor? Okay, I'll have just few short questions for Dr. Iman. I know that you see maybe a lot of patients with refractory disease and they may need multiple surgeries and they may develop short gut syndrome and intestinal failure sometime. How to deal with those patients in Saudi Arabia, because intestinal transplant is in need of well-prepared centers and it's not available everywhere. How do you manage those patients here, and with counseling, nutritional support?
Yeah, thank you so much for this question. So unfortunately, we don't have even home PN and home visit team, unfortunately, till now. But we have started now with the Ministry of Health home visit support and home medicine team. So we are trying to push for home PN as well. So I had 2 patients who had reached the stage of short bowel syndrome. Both of them died, unfortunately. So we are in shortage in general for the nutrition support in gastroenterology, and that area is still deficient for intestinal rehabilitation and intestinal transplant.
Sorry, Doctor, do you have Rivastin? And Rivastin, teglutide for short bowel?
No, but the company trying to introduce it, yeah.
And do you have intestinal transplant centers here in Saudi Arabia?
We have in King Faisal Specialist Hospital unit for intestinal transplant as well as intestinal rehabilitation, and the team are doing a great job there.
Perfect. Thank you very much. And my next question to Dr. Ahmed Al-Ghamdi. Dr. Ahmed, you give us a very informative presentation about the malignancies in those patients with IBD. And you usually, I'm sure you usually counsel your patients about the adverse events of these possible adverse events and malignancies. How do you deal with the patients who came to you with a malignancy after taking a biologic? How do you counsel them again? How do you
before or after malignancy?
After medicine. Yeah,
Okay.
It's a very, very difficult situation. We rarely face, but it's a very difficult situation. You know.
Okay, so this is very great questions. So those patients that they have active malignancy, usually they don't need treatment, because during the chemotherapy and if they give a steroid, usually their disease, they will not be active. But if patients is active disease and need therapy, we will try to go with the most safest drug. And the most safest is the vedolizumab and ustekinumab. But there is recent data from the Sapphire registry and showed that most of the biological therapy does not increase the risk of new or the recurrent malignancy. So there is assuring data about that using the medication again. But personally, I will go with the most safest one, Fido or Stikinimab.
Thank you very much. Next question to Dr. Shakir, because we didn't catch up the use of stem cell transplant. I just need you to elaborate more about this, because we have some few cases in Egypt that we use the stem cell transplant.
In fistulizing disease?
Yes, for fistulizing disease, and it was successful. So what's your experience here?
I didn't use it, but real data is promising. The last slide was real data, about 26 patients. And the response rate on complete closure of fistula is about more than 50%. So it's a good promising of using fistula in fistulizing disease. One of my patients, I refer him to Germany for stem cell transplant. We didn't have it here. I tried to contact King Faisal Specialist Hospital. And probably will run in the near future the program for that. But I don't have experience personally to use it.
But it warrants to try it.
Yes.
Yeah,
if it's really, what's your experience here?
Yeah, we have just 6 cases or 7 cases in Cairo, and 50% of them responded well.
Well,
yeah.
after you failed biologic, yeah, or the first time?
We tried everything, and this was the last resort for.
Excellent.
Yeah,
Super.
Yeah. Thank you very much. So my last question to my dear brother, Dr. Muhammad Malik. You presented a very interesting case with segmental narrowing and involving multiple areas. And these patients eventually went for surgery. And this is a high-risk patient. And we usually tell all patients that the disease will recur again if you stop the medication. So if the patient is coming to you after like 2 years and he's responding very well on the Stikinimab and he wants to stop the medication, what's your recommendation?
So that patient, for example, will never stop the medication because his father is chasing him always. But in such situations, so if that patient is high risk, he's male, young, very early disease, very aggressive phenotype from the beginning. So such patient, you want to keep them on, especially if they're going to university, or, new employment and so on. You want their life to be stable. You don't want admission, you don't want abscess, you don't want that. So he's very close because his father will WhatsApp me every week, maybe, saying that my kid is fine, everything is fine, and they will come to clinic. They'll have routine bloods and regular imaging, colonoscopies, and so on. So he's a very nice patient, very adherent. I don't think he will stop medication, but for theoretical reasons. So if he stopped medication, there's a very high chance that he will develop complications to start with, let alone that he has anastomosis now, and the anastomosis is fine, he's Rutgers 1, but if he stopped medication, he'll develop most likely a stricture there, if not, upstream fistula later on. So I'll make sure that he will not stop.
To stop the medication.
Yeah, his father is very nice. His father is very nice because he will push him. So he's taken care of. Last time I saw him maybe a week ago, and his father, he was asking, can I go abroad? Because he's in university now in Kuwait, so he wanted to go abroad afterward. I told him, you can go abroad, just make sure you take your medication with you. So I don't think he'll stop.
Yeah, you will be each effort to keep him on the medication,
yes,
because he's a very risky patient. Thank you very much for this very excellent lecture. I'd like to thank all the speakers, and I'd like to thank my co-chair, Dr. Maan.
Thank you.
And thank you all for your attendance. Thank you very much.
الله يعطيكم العافية جميعا.
الله يعطيكم العافية.
Thank you.